juvenile idiopathic arthritis acute reactive arthritis angioedema F equals gonorrhea, disseminated gonococcal infection. AAA is home library list settings. XX congenital immunodeficiency disorders. Congenital immunodeficiency disorders are characterized by a deficiency, absence, or defect in one or more of the main components of the immune system. These disorders are genetically determined and typically manifest during infancy and childhood as frequent, chronic, or opportunistic infections. Classification is based on the component of the immune system that is deficient, absent, or defective. The diagnosis is confirmed with tests such as differential WBC count, absolute lymphocyte count, quantitative immunoglobulin, LG, measurements, and antibody titers. Treatment usually consists of prophylactic antibiotics to manage and prevent infections. The prognosis in congenital immunodeficiency disorders is variable and depends on the specific disorder. 2*A. Overview. Congenital B-cell immunodeficiencies. Immunodeficiency. X-linked, Bruton, agammaglobulinemia. Selective IgA deficiency. Common variable immunodeficiency. Overview of B-cell I. Etiology. X-linked recessive inheritance BTK gene defect defective Bruton tyrosine kinase expressed in B cells complete deficiency of mature B cells. Unknown most primary I. Unknown phenotypically normal B cells are unable to differentiate into plasma cells low immunoglobulins of all classes. Congenital T-cell immunodeficiencies. Immunodeficiency. DiGeorge syndrome. Autosomal dominant hyper IgE syndrome, Job syndrome. IL-12 receptor deficiency. Chronic mucocutaneous candidiasis. IPEX syndrome. Overview of 1 T-cell. Clinical features diagnostic findings. Onset, between 3 and 6 months of age when maternal IgG levels in fetal serum start to decrease recurrent, severe pyogenic infections, especially by encapsulated bacteria and enteroviruses. Absent or low B cells normal T cell count low immunoglobulins of all classes hypoplasia of lymphoid tissue, example tonsils, lymph nodes. Often asymptomatic may manifest with respiratory infections, and/or chronic diarrhea, example giardiasis, increased risk of autoimmune diseases like gluten-sensitive enteropathy copyright inflammatory bowel disease anaphylactic reaction to products containing IgA atopy. Clinical symptoms usually develop between 20 to 40 years of age but may also manifest during childhood. Recurrent sinopulmonary infections. Low serum IgA normal IgG and IgM. Low IgG, IgA, IgM low plasma cells normal B cell and T cell counts increased risk of lymphoma, autoimmune disorders, and bronchiectasis. Etiology. Microdeletion at 22q11.2 autosomal dominant inheritance. Defective development of 3 and 4 pharyngeal pouches hypoplastic or absent thymus and parathyroids. STAT3 gene mutation Th17 cells defective neutrophil chemotaxis. Autosomal recessive inheritance. Air protein deficiency, impaired T cell function impaired or absent immune response to candida. FOXP3 gene mutation impaired regulatory T cells autoimmunity sent X-linked recessive inheritance. Collapse. Decreased IL-12 impaired Th1 response no release of IFNY. Several congenital defects, example STAT1 gain of function mutation. AEA. Clinical features. Variable phenotype remember the acronym Catch-22 copyright cardiac anomalies anomalous face copyright thymus aplasia/hypoplasia copyright cleft palate copyright hypocalcemia affected chromosome 22. Remember the acronym FADED, copyright fractures and facies, coarse facial features, abscesses, mainly staphylococcal, teeth, retained primary teeth, hyper-IgE and eosinophilia dermatologic features, severe eczema. Degree. Onset varies but usually 1 to 3 years of age. Disseminated disease, especially tuberculosis fungal infections. Non-invasive candida infections of the skin, nails, and mucous membranes associated with autoimmune disorders. Onset, early infancy. Lymphadenopathy, chronic lymphoid tissue hypertrophy. Autoimmune skin and endocrine disorders, example type 1 DM especially in boys, enteropathy A. Find text. Poor response to immunizations. Diagnostic findings. Detection of 22q11.2 deletion via FISH. Low PTH and CA. Low T cells. CXR, absence of thymic shadow. Skin testing, delayed hypersensitivity. Increased IgE scent. Low IFNY, commonly increased eosinophils. Low IFNY. Usually clinical cutaneous reaction to candida antigens is absent. In vitro T cell proliferation is absent when exposed to candida antigens. Genetic testing, FOXP3 gene mutations. Low or absent CD4 CD25 regulatory T cells. Otherwise normal T cell populations. AL. Outline. IPEX syndrome. FOXP3 gene mutation impaired regulatory T cells. Autoimmunity. Scent X-linked recessive inheritance. Congenital combined immunodeficiencies. Immunodeficiency. Severe combined immunodeficiency. Wiskott-Aldrich syndrome, was. Overview of. Onset, early infancy. Lymphadenopathy, chronic lymphoid tissue hypertrophy. Autoimmune skin and endocrine disorders, example type 1 DM especially in boys, enteropathy. Failure to thrive. Nail dystrophy. Etiology. Scent various mutations resulting in impaired function of B cells and T cells. Copyright X-linked recessive inheritance, defective IL-2R gamma chain, most common variant, copyright autosomal recessive inheritance, adenosine deaminase deficiency. Copyright human RAG mutations, defective VDJ recombination. X-linked recessive inheritance was gene mutation was protein synthesis impaired remodeling of T cells actin cytoskeleton defective antigen presentation. X-linked recessive inheritance hyper IgMSY. Ataxia telangiectasia. Asterisk class switching defect of Th cells, most commonly CD40 ligand deficiency. Autosomal recessive inheritance plus ATM gene defect failure to recognize and repair dsDNA breaks no cell cycle arrest continuous replication of damaged DNA. Congenital neutrophil and phagocyte disorders. Immunodeficiency. Chronic granulomatous disease, CGD. Leukocyte adhesion deficiency type 1. Chediak-Higashi. Clinical features. Asymptomatic at birth. Recurrent bacterial, viral, fungal, thrush, and protozoal infections. Chronic diarrhea. Failure to thrive. Lymph nodes and tonsils may be absent. Present at birth. Remember the acronym WISPR, Wiskott-Aldrich syndrome. Copyright purpura, due to thrombocytopenia, copyright eczema. Copyright recurrent pyogenic infections, with encapsulated organisms. Increased risk of autoimmune diseases and hematological malignancies. Recurrent sinopulmonary infections *, commonly infections with pneumocystis jirovecii, histoplasma, cryptosporidium, and CMV. Failure to thrive. Onset, early childhood. Classic triad of 3 Copyright progressive ataxia due to cerebellar atrophy. Spider angiomas. Copyright IgA deficiency. Susceptibility to infections, example ear infections, sinusitis, pneumonia, increased risk of malignancy, example non-Hodgkin lymphoma and leukemia, increased sensitivity to radiation, therefore X-ray exposure should be avoided in these individuals. Overview of etiology. X-linked, most common, or autosomal recessive inheritance ** defective phagocytic NADP oxidase defective ROS production by neutrophils and macrophages decreased respiratory burst in neutrophils. Autosomal recessive inheritance scent absent LFA1, CD18, protein impaired leukocyte chemotaxis and migration. Autosomal recessive inheritance LYST gene defect defective neutrophil chemotaxis and Y. Myeloperoxidase deficiency. Severe congenital neutropenia. Polymerization dysfunction defective phagosome-lysosome fusion. Autosomal recessive inheritance mutation in MPO gene partial or complete deficiency of MPO in phagocytes. Autosomal dominant, autosomal recessive, or X-linked recessive inheritance bone marrow failure of myeloid lineage. Phil and Phagocy S. Clinical features. Recurrent, severe infections with catalase-positive organisms 1, lymphadenopathy possible skin granulomas. Recurrent non-suppurative bacterial infections of skin and mucosa impaired wound healing delayed separation of the umbilical cord periodontitis. Remember the acronym ALPINE. Degree partial albinism lymphohistiocytosis peripheral neuropathy recurrent pyogenic infections, S. pyogenes, S. aureus, and Pseudomonas species. Progressive neurodegeneration, and neutropenia. Degree. Often asymptomatic * recurrent candida infections. * recurrent bacterial infections, e.g. gingivitis, otitis media, respiratory infections, and cellulitis, streptococcus and staphylococcus, oral ulcerations. WV. NA collapse. A. Find text. Genetic testing, FOXP3 gene mutations * low or absent CD4 CD25 regulatory T cells otherwise normal T cell populations. Diagnostic findings. Quantitative PCR, low TRECs absent T cells, X-linked variant, absent T cells, B cells, and NK cells, AR variant, CXR, absent thymic shadow lymph node biopsy, absent germinal centers. Normal or low IgG and IgM increased IgE and IgA thrombocytopenia with small platelets genetic analysis, mutated was gene. Low IgG, IgA, and IgE normal or increased IgM lymph node biopsy, absent germinal centers. MRI, cerebellar, vermis, atrophy increased AFP levels low IgA, IgG, and IgE lymphopenia. Diagnostic findings. Abnormal DHR test, absent or decreased green fluorescence negative nitroblue tetrazolium dye reduction test J anemia genotyping is confirmatory. Leukocytosis, however, neutrophils are absent at the site of infection flow cytometry, absent CD18. Peripheral smear, giant cytoplasmic granules in granulocytes and platelets sent mild coagulation abnormalities pancytopenia. Positive nitroblue tetrazolium test, intact NADP oxidase, absent MPO on staining genetic analysis, MPO gene mutation. Absolute neutropenia, relative monocytosis bone marrow ASPI rate, normal or decreased cellularity, arrest of myeloid lineage. Outline. A. OOE. Absolute neutropenia, relative * recurrent bacterial infections, e.g. gingivitis, otitis media, autosomal dominant, autosomal recessive, or X-linked recurrent D cellulitis, strep D monocytosis, respiratory infections, and cellulitis eptococcus ani severe congenital recessive inheritance * bone marrow ASPI rate, normal or neutropenia, Oo Staphylococcus, 7 bone marrow failure of myeloid lineage, decreased cellularity, arrest of oral ulcerations myeloid yelloid lineage. Complement disorders. Overview of complement disorders: immunodeficiency etiology, clinical features, diagnostic findings. CHS50 assay screening, autosomal dominant inheritance, 5 test EREA_recurrent angioedemas provoked by triggers, example trauma, unregulated activation of kallikrein T bradykinin C1 esterase inhibitor deficiency, surgery, infections, and drugs. Angioedema AIDBAFEAH Phaedo airway edemas can be life-threatening. See bradykinin-mediated angioedema in angioedema Y9. Bradykinin levels low, C4 levels strong, contraindication for ACE inhibitors. T risk of recurrent severe infections of the respiratory tract, mostly autosomal recessive inheritance, canes * most common deficiency, C2I and sinus yen. 7 colonase risk of developing SLE, early complement deficiencies, scent deficiency of C3 and its cleaved fragments, example C3b, scent recurrent, severe infections with encapsulated bacteria, example scent impaired, opsonization of pathogens, reduced Neisseria meningitis, Haemophilus influenza, CHS50 assay screening, codons yen isoclearance of C3b bound. Immune complexes T streptococcus pneumoniae, tests susceptibility to type 3 HS, are associated with autoimmune diseases, example SLE, scent levels of complement. Recurrent Neisseria, e.g. meningococcal, or gonococcal pyogenic infections, life-threatening sepsis is possible. Associated with SLE and glomerulonephritis. Autosomal recessive inheritance. Most common deficiencies, C5, C6, and C8, inability to form membrane attack complex. Congenital B-cell immunodeficiencies. B-cell defects, humoral immunity deficiencies, account for 50 to 60% of all primary immunodeficiencies. X-linked, Bruton, agamoglobulemia/3. Scent definition: X-linked recessive disease that causes a complete deficiency of mature B lymphocytes. Scent epidemiology, occurs mainly in boys. Scent etiology, defect of Bruton tyrosine kinase, BTK, expressed in B cells. Complete deficiency of mature B cells. * Clinical features: symptoms develop between 3 and 6 months of age, when maternal IgG levels in fetal serum start to decrease. Copyright hypoplasia of lymphoid tissue, example tonsils, lymph nodes, O recurrent, severe, pyogenic infections, example pneumonia, otitis media, especially with encapsulated bacteria, S. pneumoniae, and meningitis, and H. influenza. Copyright hepatitis virus and enterovirus, example Coxsackie virus, infections. Scent diagnosis: O flow cytometry. Absent or low levels of B cells, marked by CD19, CD20, and CD21, equals normal or high T cells. Copyright low immunoglobulins of all classes. Copyright absent lymphoid tissue, i.e., no germinal centers and primary follicles. Scent treatment. Copyright IV immunoglobulins E. Prophylactic antibiotics. Live vaccines, example MMR, are contraindicated in patients with X-linked, Bruton, agamoglobulemia. And X-linked, Bruton, agamoglobulemia, brutal defects in a B cell make little boys feel unwell. Selective IgA deficiency, SIGAD/IL5. Scent definition: most common primary immunodeficiency that is characterized by a near or total absence of serum and secretory IgA. Scent epidemiology, approximate 1:220 to 1:1,000. Scent etiology, unknown. Scent clinical features: O often asymptomatic. =QL. Collapse. Fine text outline. Scent definition: most common primary immunodeficiency that is characterized by a near or total absence of serum and secretory IgA. Scent epidemiology, approximate 1:220 to 1:1,000 etiology, unknown 1 cent clinical features. O often asymptomatic degree may manifest with sinusitis or respiratory infections, S. pneumoniae, H. influenza, copyright chronic diarrhea, partially due to elevated susceptibility to parasitic infection, e.g. by Giardia lamblia, copyright associated with autoimmune diseases, example gluten. Sensitive enteropathy, inflammatory bowel disease, immune thrombocytopenia, and atopy. Copyright anaphylactic reaction to products containing IgA, example intravenous immunoglobulin, scent diagnosis. O decreased serum IgA levels. Scent treatment. Copyright treatment of infections. Copyright prophylactic antibiotics. Copyright intravenous infusion of IgA is not recommended because of the risk of anaphylactic reactions, caused by the production of anti-IgA antibodies. 6. To prevent transfusion reactions, IgA-deficient patients must be given washed blood products without IgA or obtain blood from an IgA-deficient donor. QB. The 6 A's of selective IgA deficiency: asymptomatic, airway infections, anaphylaxis to IgA-containing products, autoimmune diseases, atopy. Common variable immunodeficiency, CVID, 728291. Scent definition: primary immunodeficiency with low serum levels of all immunoglobulins despite phenotypically normal B cells. Scent epidemiology: O sex, $=0. Copyright onset, later than other B cell defects, typically at 20 to 40 years of age. 10. Scent etiology: most cases are sporadic with no known family history. Scent pathophysiology: B cells are phenotypically normal but are unable to differentiate into Ig-producing cells, resulting in low immunoglobulins of all classes. Scent clinical features. Copyright recurrent pyogenic respiratory infections, example sinopulmonary infections, in rare cases, enteroviral meningitis, copyright associated with a high risk of lymphoma, gastric cancer, bronchiectasis, and autoimmune disorders, example rheumatoid arthritis, autoimmune hemolytic anemia, immune thrombocytopenia, vitiligo. 5.1. Scent diagnosis. Copyright quantitative immunoglobulin levels, low levels of IgG, IgA, and IgMO, decreased number of plasma cells. Copyright flow cytometry shows subsets of normal B and T cells. Copyright poor response to immunization. Scent treatment. Copyright treatment of infections. Copyright prophylactic antibiotics. Copyright for immunoglobulins. Transient hypogammaglobulinemia of infancy, T, 12 to 13. Scent definition: an age-related delay in immunoglobulin production despite having normal levels of B cells. Scent epidemiology. Copyright approximate 1:1000 live births. 13. Copyright onset, 6 months of age. Ig levels typically increase and normalize at 2 to 6 years of age. 12. Scent clinical features. O recurrent infections, most common, sinopulmonary infections, otitis media, bronchitis, tonsillitis, diarrhea. Copyright atopic manifestations, example asthma, food allergies. Copyright failure to thrive and/or developmental delay. Copyright can be asymptomatic. Copyright severe and/or invasive infections, such as meningitis and bacteremia, rare. Scent diagnosis. Copyright quantitative immunoglobulin levels equals IgG is. Copyright IV immunoglobulins in patients who develop severe and/or invasive infections or recurrent infections despite prophylaxis. Copyright appropriate treatment in patients with atopic manifestations, example bronchodilators. Copyright routine immunization schedule should be continued. Ads, a req collapse fine text outline. Congenital T-cell immunodeficiencies. T-cell defects, cellular immunity deficiencies, are responsible for 5 to 10% of congenital immunodeficiencies. DiGeorge syndrome, 22q11.2 deletion syndrome, 141. Scent definition: syndrome characterized by defective development of the third and fourth pharyngeal pouches leading to hypoplastic thymus and parathyroids. Etiology: autosomal dominant, microdeletion at chromosome 22, 22q11.2, scent clinical features copyright cardiac anomalies equals conotruncal abnormalities, example tetralogy of Fallot or persistent truncus arteriosus, equals ventricular septal defect, VSD, equals atrial septal defect, ASD, O anomalous face equals prominent nasal bridge equals hypoplastic wing of the nose equals dysplastic ears equals micrognathia, small lower jaw, and slash or retrognathia copyright thymus aplasia slash hypoplasia, recurrent infections, viral slash fungal slash PCP pneumonia, due to T-cell deficiency copyright cleft palate E hypoparathyroidism, hypocalcemia with tetany scent diagnosis copyright detection of 22q11.2 deletion via fluorescence in situ hybridization, FISH, OPTH and CA, *O absolute T lymphocyte count copyright delayed hypersensitivity skin testing copyright CXR, absence of thymic shadow scent treatment. O immune deficiency treatment equals antibiotics, virostatics, and antimycotics equals PCP prophylaxis equals consider bone marrow transplant and slash or IVIG copyright possible thymus transplantation, scent prognosis, poor if not treated, patients usually do not survive beyond childhood. QCatch22 is the acronym for typical features of DiGeorge syndrome, cardiac anomalies, anomalous face, thymic aplasia slash hypoplasia, cleft palate, hypocalcemia, chromosome 22. Autosomal dominant hyperimmunoglobulin E syndrome, Job syndrome, 151. Scent definition, defect in neutrophil chemotaxis etiology, autosomal dominant, STAT3 mutation Th17 cells neutrophil slash macrophage chemotaxis scent clinical features copyright coarse facies copyright non-inflamed abscesses, recurrent bacterial, staphylococcal, infections copyright retained primary teeth copyright hyper-IgE, eosinophilia, copyright dermatologic, severe eczema, copyright other features, decreased bone density increases the risk of bone fractures following minor trauma. 16 scent diagnosis OTFIGE copyright, variable, eosinophilia OJIF New York scent treatment copyright antibiotics and prophylaxis, with penicillinase-resistant antibiotics, copyright for immunoglobulin therapy. QB faded is the acronym for the typical features of autosomal dominant hyper-IgE syndrome, coarse facies slash fractures, abscesses, retained primary teeth, hyper-IgE slash eosinophilia, dermatologic, severe eczema. IL-12 receptor deficiency, 171 I18 I19. Plus definition, impaired Th1 response due to IL-12 receptors scent etiology, autosomal recessive E pathophysiology equals QL. Collapse fine text outline. IL-12 receptor deficiency, 171 I18 I19. Asterisk definition, impaired Th1 response due to IL-12 receptors scent etiology, autosomal recessive scent pathophysiology O normally, antigen-presenting macrophages release IL-12 Th cells transformation to T1 type release of IFNY to activate macrophages copyright defective IL-12 receptors, macrophages cannot be activated by IFNY no cytotoxicity in cells infected with intracellular pathogens, example mycobacteria, salmonella. Copyright IL-12 receptor deficiency is the underlying pathology in most cases of high Mendelian susceptibility to mycobacterial disease, MSMD, equals affected individuals have defects in IFNY-mediated immunity. Equals this increases susceptibility to infection with weakly virulent mycobacteria, example environmental mycobacteria, BCG vaccine. Scent clinical features copyright the age of onset varies, depends on the age at exposure to causative pathogens 1 to 3 years of age O features of disseminated disease. Equals mycobacterial infections, example developing tuberculosis after BCG vaccination. Equals fungal infection scent diagnosis, IFNY scent treatment, antibiotics and IFNY therapy, chronic mucocutaneous candidiasis. Scent definition, impaired or absent T-cell response to Candida antigen. Scent etiology. Copyright several congenital defects that result in impaired T-cell function. Autoimmune regulator, AIR protein, deficiency is a common cause. Copyright the majority of cases are caused by a gain of function mutation in the STAT1 gene. 201. Pathophysiology, defects in IL-17 and IL-17 receptors. Insufficient cell-mediated immune response to Candida infection. Scent clinical features. Copyright persistent or, less commonly, recurrent non-invasive Candida infections of the skin, mucous membranes, and nails. Associated autoimmune disorders, example immune thrombocytopenic purpura, rheumatoid arthritis. Scent diagnosis. Copyright usually clinical. Copyright absent in vitro T-cell proliferation when exposed to Candida antigen. Absent cutaneous reaction to Candida antigen. Scent treatment. Copyright antifungal therapy. Copyright treatment of associated conditions. IPEX syndrome, immune dysregulation, polyendocrinopathy, enteropathy, X-linked. Scent definition, a syndrome characterized by a dysfunctional regulatory T-cell lineage that leads to autoimmunity as a result of disrupted tolerance to self-antigens. Etiology. X-linked recessive type of inheritance. Copyright mutation in transcription factor FOXP3. Unchecked activation of T cells against host tissues. Scent clinical features. Copyright classically presents in early infancy. Lymphadenopathy and/or chronic lymphoid tissue hypertrophy, example enlarged tonsils, eczema, possibly accompanied by other autoimmune dermatologic conditions. Autoimmune endocrine conditions, example hyperthyroidism or hypothyroidism, type 1 diabetes mellitus in male individuals. Copyright enteropathy, manifesting as example chronic diarrhea. Copyright nail dystrophy. Failure to thrive. Scent diagnosis. Copyright primarily based on clinical examination and family history. Genetic testing, mutations in FOXP3. Flow cytometry, severely reduced or absent CD4 plus CD25 plus regulatory T cells with otherwise normal T cell populations. Scent treatment. Copyright nutritional support. Immunosuppression, tacrolimus, cyclosporin, or sirolimus. Copyright rituximab. Bone marrow transplant. CC-ital mixed I-deficit YG. Severe combined immunodeficiency, SCID, Glanzmann-Reinecker syndrome, a lymphocytosis. Scent definition, a rare genetic condition caused by numerous genetic mutations that result in the defective development of functional B cells and T cells. Scent etiology, various mutations, the most common of which are, AE, A equals QCD collapse. Fine text outline. Severe combined immunodeficiency, SCID, Glanzmann-Reinecker syndrome, a lymphocytosis. Scent definition, a rare genetic condition caused by numerous genetic mutations that result in the defective development of functional B cells and T cells. Scent etiology, various mutations, the most common of which are, copyright X-linked recessive, mutations in the gene encoding the common gamma chain defective IL-2R gamma chain receptor linked to JAK3, most common SCID mutation, autosomal recessive adenosine deaminase, ADA, deficiency accumulation of toxic metabolites, deoxyadenosine and DATP, and disrupted purine metabolism. Accumulation of DATP inhibits the function of ribonucleotide reductase. Impaired generation of deoxynucleotides. Janus-associated kinase 3, JAK3, deficiency. ORAG mutation results in faulty VDJ recombination, see immunoglobulin properties. Scent clinical features. O normal at birth. O severe, recurrent infections, bacterial diarrhea, chronic candidiasis, thrush, viral and protozoal infections. O failure to thrive. Copyright chronic diarrhea. O lymph nodes and tonsils may be absent plus subtype, Omen syndrome, an autosomal recessive form of SCID, 21. Copyright etiology, mutations of RAG gene or ILRA7 gene. Copyright clinical features equals onset before 3 months of age equals erythroderma, adenopathy, and hepatosplenomegaly equals severe, recurrent infections equals failure to thrive. Copyright diagnosis, oligoclonal T cells, eosinophilia, TIgE levels. Sent diagnosis. Copyright quantitative PCR, T cell receptor excision circles, TRECs. Detection of TRECs is used in the newborn screening for SCIDO flow cytometry, absent T cells, 10CXR, absent thymic shadow O lymph node. Biopsy, absent germinal centers. Sent treatment. Copyright 4 immunoglobulins. Copyright BCP prophylaxis O bone marrow transplant or stem cell transplantation. Copyright avoidance of live vaccines. Copyright prognosis, often fatal in the first year of life if left untreated. 22. Wiskott-Aldrich syndrome, was. Sent definition, genetic condition characterized by impaired function of T cells and thrombocytopenia. Sent epidemiology, occurs primarily in males. Sent etiology, mutated was gene, X-linked recessive inheritance, impaired signaling to actin cytoskeleton reorganization. Defective antigen presentation. Sent clinical features. Copyright onset of symptoms, from birth. Copyright classic triad equals purpura, bleeding diathesis, equals eczema, high risk of atopic disorders, equals recurrent opportunistic infections with encapsulated organisms in the first years of life, example otitis media. Copyright increased risk of autoimmune diseases and hematological malignancies, example lymphoma, leukemia. Sent diagnosis. Copyright normal or JIgG and IgM. Copyright foot IgE and IgA, copyright thrombocytopenia with small platelets. Copyright genetic analysis, confirmatory test mutated was gene. Sent treatment. Copyright for immunoglobulin therapy. Copyright prophylactic antibiotics O platelet transfusions. Copyright stem cell transplantation may be curative. Sent prognosis, shortened life expectancy. And classic findings of Wiskott-Aldrich syndrome, Wiskott-Aldrich syndrome, purpura, eczema, recurrent infections. Whisper. Hyper-IgM syndrome 231. Sent definition, a group of syndromes characterized by impaired interaction between Th cells and B cells that results in a B cell class switching defect. Sent epidemiology, CD40 ligand deficiency is the most common form. Etiology O X-linked recessive inheritance. ECD4OL deficiency in Th cells leads to abnormal interaction with B cells that express the CD40 receptor, disrupting B cell class switching, which leads to depleted immunoglobulins. 5 equals al. Collapse. Find text outline. Sent clinical features O recurrent severe pyogenic infections that manifest since childhood equals opportunistic sinopulmonary infections, commonly pneumocystis jirovecii and histoplasma, equals cryptosporidium entrithes, which may lead to biliary disease, cirrhosis, and cholangiocarcinoma, equals CMV. Hepatitis O failure to thrive. Sent diagnosis O4 IgG, IgA, IgE degree norma or TIgM. Copyright lymph node biopsy, absent germinal centers. Sent treatment. Copyright for immunoglobulin therapy. Copyright prophylactic antibiotics. Copyright recombinant human granulocyte colony stimulating factor O. Stem cell transplantation may be curative. Ataxia telangiectasia. Sent see ataxia telangiectasia for details. WA 2. Congenital neutrophil and phagocyte disorders. Phagocytic defects are characterized by the impaired ability of phagocytic cells, example monocytes, macrophages, granulocytes such as neutrophils and eosinophils, to kill pathogens. These types of defects account for 10 to 15% of primary immunodeficiencies. Chronic granulomatous disease, CGD. Sent definition, deficiency of superoxide production by polymorphonuclear neutrophils and macrophages. Etiology O X-linked recessive or autosomal recessive inheritance, 2:1, O defective phagocytic nicotinamide adenine dinucleotide phosphate, NADPH, oxidase that results in equals defective reactive oxygen species, ROS, production, example superoxide, impaired ability to deactivate or kill ingested microorganisms equals decreased respiratory burst in neutrophils sent clinical features or recurrent. Severe infections, chronic skin, lymph node, bone, respiratory, GL, and urinary tract infections, with catalase-positive organisms, S. aureus, Nocardia species, Escherichia coli, Candida, Klebsiella, Pseudomonas, Aspergillus, Serratia, O lymphadenopathy O granulomas of the skin and GI/GU tract scent diagnosis O neutrophil assay equals dihydroerhodamine test, DHR flow cytometry test showing abnormal NADH oxidase activity, inability to metabolize dihydroerhodamine to fluorescent product, rhodamine decreased green fluorescence, 24. Equals nitroblue tetrazolium direduction test, negative, i.e., incubated leukocytes fail to turn blue when exposed to nitroblue tetrazolium O hypergammaglobulinemia O anemia copyright genotyping is confirmatory scent treatment O treatment of infections copyright lifelong prophylactic antibiotics, example TMPSMX, for catalase-positive infections, copyright antifungal prophylaxis, example itraconazole, voriconazole, posaconazole, copyright glucocorticoids for severe inflammation OIFNY therapy O bone marrow transplant copyright possibly gene therapy. Leukocyte adhesion deficiency type 1, LAD1. Scent definition, a genetic condition characterized by a defect in the leukocytic chemotaxis that results in decreased phagocyte activity etiology O autosomal recessive inheritance copyright absence of the B2INTE-GRIN leukocyte adhesion surface molecule LFA1, CD18, prevents leukocytes from migrating to tissues during infection or inflammation. Scent clinical features O recurrent non-suppurative bacterial infections, example skin and mucosal infections, with minimal inflammation due to dysfunctional neutrophils equals QL. Collapse fine text outline. Scent clinical features O recurrent non-suppurative bacterial infections, example skin and mucosal infections, with minimal inflammation due to dysfunctional neutrophils O impaired wound healing copyright omphalitis O delayed separation of the umbilical cord, 30 days postpartum, scent diagnosis O leukocytosis, however, neutrophils are absent at the site of infection copyright flow cytometry, absent CD18, CD11A, CD11B, and CD11 scent treatment copyright prevention of further infections, example adequate dental hygiene, copyright treatment of infections O bone marrow transplant. Chediak-Higashi syndrome. Scent definition, defect in neutrophil chemotaxis and microtubule polymerization dysfunction defective phagosome-lysosome fusion etiology, autosomal recessive, defective lysosomal trafficking regulator, LYST, gene scent clinical features copyright recurrent pyogenic infections may be extensive if massive infiltration occurs pathogens include, S. pyogenes, S. aureus, and Pseudomonas spp. Copyright partial albinism O progressive degeneration of neurons and peripheral neuropathy copyright hemophagocytic lymphohistiocytosis, can occur in the accelerated phase and is potentially fatal. Scent diagnosis copyright peripheral smear shows giant cytoplasmic granules in granulocytes and platelets copyright mild coagulation abnormalities copyright pancytopenia, especially neutropenia, scent treatment, bone marrow transplant. Classic findings of Chediak-Higashi syndrome, albinism, lymphohistiocytosis, peripheral neuropathy, infections, neurodegeneration, neutropenia alpine. Myeloperoxidase deficiency. Scent definition, a genetic condition characterized by the deficiency or absence of myeloperoxidase enzyme in phagocytes that are unable to form hypochlorous acid, HCIO, but have preserved respiratory burst, since NADH oxidase is intact. Etiology, autosomal recessive mutation in the MPO gene scent clinical features O recurrent candida infections, example oral thrush, vulvovaginitis, Many patients are asymptomatic. Scent diagnosis: copyright positive nitroblue tetrazolium test, intact NADF oxidase O, absent myeloperoxidase on staining O, mutations in MPO gene on sequencing. Scent treatment: copyright no specific treatment or prophylaxis, copyright treatment of fungal infections. Severe congenital neutropenia. Scent definition: a deficiency of neutrophils that occurs at or around birth due to bone marrow failure of the myeloid lineage. Scent etiology: EO, autosomal dominant, autosomal recessive, or X-linked recessive inheritance. E, mutations in the neutrophil elastase gene, HAX1 gene, and Wiskott-Aldrich syndrome gene. Scent clinical features: copyright recurrent bacterial infections, example gingivitis, otitis media, respiratory infections, and cellulitis due to streptococcus and staphylococcus. Copyright oral ulcerations are commonly seen by the age of 2 years. Scent diagnosis: O, absolute neutropenia with relative monocytosis. Absolute neutrophil count is usually equals QL. Collapse fine text outline. Congenital complement deficiencies. Complement component deficiencies. Complement component deficiencies are a group of rare inherited genetic conditions characterized by absent or abnormal complement component proteins, which increases the risk of recurrent bacterial infections and autoimmune conditions. Classification. Epidemiology. Etiology. Pathophysiology. Clinical features. Diagnosis. Management. Complications. 2. Overview of CI Path 7 equals defici CIR deficiency and/or 26127 C1S deficiency C1Q deficiency. Underscore asterisk extremely rare J very rare, 12631. Autosomal recessive inheritance. Underscore sensoran/or C1S gene C1Q gene mutations. A. Mutations. Decreased or abnormal, i.e., low molecular weight, C1q protein, C1R, and/or cis-J equals inability to form the C1 complex, disruption of the classical pathway cascade. Increased risk of bacterial infections. Recurrent skin lesions that worsen with scent, high frequency of sinopulmonary infections, especially with S. pneumonia. Excessive UV light exposure, cataracts, hair loss, eyelashes, eyebrows, scalp hair. Measurement of serum protein levels, confirmatory molecular genetic testing. Alternative PIP. C2 deficiency 28. 1:20,000 in individuals of Western European descent. 821, most common genetically determined complement deficiency. C2 gene mutations. Type C2 deficiency, deletion in C2 gene, impaired translation of the C2 protein, absent C2 protein. Type ILC2 deficiency, point mutation the C2 gene, C2 secretion, plasma levels. Asymptomatic in the majority of cases. C3 deficiency 29. Asterisk very rare 183. Asterisk primary or secondary due to impairment in the regulatory proteins factor or factor H. Decreased C3b, impaired opsonization of pathogens and for clearance of C3b bound immune complexes. Recurrent, severe childhood infections, example upper respiratory tract infections, pneumonia, meningitis, with encapsulated bacteria, example N. Meningitis, H. influenza, S. pneumoniae. C1q deficiency, neuroimaging may show cerebral vasculitis, brain atrophy, and/or lesions of the basal ganglia. CHS50 assay screening test. O measures total hemolytic complement activity of the classical complement pathway. E hemolysis of the serum sample will be absent if the patient has a complement deficiency. No specific treatment available. Immunization against the most likely pathogens, antibiotic prophylaxis and treatment of infections, immunosuppression in patients with SLEC1Q deficiency, allogeneic hematopoietic stem cell transplantation can restore physiologic C1Q production. Associated with renal disease, mesangial proliferative glomerulonephritis, IgA nephropathy. Risk of autoimmune conditions. Extremely high risk of SLE or SLE-like disease. 1. Copyright usually manifests with severe symptoms during childhood. Prominent cutaneous scent. High risk of SLE or degree SLE-like disease. 1. Manifestations. Neuropsychiatric symptoms, example seizures, psychosis, ataxia. Degree. 10 to 30% of affected individuals develop SLE. C1 esterase inhibitor deficiency, hereditary angioedema. Sense bradykinin-mediated angioedema. Mannose binding lectin deficiency, MBL deficiency, 35. Plus associated with SLE and type IL hypersensitivity reactions. Terminal complement Ashral, C5C9, 25C430. Asterisk very rare 430. Autosomal dominant or autosomal recessive inheritance asterisk C4 gene mutations. Decreased or absent C4 protein J activation of the classical and lectin complement. Pathway 34. Asterisk increased risk of viral infections. Asterisk very high risk of developing SLE or SLE-like diseases. Scent definition, an inherited genetic condition characterized by low levels of MBL associated with increased susceptibility to infections. Scent epidemiology, common, affects an estimated 10 to 30% of the population worldwide. Plus etiology, mutations in the MBL2 gene. Pathophysiology, genetic mutations, production of MBL subunits or impaired subunit assembly into functional MBLJ, activation of the lectin complement. NA collapse. A. Find text. Asterisk C5, C6, and C8 deficiency are the most common. Autosomal recessive inheritance. Asterisk impaired formation of the membrane attack complex due to deficiencies in terminal complement factors, C5-C9. Asterisk increased risk of recurrent Neisseria species infections. Scent risk of infection and subsequent potentially life-threatening sepsis increases with course of the disease. Outline. Etiology. Pathophysiology. Clinical features. Diagnosis. Management. Complications. 2. Autosomal recessive inheritance. Scent CLRAN/or C1s gene C1q gene mutations, mutations. 1. Decreased or abnormal, i.e., low molecular weight, C1q protein, CIR, and/or cis equals inability to form the C1 complex, disruption of the classical pathway cascade. Increased risk of bacterial infections. Recurrent skin lesions that worsen with excessive UV light exposure, cataracts. Scent high frequency of sinopulmonary infections, especially, with S. pneumonia, hair loss, eyelashes, eyebrows, scalp hair. Measurement of serum protein levels, confirmatory molecular genetic testing. C1q deficiency, neuroimaging may show cerebral vasculitis, brain atrophy, and/or lesions of the basal ganglia. CHS0 assay screening test. C2 gene mutations. Type C2 deficiency, deletion in C2 gene, impaired translation of the C2 protein, absent C2 protein type. ILC2 deficiency, point mutation the C2 gene, C2 secretion plasma levels. Asymptomatic in the majority of cases. primary or secondary due to impairment in the regulatory proteins factor or factor H. Decreased C3b impaired opsonization of pathogens and J clearance of C3b bound immune complexes. Recurrent, severe childhood infections, example upper respiratory tract infections, pneumonia, meningitis, with encapsulated bacteria, example N. Meningitis, H. Influenza, S. Pneumonia. Copyright measures total hemolytic complement activity of the classical complement pathway. Copyright hemolysis of the serum sample will be absent if the patient has a complement deficiency. No specific treatment available. Immunization against the most likely pathogens, antibiotic prophylaxis and treatment of infections, immunosuppression in patients with SLEC1q deficiency, allogeneic hematopoietic stem cell transplantation can restore physiologic C1q production. Associated with renal disease, mesangial proliferative glomerulonephritis, IgA nephropathy. Risk of autoimmune conditions. Extremely high risk of SLE or SLE-like disease. Copyright usually manifests with severe symptoms during childhood. Prominent cutaneous manifestations, neuropsychiatric symptoms, example seizures, psychosis, ataxia. Asterisk high risk of SLE or degree SLE-like disease. Degree 10 to 30% of affected individuals develop SLEI. C1 esterase inhibitor deficiency, hereditary angioedema. Sense bradykinin-mediated angioedema. Mannose binding lectin deficiency, MBL deficiency, 35. Etiology, mutations in the MBL2 gene. Pathophysiology, genetic mutations, production of MBL subunits or impaired subunit assembly into functional MBLJ, activation of the lectin complement pathway. 7. Susceptibility to infections. 1-841. Diagnostics, clinical features, symptoms of recurrent infections. O. Measurement of serum MBL protein levels. Copyright confirmatory molecular genetic testing. S. Sources. Management and complications, CC1q deficiency. Epidemiology, common, affects an estimated 10 to 30% of the population worldwide. Asterisk associated with SLE and type I hypersensitivity reactions. Last updated January 31, 2024. NA collapse. A. Plus autosomal dominant or autosomal recessive inheritance asterisk C4 gene mutations OMCL. Decreased or absent C4 protein activation of the classical and lectin complement pathway, 34. Asterisk increased risk of viral infections. Asterisk very high risk of developing SLE or SLE-like diseases. Phi. Definition: an inherited genetic condition characterized by low levels of MBL associated with increased susceptibility to infections. Find text. Autosomal recessive inheritance. Impaired formation of the membrane attack complex due to deficiencies in terminal complement factors, C5-C9. Asterisk increased risk of recurrent Neisseria species infections. Plus risk of infection and subsequent potentially life-threatening sepsis increases with course of the disease. Outline. Urocongenital immunodeficiency disorders, 1/1. X-linked, Bruton, hypoplastic lymphoid tissue uncanrenwit. Agamoglobulinemia. Pyogenic EE infections. Inheritance X-linked recessive. Epidemiology E almost exclusively affects boys. Tonsil hypoplasia 1E symptom onset at 3 to 6 months of age, as maternal IgG levels decrease. Diagnosis: low immunoglobulins of all classes. Flow cytometry degree: absence or low levels of B cells, normal or high levels of T cells. Sinusitis. Pneumonia. Lymph node E. Genetic testing: hypoplasia. Treatment for immunoglobulins, prophylactic antibiotics, equals 2 ARI. Gastrointestinal tract infections. Defective BTK, ATYY. AI. Lymphoid pro B cell, pre B cell, immature B cell, mature B cell, plasma ESP, precursor cell 4OI. Bruton agammaglobulinemia. Fact sheet VV. BTK, B cell tyrosine kinase. Copyright Boss. 22q11.2 Deletion syndrome, DiGeorge syndrome. Epidemiology: incidence 1 in 2,000 to 7,000 live births. Etiology: microdeletion on chromosome 22, 22q11.2, 90% spontaneous mutations. Prognosis: highly variable, depending on severity of symptoms. Degree of cardiac involvement is the most important prognostic factor. Life expectancy: mostly normal life expectancy. Learning difficulties and psychiatric disorders, example ADHD, schizophrenia. Congenital immunodeficiency disorders, 1/2. Characteristic facial features: ptosis, epicanthal folds, and wide-set eyes, high and broad nasal bridge, cleft palate, hearing loss / nasal voice edge, feeding disorder, flat cheekbones / ZH4, enamel hypoplasia / DiGeorge syndrome, 22q11.2 deletion syndrome, fact sheet. Copyright Boss. Thymic features, thymic aplasia / hypoplasia. Cardiac features, ventricular septal defect, truncus arteriosus, tetralogy of Fallot. Renal features, renal agenesis. Gastrointestinal features, structural gastrointestinal anomalies, anal atresia. Registered hypocalcemia EX. Congenital immunodeficiency disorders, 2/2. Facial features in DiGeorge syndrome VV. Broad nasal bridge and nasal tip, ocular hypertelorism, dysplastic and low-set ears, as well as micrognathia. Source: Figure 1, in, Towards a Safety Net for Management of 22q11.2 Deletion Syndrome, Guidelines for Our Times by A. Habel, R. Ario, D. Kumararotny et al., Springer Link, licensed under CC by 4.0. Modifications, person anonymized. A recurrent infections manifestations: chronic granulomatous disease. Definition: impaired phagocytosis due to neutrophils and macrophage defect in NAPT oxidase and superoxide radical production. Pallor, due to anemia. Lymphadenopathy, pneumonia. Bacterial liver abscesses, hepatomegaly, inheritance, X-linked recessive or autosomal recessive gastrointestinal granulomas, bowel obstruction. Diagnosis: E-dihydroergotamine, DHR, test urinary tract granulomas, E-nitroblutetrazolium, test urinary retention. Treatment: skin granulomas, E daily trimethoprim / sulfamethoxazole, TMPSMX, EIFN gamma, E bone marrow transplant, E gene therapy, if possible. Osteomyelitis. L. J superoxide, J hydrogen, AE production, peroxide, OHO, EN. Defecti. E/ZBY.A registered at / NAPT equals and microbial OTAA oxidase catalase, at IA at .2. O, H0 plus 0, diac-phagocyte phagolysosome, intracellular microbe granuloma, impaired respiratory burst, survival formation. Chronic granulomatous disease, fact sheet VV. Copyright Boss. Neurocongenital immunology. Chediak-Higashi syndrome VV. Photomicrograph of peripheral blood smear, right Guillain stain, very high magnification, inclusion bodies, examples indicated by arrows, and polymorphous nuclei, green overlay, can be seen within the leukocytes. These findings are consistent with Chediak-Higashi syndrome. Source, Figure 2, in, 2 novel mutations identified in an African American child with Chediak-Higashi syndrome by Carrie Morone, Yanhua Wang, Marjan Huizing, Ellie Sutton, James G. White, William A. Gall, and Karen Moody, Case Reports in Medicine, licensed under CC by 3.0. X hypersensitivity reactions. A hypersensitivity reaction, HSR, is an exaggerated and/or pathological immune response to exogenous or endogenous substances. HSRs are commonly classified into 4 types. Type HSRs, example food and pollen allergies, asthma, anaphylaxis, are immediate allergic reactions. Type 2 HSRs, example autoimmune hemolytic anemia, Goodpasture syndrome, are cytotoxic. Tissue-specific antibodies cause destruction of cells in these tissues. Type 3 HSRs, example many vasculitides and glomerulonephritides, are immune complex mediated. Tissue damage is caused by antigen-antibody complex deposition. Type 4 HSRs, example TB skin tests, contact. Dermatitis, are delayed and cell-mediated and are the only HSRs that involve sensitized T lymphocytes rather than antibodies. In practice, many hypersensitivity syndromes are mixed reactions, meaning that they do not fit into a single reaction type. Non-allergic HSRs, example pseudoallergies, are caused by mast cell activation and histamine release after the first exposure to a trigger substance, example radiocontrast media. See also anaphylaxis and drug hypersensitivity reactions. WA. Re. Sus. Overview. Definitions. Scent hypersensitivity reaction, an exaggerated and/or pathological immune response to foreign or self-antigens. U1 scent allergy, an abnormal immunological response to an otherwise harmless environmental stimulus, example food, pollen, animal dander, autoimmune disease, an abnormal immunological response directed against self-antigens. Scent drug hypersensitivity reaction, group of adverse drug effects that resemble an allergy, may be allergic or non-allergic. 2. Stages. Scent sensitization, immunology. Initial asymptomatic contact with an antigen. Scent effect, harmful immune response following subsequent antigen contact. Classification. Scent traditionally categorized into 4 types based on immunological mechanisms. Reactions may be heterogeneous, i.e., syndromes do not fit into a single category. F2. Hypersensitivity classification 3-4. Summary of pathophysiology examples. Allergic or anaphylactic transfusion reactions, example in patients with IgA deficiency. 5. Anaphylaxis drug reactions, example penicillin, muscle relaxants, food allergies, example nuts, shellfish, eggs, soy, wheat, insect venom allergies, example bee, wasp, reactions to inhaled or other environmental allergens, example dust mites, animal dander. Preformed IgE antibodies coating mast cells and basophils are cross-linked type, immediate, by contact with free antigen. Ha cell degranulation results in the release of histamine and other inflammatory mediators. Pollen, latex, asthma, allergic rhinitis, atopy 1, 6. Destruction of cells. Acute hemolytic transfusion reaction AIA degree LO hemolytic disease of the fetus and newborn. Copyright immune thrombocytopenia, ITP, Copyright drug-induced neutropenia and agranulocytosis, example caused by methimazole, sulfasalazine, trimethoprim/sulfamethoxazole. Copyright pernicious anemia IgM or IgG antibodies bind to antigens on the cells of particular tissue equals types. Type IL, excitance comp Y and lysis or phagocytosis of cells * inflammation E plus antibody-dependent cell-mediated cytotoxicity, example by natural killer cells. Copyright Goodpasture syndrome antibody interference with normal cell function O rheumatic fever O hyperacute transplant rejection impaired cellular function O Graves' disease Copyright Bullous pemphigoid O E pemphigus vulgaris O myasthenia gravis. Serum sickness-like reaction, atypical without circulating immune complex involvement, Arthus reaction drug-induced hypersensitivity vasculitis IgG antibodies bind to circulating antigens. Type IL plex formation and deposition in particular tissues complex A deposits in tissue activate the complement system and attract neutrophils neutrophilic lysis or phagocytosis of cells. Hypersensitivity pneumonitis 5 polyarteritis nodosa, PEN, post-streptococcal glomerulonephritis IgA nephropathy membranous nephropathy degree SY lupus eryth, SLE. Plus acute and chronic transplant rejection graft versus host disease contact dermatitis, example nickel, poison ivy, rubber gloves, and we. Back collapse fine text outline. Acute and chronic transplant rejection graft versus host disease contact dermatitis, example nickel, poison ivy, rubber gloves, cosmetics, manta-tuberculin skin test for latent tuberculosis * contact of antigen with P-itis TLYMP * candida skin test type 4, delayed, T plus presensitized CD4 plus T cells recognize antigens on antigen presenting cells plus drug reactions, including, R cell-mediated, equals release of inflammatory cytokines activation of macrophages copyright Stevens-Johnson. Syndrome E antibodies, present presensitized CD8 plus T cells recognize antigens on somatic cells cell copyright toxic epidermal necrolysis SA-mediated cytotoxicity copyright drug reaction with eosinophilia and systemic symptoms, DRESS, multiple sclerosis Hashimoto's thyroiditis * rheumatoid arthritis * type 1 diabetes mellitus * Me equals Fe4 FLA, equals E registered 2. All four types of HSRs can be drug-induced. To remember the HSRs, think acid, A, allergic/anaphylactic/atopic, type, C cytotoxic, type IL, 1, immune complex deposition, type 3, D, delayed, type. AD, type and LVHSRs most commonly manifest cutaneously. 7. QBE. Type hypersensitivity reaction. Overview. Scent-type hypersensitivity reactions are referred to as immediate reactions. Antibody-mediated, include anaphylactic and atopic immune responses. Scent-C hypersensitivity classification for specific causes of type hypersensitivity. Tre iperatni renefe. Pathophysiology. 1. IgE is formed as a result of prior sensitization, i.e., previous contact with the antigen, and coats mast cells and basophils. 2. Subsequent encounter with antigen results in an IgE-mediated reaction by preformed IgE antibodies. Free antigen binds to two adjacent IgE antibodies, cross-linking, degranulation of cells. 3. Release of histamine and other mediators, example prostaglandin, platelet activating factor, leukotrienes, heparin, tryptase, leading to, copyright T smooth muscle contraction bronchospasm, abdominal cramping O peripheral vasodilation and 1 vascular permeability hypovolemia, hypotension O extravasation of capillary blood erythema copyright fluid shift into the interstitial space, edema, pulmonary edema copyright pruritus. 4. Mast cell secretion of cytokines and other pro-inflammatory mediators eosinophil and neutrophil chemotaxis late phase reaction inflammation and tissue damage. Typeless fast and furious. Cross-reactive hypersensitivity 1L9L. Scent description. Individuals with allergies may also react to substances that contain particles that are similar to the main antigen. Scent examples: primary allergen, cross-reactant allergen. Copyright pollen, various foods, example apple, hazelnut, carrot, kiwi, apricots, peaches. Back collapse, fine text outline. Scent examples: primary allergen, cross-reactant allergen, copyright pollen, various foods, example apple, hazelnut, carrot, kiwi, apricots, peaches, omites, crustaceans, latex, exotic fruits, example banana, avocado, kiwi, copyright bird dander, egg yolk, cat dander, pork timing. Scent immediate reaction, allergic reaction within minutes of contact with the antigen. Late phase reaction, occurs hours after immediate reaction for a duration of 24 to 72 hours. Examples: scent anaphylaxis, pruritus, edema, rash, rhinitis, bronchospasm, and abdominal cramping. Scent angioedema, due to mast cell activation in the dermis and/or subcutaneous tissue plus urticaria, hives, well circumscribed, raised, pruritic, and erythematous plaques with a round, oval, or serpiginous shape up to several centimeters in diameter, wheals, copyright caused by mast cell activation and degranulation in the superficial dermis. Hyperpermeability of microvasculature edema 10 copyright. Differential diagnosis, see overview of annular skin lesions. Plus atopy copyright. Genetic predisposition to producing IgE antibodies against certain harmless environmental allergens, example pollen, mites, molds, certain foods. Plus allergic conjunctivitis, allergic rhinitis, scent allergic asthma. Diagnostics, 11. Allergy-specific diagnostic testing should only be obtained in patients with a clinical history consistent with the HSR. It is not intended for screening purposes. In vivo allergy skin tests, 12. Scent modalities. Copyright skin prick test. Analergen solution is applied through a skin prick, example of the volar forearm. Equals first line test for immediate DHRs, safest and easiest. 2-degree scratch test equals analergen is applied to a scratch, 1 centimeter, on the skin. Equals comparable to prick test. Intradermal test equals intradermal injection of small amounts of the allergen equals can be used to diagnose immediate and non-immediate HSRs. Fate equals more sensitive than skin prick test, higher risk of false positives. 12 equals may lead to anaphylaxis in IgE-mediated HSRs. 2. Hypersensitivity blood tests, in vitro. Scent tryptase. Copyright a relatively specific marker of mast cell activation. Copyright elevated levels indicate an increased risk of severe reactions. Scent allergen specific IgE test, SLGE, copyright indicated in patients with known allergic triggers and clinical symptoms. Copyright preferable to skin testing in patients at high risk of anaphylaxis. Copyright quantitatively D using enzyme-linked immunosorbent assay, ELISA, treatment. Treatment of type hypersensitivity reactions depends on the cause of the reaction, see hypersensitivity classification above. Scent drug reactions, remove the offending drug. Severe reactions, emergency resuscitation, see management of anaphylaxis v. Back collapse, fine text outline. Scent drug reactions, remove the offending drug. Severe reactions, emergency resuscitation, see management of anaphylaxis. Moderate reactions, more pronounced urticaria/angioedema, fever, arrhythmia, bronchospasm, antihistamines with or without glucocorticoids. Mild reactions, mild urticaria/angioedema, GI symptoms, tremor, palpitations, headache, cough. Expectant management with or without antihistamines. C. Drug hypersensitivity reactions. Scent emergency self-management for patients with known allergic reactions, epinephrine autoinjectors, antihistamines, Corticosteroids EO anaphylaxis emergency action plan sent urticaria 7.0 avoid trigger, if known. OH receptor blocker, example ketorisen, copyright glucocorticoids. AD, preventative treatment, i.e., contact prevention and avoidance of offending agents, is the most effective form of management for allergies. Allergen immunotherapy, desensitization. Scent indication copyright documented IgE-mediated allergy, example allergic rhinitis, allergic asthma, allergy to wasp or bee venom, copyright significant symptoms and inadequate relief from symptomatic therapy and exposure prophylaxis copyright significant symptoms despite symptomatic therapy and avoidance of the allergen method degree only available for some allergens but can be quite effective copyright application of specific antigen in subclinical dose, subcutaneous, mucosal, copyright slow escalation of dose copyright goal, T. Production of IgG antibodies instead of excessive IgE production, isotype switching, 7 copyright duration of treatment, at least 3 years JE prognosis copyright success in up to % of patients copyright younger patients see comparatively more benefits. O higher success rates in patients with sensitivity to only one allergen, monovalent, as opposed to patients with sensitivity to many allergens, polyvalent. ZO. OOC. Type IL hypersensitivity reaction. Overview. Scent type IL hypersensitivity reactions, or cytotoxic reactions, are antibody-mediated and responsible for a number of autoimmune disorders. Scent clinical features, diagnostics, and treatment depend on the underlying etiology, see hypersensitivity classification above. Asterisk distribution of disease, often limited to a particular tissue type diagnosis may involve autoantibody testing, see antibody diagnosis of autoimmune diseases, and the Coombs test. Pathophysiology. IgM and IgG mistakenly bind to surface antigens of the cells in the body, which results in I-scent cellular destruction O antibody-dependent cell-mediated cytotoxicity, NK cells or macrophages, O target cell opsonization phagocytosis and or complement activation scent inflammation O Phe receptor-mediated immune cell activation copyright antibodies bind to cellular surfaces activation of the complement system scent impaired cellular function O antibodies bind to cell surface receptors. Inhibition or activation of downstream signaling pathways impaired cellular function. Copyright Seer burpenicatun's typhiota and B-type IL is cytotoxic and consists of 2 components, antigen and antibody. Examples: Scent hemolysis O acute hemolytic transfusion reaction O autoimmune hemolytic anemia O hemolytic disease of the newborn. Back collapse fine text outline. Scent systemic disorders O Goodpasture syndrome O rheumatic fever O myasthenia gravis O Graves' disease Scent skin disorders copyright Bullous pemphigoid O pemphigus vulgaris. O. CE. Type IL hypersensitivity reaction. Overview. Scent type IL hypersensitivity reactions, also referred to as immune complex reactions, are antibody-mediated. Asterisk clinical features, diagnostics, and treatment depend on the underlying etiology, see hypersensitivity classification above. Plus distribution of disease, systemic pathophysiology. One antigen, example the molecules of a drug in circulation, binds to IgG to form an immune complex, antigen-antibody complex, I2. Immune complexes are deposited in tissue, especially blood vessels initiation of complement cascade release of lysosomal enzymes from neutrophil cell death inflammation vasculitis. Yie genus dei bara oe. At B to remember type IL, think of 3 things stuck together, antigen plus antibody plus complement. Examples: Scent vasculitis o polyarteritis nodosa o drug-induced hypersensitivity vasculitis scent nephropathy copyright post-streptococcal glomerulonephritis copyright IgA nephropathy o membranous nephropathy scent rheumatoid arthritis scent hypersensitivity pneumonitis, systemic lupus erythematosus, example lupus nephritis, hypertension, thrombosis, scent serum sickness and serum sickness-like reaction scent Arthus reaction. OSOES. 4. Arthus reaction. Overview, 18I19. Scent a local subacute type IL hypersensitivity reaction. Asterisk typically caused by vaccination against tetanus and or diphtheria. 19 Pathophysiology. Intradermal antigen injection in a presensitized individual, previously exposed to the antigen, with preformed, antigen-specific IgG in the serum, formation of antigen-antibody complexes in the skin complement activation local inflammation and possibly necrosis clinical features. Plus cutaneous small vessel vasculitis 9 scent localized swelling, erythema, hemorrhage scent occasional superficial skin necrosis a few hours after booster vaccination scent the reaction typically peaks after 12 to 36 hours. Differential diagnoses, 191. Back collapse fine text outline. Differential diagnoses, 19. Scent injection site reaction unrelated to hypersensitivity abscess scent cellulitis scent shoulder injury related to vaccine administration. Diagnostics, 191I18. Scent increased tetanus and diphtheria antibody levels in the serum support the diagnosis. Asterisk consider skin biopsy to rule out differential diagnoses. 1 degree. Treatment. Scent the reaction is self-limited. Symptomatic relief of swelling, example cold compresses, NSAIDs, limb elevation. Copyright evidence of vasculitis on histology differentiates between a true Arthus reaction and an injection site reaction unrelated to hypersensitivity. 19. WA. CE. Type 4 hypersensitivity reaction. Overview. Scent type 4 hypersensitivity reactions are delayed and cell-mediated. See hypersensitivity classification for the specific causes of type 4 hypersensitivity. Scent clinical features, diagnostics, and treatment depend on the underlying etiology. Pathophysiology. Compared to type I3 hypersensitivity reactions, which are antibody-mediated, type 4 reactions are mediated by T cells. Type 4 hypersensitivity reactions involve two major steps. 1. T cell sensitization, skin penetration by the antigen uptake of the antigen by Langerhans cell migration to lymph nodes formation of sensitized T lymphocytes 2. Presensitized T cell response, after repeated contact with the antigen, copyright CD4 plus T cells recognize antigens on antigen-presenting cells release of inflammatory lymphokine cytokines, example IF New York, TNFA, macrophages activation phagocytosis of target cells degree CD8 plus T cells recognize antigens on somatic cells cell-mediated cytotoxicity direct cell destruction A. QB to remember the specifics of type 4 hypersensitivity reaction, think of the 5 Ts, T cells, transplant rejection, TB skin tests, touching, contact, dermatitis, terminal, last, delayed. Examples. Scent severe cutaneous adverse reactions, SCAR, Odress-O-Stevens-Johnson syndrome, SJS, copyright toxic epidermal necrolysis, 10, copyright acute generalized exanthematous pustulosis, AGEP, A plus exanthematous drug eruption, morbilliform rash on the trunk and proximal extremities /E. Associated symptoms include pruritus and low-grade fever. Copyright typical onset 5 to 14 days after drug exposure. Copyright most commonly caused by antibiotics, example ampicillin rash following ampicillin administration for infectious mononucleosis or resolves after discontinuation of the offending drug. Scent allergic contact dermatitis, Local drug reaction following topical application of drug. Scent skin tests. Copyright Candida skin test, to test the immune function of T cells. Mantotuberculin skin test for latent tuberculosis. Scent systemic disorders. Degree Hashimoto thyroiditis E multiple sclerosis. Copyright type 1 diabetes mellitus E degree 2 ILLIEEE. Back collapse. Find text outline. Scent skin tests. Copyright Candida skin test, to test the immune function of T cells. Mantotuberculin skin test for latent tuberculosis E systemic disorders EO Hashimoto thyroiditis E multiple sclerosis. Copyright type 1 diabetes mellitus. Non-allergic hypersensitivity. Pseudoallergy. Asterisk description, an IgE-independent reaction that is clinically indistinguishable from type hypersensitivity. 1. Scent etiology. O radiocontrast media. O narcotics. O vancomycin, NSAIDs. Scent pathophysiology. O substances cause direct, or complement-mediated in case of anaphylactoid reaction, mast cell activation and subsequent release of histamine not mediated by immunoglobulin. Copyright. In contrast to true anaphylactic reactions, no sensitization to allergens is required, i.e., first contact can already lead to anaphylactic shock. Scent clinical features: urticaria, pruritus, edema, hypotension, or even symptoms of anaphylactic shock. CA. Scent diagnostics. Clinical diagnosis. Scent treatment. Copyright minor reactions equals avoidance of offending drug equals antihistamines for pruritus or urticaria. O pseudoallergy with anaphylactic characteristics. See anaphylaxis. Infection-induced urticaria. Scent etiology. Copyright viral infections, example rotavirus and rhinovirus. Copyright bacterial infections, example Mycoplasma pneumoniae, group streptococcal pharyngitis. O parasitic infections, example Anisakis simplex infection from eating raw fish and Plasmodium falciparum. Scent pathophysiology, mast cell activation and subsequent release of histamine, most likely IgE-independent. A. Scent clinical features, see urticaria. Scent diagnostics, clinical diagnosis based on physical examination and patient history. Scent treatment. O. Usually self-limited. E. Antihistamines may be given for pruritus or urticaria. O. Your notes. Good shared notes. Related 1-minute telegram. Scent 1-minute telegram AD-2023-3/3. The oral pen is as mighty as the needle. Tips and links. Sources. Last updated November 20th, 2023. Back collapse. Find text outline. Euro hypersensitivity reactions, 1/5. Cross-linking degranulation 4 pp. Immediate hypersensitivity reaction. GSNs, 2 inflammatory, equals mediators mast cell or basophil, example histamine. Type hypersensitivity reaction VV. IgE is typically bound to Fc receptors, FCR, on the surface of immune cells, such as mast cells and basophils. Cross-linking of an allergen with the IgE signals the immune cells to degranulate, releasing inflammatory mediators, example histamine, that instantly trigger a hypersensitivity reaction. This is the pathophysiology of type hypersensitivity reactions, example anaphylaxis, food allergies, drug reactions, which can be severe enough to result in anaphylactic shock. Copyright Boss. Hypersensitivity reactions, 2/5. IgM scent is, 2 MAC. Complement lake-dependent reactions. \IgG or C3b antigens, equals IgG or IgM. Complement independent reactions. IgG or IgM. Type IL hypersensitivity reaction. Equals cell lysis Ka. Neutrophil FCR. Age. FCR7Z, K phagocytosis SS2. Phagocyte. Tridarmon. Example macrophage. Pax FER. NK cell A. Apoptosis. Change in signaling cellular dysfunction K. IgM or IgG recognize and bind to specific antigens on the surface of a cell. This antigen-antibody cross-linking activates the complement cascade, resulting in inflammation and a type 2 hypersensitivity reaction, example acute hemolytic transfusion reaction, autoimmune hemolytic anemia. Complement-dependent reactions. Antigen-bound IgM is a potent complement activator and leads to the generation of membrane attack complex, MAC, a terminal product of the complement cascade. MAC creates holes in the cell membrane and causes cytolysis of the antigen-bearing cell. Antigen-bound IgG binds to the Fc receptors, FcR, on the surface of neutrophils and macrophages, inducing cytolysis and phagocytosis respectively. Antigen-bound IgG also activates the complement cascade that generates several activated complement proteins, including C3b that binds to the antigen-bound cell membrane, tagging it to be phagocytosed by macrophages, i.e., opsonization. Camdiamantindin and ractin A. Hypersensitivity reactions, 2/5. I. OMZ7 equals 3 cell lysis copyright K4 MacBoy. Neutrophil FCR, MO, S complement log F% A registered dependent A, C3BD reactions NAD SA, CA, degree, cell lysis 9 plus inflammation equals asterisk. Antigens X __ IgG or C3b, YD /phagocytosis ZAAGAAE 4 pounds inulsati APX, A. 4G _ cent re SASKKOME ya C3BR _ phagocyte A, example macrophage, IgG or IgMA IgCO apoptosis. Asterisk SNK cell complement independent reactions. IgG or IgM change in signaling cellular dysfunction A. VA. Type IL hypersensitivity reaction VB. Complement-dependent reactions. Antigen-bound IgM is a potent complement activator and leads to the generation of membrane attack complex, MAC, a terminal product of the complement cascade. MAC creates holes in the cell membrane and causes cytolysis of the antigen-bearing cell. Antigen-bound IgG binds to the Fc receptors, FcR, on the surface of neutrophils and macrophages, inducing cytolysis and phagocytosis respectively. Antigen-bound IgG also activates the complement cascade that generates several activated complement proteins, including C3b that binds to the antigen-bound cell membrane, tagging it to be phagocytosed by macrophages, i.e., opsonization. Complement-independent reactions. IgG is also involved in complement-independent reactions, such as apoptosis, and along with IgM, altering cellular signaling that leads to cell dysfunction and death. Hypersensitivity reactions, 3/5. Blood vessel. Lysosomal enzymes Bt/7 equals C4, registered C5EI /gel C3A/5 /cent A9 /@/y copyright C3 convertase. Basement membrane. Endothelial cell damaged endothelial cell. Type 3 hypersensitivity reaction BB. Immune complexes, antigen-antibody complexes, are formed in the circulation and get deposited in tissues, preferably within the vascular endothelium, certain organs, example kidney, lung, and the serosal membranes, example synovium, pleura, pericardium. The deposited immune complexes activate the complement cascade, resulting in chemotaxis, recruitment of neutrophils. The antigen-bound IgG bind to the Fc receptors, FcR, on the surface of neutrophils that then release lysosomal enzymes, which damage the local tissues. The site of immune complex deposition determines the clinical features of a type I hypersensitivity reaction, example Arthus reaction, vasculitis, glomerulonephritis, synovitis, pneumonitis. Copyright Boss. Euro hypersensitivity reactions, 4/5. EWE MHCIL equals 7 IEIEX complex chemokines and cytokines FIO degree A, example IF New York, TN5, S.27 E: a macrophages. \YAK. Phagocyte and BAD-J delayed inflammatory response. La CD4 asterisk Th2 cell FSO2 at \OS. 3 LH equals F and LS of 5 degrees 0 UYNRH chemokines and cytokines /% S \plus, example eotaxin, IL5.2 E star. Low underscore, eosinophil NMY. Pran. CD4 mediated type 4 hypersensitivity reaction VV. Type 4 hypersensitivity reactions are mediated by antigen-specific T cells, unlike all other hypersensitivity reactions, which are antibody-mediated. T helper cells, CD4 plus cells, Th cells, mainly act by cytokine-mediated recruitment of inflammatory cells to the site of the target cells. T cell receptors, TCR, present on sensitized CD4 asterisk cells recognize and bind to specific exogenous antigens, example bacteria, viruses. These antigens are bound to the major histocompatibility complex class II, MHC2, a transmembrane protein present on the surface of antigen-presenting cells, like macrophages. Th cells are divided into two subsets based on the cytokines they produce. Bacterial and viral infections predominantly activate Th1 cells, which release cytokines that preferentially recruit neutrophils and macrophages, example IF New York, TN5. Activated macrophages release reactive oxygen species, ROS, and nitric oxide, NO, which aid in the destruction of phagocytosed pathogens. Helminthic or parasitic infections predominantly activate Th2 cells, which release cytokines that preferentially recruit eosinophils, example IL5. Activated eosinophils release major basic protein, MBP, which aids in the destruction of helminths and CE/MHCIIS \PONA\T antigen 1/\n_N VE complex EE chemokines and cytokines +2 to 1 SIAT, example IF New York, TN5.-2 VE star FS macrophages. AQO, delayed WZ inflammatory response. I. Chemokines and cytokines /star. E. Example eotaxin, IL5.2 E star. In ENX, OE eosinophil at __. CD4 mediated type 4 hypersensitivity reaction VV. T cell receptors, TCR, present on sensitized CD4 asterisk cells recognize and bind to specific exogenous antigens, example bacteria, viruses. These antigens are bound to the major histocompatibility complex class II, MHC2, a transmembrane protein present on the surface of antigen-presenting cells, like macrophages. Th cells are divided into two subsets based on the cytokines they produce. Bacterial and viral infections predominantly activate Th1 cells, which release cytokines that preferentially recruit neutrophils and macrophages, example IF New York, TN5. Activated macrophages release reactive oxygen species, ROS, and nitric oxide, NO, which aid in the destruction of phagocytosed pathogens. Helminthic or parasitic infections predominantly activate Th2 cells, which release cytokines that preferentially recruit eosinophils, example IL5. Activated eosinophils release major basic protein, MBP, which aids in the destruction of helminths and signals mast cells to release histamine. Cytokines, ROS, and MBP recruit more inflammatory cells to the site of the reaction and amplify the inflammatory response, which typically becomes evident 48 hours after antigen exposure, i.e., delayed hypersensitivity. Hypersensitivity reactions, 5/5. Granzyme. ill-registered intrinsic P, of 4. CD8 degree T cell / apoptosis TYYZ, XN4YA Re equals FOS CD8, TCR extrinsic pathway -at. Delayed 8 \MHC class, \Epepius inflammatory antigen, XV signal at response complex at virus and /wo, _crop MDA at cytokines -- EBAD _ FNUEA infected cell and 33333. \cytokine release EOP. CJ viral replication TMHC class. CD8 mediated type 4 hypersensitivity reaction VV. Type 4 hypersensitivity reactions are mediated by antigen-specific T cells, unlike all other hypersensitivity reactions, which are antibody-mediated. The cytotoxic T cells, CD8* T cell, mainly act by inducing apoptosis of the target cell. T cell receptors, TCR, located on sensitized CD8* T cells recognize and bind to endogenously synthesized antigens, typically viral antigens, that are bound to the major histocompatibility complex class, MHC1, a transmembrane protein present on the surface of nucleated cells and platelets. CD8* T cells binding to the antigen stimulates two signaling pathways. These pathways result in apoptosis of the infected cell by activating the intracellular caspase enzymes and destroying intracellular pathogens in the process. Intrinsic pathway, main pathway CD8* T cells release protease granules, granzyme, perforin, into the infected cell and induce apoptosis. Extrinsic pathway, FOS ligand, FASL, present on CD8* T cells bind to FOS receptors on the target cells and induce apoptosis. SADA-ES. Hypersensitivity reactions, 5/5. CD8 degree T cell. Granzyme YY perforin. EEE intrinsic EO at.
Are you nervous about an important
apoptosis
exam?
_
We created this short
PFU
dose
at
of
\YY registered 7 and 2 /FOS L equals a FOS YACOS, ATCR equals extrinsic pathway sent J _ delayed MHC class, 5 equals A8 inflammatory antigen. X / signal copyright response complex at virus as head OE cytokines, ISEES, BCD4 of TNF opto, EADUEOEOEA infected cell, AG33E. \cytokine release. DOE at OO. JJ viral replication TMHC class. CD8 mediated type 4 hypersensitivity reaction VV. T cell receptors, TCR, located on sensitized CD8* T cells recognize and bind to endogenously synthesized antigens, typically viral antigens, that are bound to the major histocompatibility complex class, MHC1, a transmembrane protein present on the surface of nucleated cells and platelets. CD8* T cells binding to the antigen stimulates two signaling pathways. These pathways result in apoptosis of the infected cell by activating the intracellular caspase enzymes and destroying intracellular pathogens in the process. Intrinsic pathway, main pathway CD8* T cells release protease granules, granzyme, perforin, into the infected cell and induce apoptosis. Extrinsic pathway, FOS ligand, FASL, present on CD8* T cells bind to FOS receptors on the target cells and induce apoptosis. Cytokine pathway, activated CD8* T cells also release cytokines that decrease viral replication and increase the expression of MHC to amplify the detection of antigens. Cytokines also recruit macrophages to the site of the reaction, inducing an inflammatory reaction that typically becomes evident 48 hours after antigen exposure, i.e., delayed hypersensitivity. Euro-hypersensitivity reactions, 110. Cross-linking degranulation, \, IMPP. Immediate hypersensitivity reaction. GSNs, 2 inflammatory, equals mediators mast cell or basophil, example histamine. Type hypersensitivity reaction BV. IgE is typically bound to Fc receptors, FCR, on the surface of immune cells, such as mast cells and basophils. Cross-linking of an allergen with the IgE signals the immune cells to degranulate, releasing inflammatory mediators, example histamine, that instantly trigger a hypersensitivity reaction. This is the pathophysiology of type hypersensitivity reactions, example anaphylaxis, food allergies, drug reactions, which can be severe enough to result in anaphylactic shock. Copyright on BOSS. Euro hypersensitivity reactions, 2/10. Urticaria of EV. Anterior upper body of a man presenting with a pruritic rash after consuming peanuts. Multiple well-defined, raised, erythematous plaques of varying sizes are visible on the upper left abdomen and inner arm. The largest lesion on the trunk shows central clearing. This is the typical appearance of urticaria, hives, a type hypersensitivity reaction that appears immediately after exposure to an antigen and disappears within a few days. Our great thanks to Milena Korang for kindly providing this image. Euro hypersensitivity reactions, 3/10. Urticaria of EV. Well circumscribed, partially confluent erythematous lesions are visible on the torso and limbs. This is the typical presentation of urticaria, hives, a type hypersensitivity reaction that appears immediately after exposure to an antigen and disappears within a few days. Copyright on BOSS. Euro hypersensitivity reactions, 4/10. Urticaria of EV. Multiple well-defined erythematous, partially confluent lesions with raised serpiginous borders and central clearing are visible. This is the characteristic appearance of urticaria, which typically has an acute onset, is highly pruritic, and transient. Source, copyright IMPP. Euro hypersensitivity reactions, 5/10. Cholinergic urticaria of EV. Multiple small, well-defined papules, wheals, surrounded by slight erythema are visible on this patient's arm. Source, cholinergic urticaria.jpg by Clope62, Wikimedia Commons, licensed under CC by SA 3.0. Euro hypersensitivity reactions, 6/10. Urticaria, hives, v. Multiple annular, erythematous, well-demarcated, slightly elevated plaques are visible. This appearance is consistent with urticaria. Urticaria appears soon after exposure to an antigen and disappears within a few hours. The lesions are caused by mast cell degranulation in the superficial dermis. Our great thanks to Milena Korang for kindly providing this image. Euro hypersensitivity reactions, 7/10. 1 loss of lateral 1/3 of eyebrows, urtica sign. Atopy. Etiology: genetic predisposition to IgE-mediated allergic conjunctivitis. Hypersensitivity reactions: environmental factors, example pollen, mites, psychosocial stress / Epidemiology: onset, typically in infancy or early childhood. Allergic rhinitis prevalence, 10 to 15%. Denny Morgan fold. Plus periorbital dark circles. White dermographism. Complications: food allergies, stigmata. Allergic march, secondary infections, urticaria, pruritus, asthma attacks, anaphylaxis, flushing, mucosal edema, note nausea, diarrhea triggers, animal and plant allergens, medications, psychological stress. Allergic bronchial, allergic dermatitis, asthma. Atopy fact sheet BV. Copyright on BOSS. Equals hypersensitivity reactions, 8/10. Papular urticaria V. Multiple well-circumscribed, oval, erythematous papules are disseminated over large parts of this child's skin. The lesions are surrounded by a wheal and occur in groups or clusters. These findings should not be mistaken for a subtype of urticaria but represent a persistent reaction to insect bites. Source: Figure 62b, in Atlas of Pediatric HIV Infection by Regina E. Oladikan, Raniko J. Leloania, Carol Hlila et.al. Open Books, licensed under CC by ND 4.0. Euro hypersensitivity reactions, 9/10. I. Skin prick test. Yeti IE, Y equals AE. B. /2 ////3 a YY3 VUY, 3C7/ALAYD. E/G ///GCGCG, or we or. Prick test scratch test intradermal test. 4-5 TTT plus, 15 to 20 minutes at, control. The test is positive if the allergen wheel is the same size or larger than the positive histamine control or 3 mm in diameter. The plus sign indicates the position of the positive control using a histamine-containing solution, which always provokes a response. The minus sign symbolizes the negative control using a saline solution. The various allergens to be tested are applied in position 1 and 2. The skin is then pierced using a thin lancet and the test is evaluated after 15 to 20 minutes. Copyright Boss. Hypersensitivity reactions, 10/10. Positive skin prick test. There is no reaction associated with the negative control, minus sign on the left side, and a definitive allergic reaction associated with the positive control, plus sign on the right side, which means the test is valid. 4 allergens were applied in the spots indicated, and the skin subsequently pierced with the lancet. Approximate 20 minutes later, a wheal and reddening developed at the top left position, where a peanut allergen had been applied. This test therefore indicates a type hypersensitivity reaction to peanuts. Source: Allergic to Peanuts by Lance Fisher, Flickr, licensed under CC by SA 2.0. Hypersensitivity reactions, 1/1. IgM scent is, 2 MAC. Complement lake-dependent reactions. \IgG or C3b antigens, equals. IgG or IgM. Complement independent reactions. IgG or IgM. Type IL hypersensitivity reaction. Equals cell lysis Ka. Neutrophil FCR. H. FCR7Z, K phagocytosis SS2. Phagocyte. Tridarmon. Example macrophage. Pax FER. NK cell A. Apoptosis. Change in signaling cellular dysfunction K. IgM or IgG recognize and bind to specific antigens on the surface of a cell. This antigen-antibody cross-linking activates the complement cascade, resulting in inflammation and a type 2 hypersensitivity reaction. Example: acute hemolytic transfusion reaction, autoimmune hemolytic anemia. Complement-dependent reactions. Antigen-bound IgM is a potent complement activator and leads to the generation of membrane attack complex, MAC, a terminal product of the complement cascade. MAC creates holes in the cell membrane and causes cytolysis of the antigen-bearing cell. Antigen-bound IgG binds to the Fc receptors, FCR, on the surface of neutrophils and macrophages, inducing cytolysis and phagocytosis respectively. Antigen-bound IgG also activates the complement cascade that generates several activated complement proteins, including C3b that binds to the antigen-bound cell membrane, tagging it to be phagocytosed by macrophages, i.e., opsonization. Camniamantindinandant ractin A. Hypersensitivity reactions, 1/1. T. OMZ7 equals 3 cell lysis copyright K/MacPoid. Neutrophil FCR3 equals asterisk of SE complement IgG F4 row, a dependent A at E reaction CIAD at SA, CA, degree, cell lysis 9 plus inflammation AIESD. TA equals FCR antigens, backslash. IgG or C3b, PL phagocytosis, AA nata slash QAADX. X% backslash. YKKE. C3BR underscore backslash. Phagocyte via, example macrophage, IgG or IgMA. GT apoptosis P-apoptosis XECR. SSNK cell complement independent reactions. IgG or IgM change in signaling cellular dysfunction KKVA. Type IL hypersensitivity reaction VV. Complement-dependent reactions. Antigen-bound IgM is a potent complement activator and leads to the generation of membrane attack complex, MAC, a terminal product of the complement cascade. MAC creates holes in the cell membrane and causes cytolysis of the antigen-bearing cell. Antigen-bound IgG binds to the Phe receptors, FCR, on the surface of neutrophils and macrophages, inducing cytolysis and phagocytosis respectively. Antigen-bound IgG also activates the complement cascade that generates several activated complement proteins, including C3b that binds to the antigen-bound cell membrane, tagging it to be phagocytosed by macrophages, i.e., opsonization. Complement-independent reactions. IgG is also involved in complement-independent reactions, such as apoptosis, and along with IgM, altering cellular signaling that leads to cell dysfunction and death. Aerating. Urohypersensitivity reactions, 1/1. Blood vessel. Lysosomal enzymes Bt7 equals C4, registered C5EI gel C3A/5/cent A9 //at/Y copyright C3 convertase. Basement membrane. Endothelial cell damaged endothelial cell. Type 3 hypersensitivity reaction VV. Immune complexes, antigen-antibody complexes, are formed in the circulation and get deposited in tissues, preferably within the vascular endothelium, certain organs, example kidney, lung, and the serosal membranes, example synovium, pleura, pericardium. The deposited immune complexes activate the complement cascade, resulting in chemotaxis, recruitment of neutrophils. The antigen-bound IgG bind to the Fc receptors, FCR, on the surface of neutrophils that then release lysosomal enzymes, which damage the local tissues. The site of immune complex deposition determines the clinical features of a type I hypersensitivity reaction, example Arthus reaction, vasculitis, glomerulonephritis, synovitis, pneumonitis. Copyright Boss. Urohypersensitivity reactions, 1A. EWMHCIL equals 7 IEIEX complex chemokines and cytokines Pho degree A, example IF New York, TN5, S.27 E: a macrophages. \YAK. Phagocyte and VAD-J delayed inflammatory response. Law CD4 *TH2 cell FSO2 at \OS. 3 LH equals F and LS of 5 degrees 0 UYNRH chemokines and cytokines %S \plus, example eataxin, IL5.2 E star. Low underscore, eosinophil NMY. Fran. CD4 mediated type 4 hypersensitivity reaction VV. Type 4 hypersensitivity reactions are mediated by antigen-specific T cells, unlike all other hypersensitivity reactions, which are antibody-mediated. T helper cells, CD4 plus cells, TH cells, mainly act by cytokine-mediated recruitment of inflammatory cells to the site of the target cells. T cell receptors, TCR, present on sensitized CD4* cells recognize and bind to specific exogenous antigens, example bacteria, viruses. These antigens are bound to the major histocompatibility complex class II. MHC2, a transmembrane protein present on the surface of antigen-presenting cells, like macrophages. Th cells are divided into two subsets based on the cytokines they produce. Bacterial and viral infections predominantly activate Th1 cells, which release cytokines that preferentially recruit neutrophils and macrophages, example IF New York, TNFA. Activated macrophages release reactive oxygen species, ROS, and nitric oxide, NO, which aid in the destruction of phagocytosed pathogens. Helminthic or parasitic infections predominantly activate Th2 cells, which release cytokines that preferentially recruit eosinophils, example IL-5. Activated eosinophils release major basic protein, MBP, which aids in the destruction of helminths and Euro-hypersensitivity reactions, 1/8. CD4 T cell plus, EEDIES. Wes*OEYROS, no PS. VE/WIMHC it copyright at L antigen 7% VOWS EOS AE equals chemokines and cytokines, IE 8°, example IF New York, TNFA, /IEAE macrophages. YS//FIG, 4X, delayed inflammatory response. CD4*_Th2 cellin, F7. EE equals 07 at copyright set. DQOFEVIATF, B-+6U yet. Chemokines and Felt, ISA, example eotaxin, IL-5.SE*, eosinophil. CD4-mediated type 4 hypersensitivity reaction VV. Viruses. These antigens are bound to the major histocompatibility complex class II, MHC2, a transmembrane protein present on the surface of antigen-presenting cells, like macrophages. Th cells are divided into two subsets based on the cytokines they produce. Bacterial and viral infections predominantly activate Th1 cells, which release cytokines that preferentially recruit neutrophils and macrophages, example IF New York, TNFA. Activated macrophages release reactive oxygen species, ROS, and nitric oxide, NO, which aid in the destruction of phagocytosed pathogens. Helminthic or parasitic infections predominantly activate Th2 cells, which release cytokines that preferentially recruit eosinophils, example IL-5. Activated eosinophils release major basic protein, MBP, which aids in the destruction of helminths and signals mast cells to release histamine. Cytokines, ROS, and MBP recruit more inflammatory cells to the site of the reaction and amplify the inflammatory response, which typically becomes evident 48 hours after antigen exposure, i.e., delayed hypersensitivity. MAEANNCE. Hypersensitivity reactions, 2/8. Granzyme. Gill-registered intrinsic P, a 4. CD8° T cell //apoptosis /TYYZ, XN4YA Re equals Fa CD8, TCR extrinsic pathway -at. Delayed 8/MHC class, /Epepius inflammatory antigen, XV signal at response complex at virus and /WO, _CROF MDA at cytokines -- EBAD _ FNUEA infected cell and 33333. /cytokine release EOP. CJ viral replication TMHC class. CD8 mediated type 4 hypersensitivity reaction VV. Type 4 hypersensitivity reactions are mediated by antigen-specific T cells, unlike all other hypersensitivity reactions, which are antibody-mediated. The cytotoxic T cells, CD8* T cell, mainly act by inducing apoptosis of the target cell. T cell receptors, TCR, located on sensitized CD8* T cells recognize and bind to endogenously synthesized antigens, typically viral antigens, that are bound to the major histocompatibility complex class, MHC1, a transmembrane protein present on the surface of nucleated cells and platelets. CD8 T cells binding to the antigen stimulates two signaling pathways. These pathways result in apoptosis of the infected cell by activating the intracellular caspase enzymes and destroying intracellular pathogens in the process. Intrinsic pathway, main pathway CD8 T cells release protease granules, granzyme, perforin, into the infected cell and induce apoptosis. Extrinsic pathway, Fos ligand, FASL, present on CD8 T cells bind to Fos receptors on the target cells and induce apoptosis. SADA-ES. Urohypersensitivity reactions, 2/8. Granzyme perforin ESKN. E intrinsic EA. CD8 degree T cell. /apoptosis IJY. /X7ETI at copyright at /YO /EFOS LSAT equals AFOS *COS at TCR, extrinsic pathway for co-EE delayed MHC class, 5-1 REA8 need inflammatory antigen, signal copyright response complex, at virus % and Y. And at infected cell. Cytokines IFN, TNFA, LTA, 6, 8. M/cytokine release C, ACR J viral replication T MHC class. CD8 mediated type 4 hypersensitivity reaction VV. Viral antigens, that are bound to the major histocompatibility complex class, MHC1, a transmembrane protein present on the surface of nucleated cells and platelets. CD8 T cells binding to the antigen stimulates two signaling pathways. These pathways result in apoptosis of the infected cell by activating the intracellular caspase enzymes and destroying intracellular pathogens in the process. Intrinsic pathway, main pathway CD8 T cells release protease granules, granzyme, perforin, into the infected cell and induce apoptosis. Extrinsic pathway, Fos ligand, FASL, present on CD8 T cells bind to Fos receptors on the target cells and induce apoptosis. Cytokine pathway, activated CD8 T cells also release cytokines that decrease viral replication and increase the expression of MHC to amplify the detection of antigens. Cytokines also recruit macrophages to the site of the reaction, inducing an inflammatory reaction that typically becomes evident 48 hours after antigen exposure, i.e., delayed hypersensitivity. Copyright on BOS. Acute generalized exanthematous pustulosis, AGEP, VV. Upper body of a child with a severe cutaneous drug reaction. The entire chest is covered with small, non-follicular, and partially confluent pustules. The surrounding skin is erythematous. Acute onset of these findings in combination with fever and neutrophilia is characteristic of AGEP. Source, Fig 2c, in A Comprehensive Review of HLA and Severe Cutaneous Adverse Drug Reactions, Implication for Clinical Pharmacogenomics and Precision Medicine by Kloipan C, Cum D.N., Satapornpung PETAL, MDPI, licensed under CC by 4.0. Modifications, image cropped. Urohypersensitivity reactions, 4/8. Drug eruption, 1/2, VV. Ventral upper body of a patient presenting with a pruritic rash following the administration of amoxicillin. A diffuse rash composed of several fine erythematous papules is visible. This rash, known as a morbilliform rash because it resembles the rash seen in measles, is typical of a drug reaction. Copyright on BOS. Urohypersensitivity reactions, 5/8. Drug eruption, 2/2. Dorsal upper body of a patient presenting with a pruritic rash following the administration of amoxicillin. A diffuse rash composed of several fine erythematous papules is visible. This rash, known as a morbilliform rash because it resembles the rash seen in measles, is typical of a drug reaction. Copyright Boss. Drug eruption VV. Patient presenting A with pruritic rash following the administration of an iodine-containing drug. A morbilliform rash with areas of post-inflammatory hyperpigmentation is visible over the gluteal region and posterior aspect of the thighs. The medical history and characteristic features of this rash indicate a type 4 hypersensitivity reaction to the drug. Source: ID #14796, Susan Lindsley, Centers for Disease Control and Prevention, CDC, licensed under public domain. Euro hypersensitivity reactions, 7/8. Drug eruption. Fissures, partial scaling, and erosions are visible on the right palm of this patient. Ciprofloxacin had been administered 2 days previously. The finding and patient history indicate a type 4 hypersensitivity reaction to the drug. Source: Exanthem by Klaus D. Peter, Wikimedia Commons, licensed under CC by 3.0. Hypersensitivity reactions, 8/8. Morbilliform drug eruption VV. Trunk and arm show widely disseminated erythematous macules, which partly merge into larger patches. These findings are typical for a drug-induced hypersensitivity reaction and usually occur after 5 to 12 days of exposure to the offending drug. The eruptions usually resolve after discontinuation of therapy. Source: Figure 87, Morbilliform rash, in Atlas of Pediatric HIV Infection by Oladikin Re, Leloanya RJ, Halila CETAL, Open Books, licensed under CC by ND 4.0. Allergic contact dermatitis. Allergic contact dermatitis is a common inflammatory condition that is characterized by erythema and pruritus at the site of exposure to an allergen. Common allergens include nickel, personal care products such as fragrances and cosmetics, topical medications, and plants. The underlying pathophysiology is a type 4, T-cell mediated delayed hypersensitivity reaction to the allergen. It is more common in women than men and impacts around 20% of the general population. Diagnosis is usually clinical, although patch testing is considered the gold standard and can be utilized if the causative allergen is unclear. Avoidance of allergen exposure is the mainstay of therapy. Topical corticosteroids and symptomatic therapy, example with calamine lotion and emollients, are used to provide acute relief. FO and epidemiology. 15 to 20% of adults have a contact allergy to one allergen. 2 LTS 259,783. Allergic contact dermatitis is one of the most common dermatological diagnoses and its prevalence is increasing worldwide. 2. Epidemiological data refers to the U.S., unless otherwise specified. 07 CE. Etiology. Common allergens /4LL5. Plus metals, nickel, J, cobalt, chromium, scent personal care products, perfumes, soaps, cosmetics, ** plants, poison ivy, poison oak, poison sumac ** occupational, gloves, solvents, detergents * preservatives, example thimerosal, * topical medications, hydrocortisone, topical antibiotics, example neomycin, benzocaine 14 risk factors 227. Scent congenital risk factors, certain genetic polymorphisms * acquired risk factors, other forms of dermatitis, example atopic dermatitis, occupational exposures ZGUCE. Pathophysiology 6. Allergic contact dermatitis is an example of a type 4 hypersensitivity reaction. Scent first contact with allergen sensitization, repeated contact with allergen, development of a rash after 12 to 48 hours. Compared to type I3 hypersensitivity reactions, which are antibody mediated, Type 4 reactions are mediated by T cells. WACE. Clinical features. Asterisk characteristics of lesions. 6.0 Intensely pruritic erythematous papules. Copyright vesicles with serous oozing in more severe cases. Copyright distinct borders that correspond to the site and extent of exposure. Scent distribution. Copyright local, reflects areas and shapes of exposures. Examples include, equals rash where jewelry is worn, suggests nickel allergy. Equals rash on face and eyelids, likely caused by cosmetics. Back collapse. Fine text outline. Equals rash in axillae, likely caused by fragrances or deodorant. Equals pruritic papulovesicular rash with a linear pattern on extremities, likely caused by urushiol-producing plants like poison ivy in patients with a history of exposure, urushiol-induced contact dermatitis. Copyright ectopic, lesions at a distance from initial exposure due to inadvertent transfer of allergen by self or others. Copyright contact dermatitis due to poison oak, poison ivy, or poison sumac is the most likely cause in a patient presenting with erythematous, pruritic, and burning skin lesions in a linear pattern that appear 24 hours after a camping trip. OD your note a registered shared Notmanig. Diagnostics. Approach 61. Scent suspect allergic contact dermatitis in patients with pruritic lesions in well-demarcated areas of exposure. Scent review the patient's use of personal products as well as their home and work environment to determine the likely allergen. M70 cause is evident, start management empirically. A copyright cause is unclear or lesions do not resolve with empiric management, consider referral to an allergist or dermatologist for further evaluation. Allergic contact dermatitis is primarily a clinical diagnosis. Diagnostic studies may be required in certain cases. Patch test, 81. Scent indications. Copyright uncertain clinical diagnosis. Copyright inadequate response to empiric management. Copyright suspected contact dermatitis in children. 7 Scent procedure. A series of patches fixed with common allergens are applied directly to the skin. In O results are commonly read at 48 hours. 119 ILS. Scent interpretation. A positive reaction consists of erythema, papules, and, sometimes, vesicles at the site of the patch, ES. 9. OO shared notes manage. Differential diagnoses. 6 IL 71. Irritant contact dermatitis. See irritant versus allergic contact dermatitis, atopic dermatitis, seborrheic dermatitis, dyshydrotic eczema, is psoriasis, scabies, tinea-pedis, 1I dermatitis, herpetiformis, M mycosis, fungoids, cutaneous T-cell lymphoma, AA. Back collapse. Fine text outline. Copyright suspected contact dermatitis in children. 7 Scent procedure. A series of patches fixed with common allergens are applied directly to the skin. IO results are commonly read at 48 hours. 1A, ILS, Scent interpretation. A positive reaction consists of erythema, papules, and, sometimes, vesicles at the site of the patch, ES. 9. Differential diagnoses, L7. Irritant contact dermatitis, see irritant versus allergic contact dermatitis, atopic dermatitis 2%, seborrheic dermatitis, dyshydrotic eczema, ES psoriasis, scabies, tinea-pedis, 2is dermatitis, herpetiformis, I mycosis, fungoids, cutaneous T-cell lymphoma, 1 ANA. The differential diagnoses listed here are not exhaustive. OO your EE shared notes. Treatment. Avoidance of exposure to allergens is the mainstay of management for allergic contact dermatitis. In addition, the following adjunctive measures should be initiated for acute relief. 61 L7 Scent symptomatic therapy. Copyright cool compresses. Copyright calamine lotion, emollients, colloidal oatmeal baths. O wet dressings, example for oozing, crusting lesions. Scent corticosteroids. Copyright topical corticosteroids are preferred for localized dermatitis. 7 equals initial treatment, mid-potency topical steroid, example triamcinolone. I6 equals no clinical improvement, escalate to a high-potency topical steroid, example clobetasol. 6. Copyright consider systemic steroids, example prednisone. 6 equals if 20% of the body surface area is affected. I equals or if rapid relief is desired, example involvement of the face and eyelids. Scent treatment of bacterial and fungal superinfections, see impetigo and treatment of mucocutaneous candidiasis as needed. Antihistamines, though commonly used, are generally not effective for treating pruritus associated with allergic contact dermatitis. See your notes. 4 shared notes. Tips and links. Sources. Last updated November 10, 2023. Back collapse fine text outline. Uroallergic contact dermatitis, 1/6. Urushiol-induced contact dermatitis VV. An erythematous rash with numerous small vesicles in a linear pattern can be seen on the left forearm. This rash is typical of mild allergic contact dermatitis caused by urushiol-containing plants, example poison oak. In more severe cases, bullae and pronounced edema may be present. Source: 4484, CDC, Centers for Disease Control and Prevention, Atlanta, USA. Licensed under public domain. Urushiol-induced contact dermatitis VV. Legs of Aman presenting with a pruritic rash 3 days after skin contact with poison ivy. A streaky erythematous blistering rash using a serous discharge is visible predominantly on the anterior aspect of the right leg. There is significant edema of the right leg and foot. A few streaks of the rash are visible on the anterior aspect of the left leg as well. This is the typical appearance of urushiol-induced contact dermatitis, which typically occurs 1 to 3 days after contact with urushiol-containing plants, example poison ivy, poison oak. The rash is characteristically streaky as a result of the poison-containing leaves brushing against the skin. Source: Poison ivy with swelling by Itirv, Wikimedia Commons, licensed under CC by SA 3.0. Eczema VV. Eczema as seen in contact dermatitis or atopic dermatitis is visible on the back of the right hand. Source: Copyright IMPP. Allergic contact dermatitis, 4/6. Allergic contact dermatitis V. Upper body of a man presenting with a severely pruritic rash after getting a henna tattoo on the right arm. An erythematous papulovesicular rash is visible over the chest and arms. The rash is most severe around the henna tattoo, which appears markedly erythematous. This is the typical appearance of allergic contact dermatitis. Source: Copyright IMPP. Uroallergic contact dermatitis, 5/6. Allergic contact dermatitis VV. Marked erythema and streaky, indurated plaques with numerous oozing vesicles and bullae are visible on the back of the hand. The appearance and, especially, the pattern of the lesion are typical of allergic contact dermatitis. Source: courtesy of Dr. Gary M. White MD. Uroallergic contact dermatitis, 6/6. Allergic contact dermatitis. Marked redness and swelling with plaques as well as crust formation are visible on the palmar surface of the left hand. Palmar localization and sharp demarcation of redness at the wrist suggest, potentially occupational, allergic contact dermatitis. Source: Copyright IMPP. Patch test VV. Multiple patches containing potential allergens have been applied to the patient's back. Source: Epicutiny test by Jan Polak, Wikimedia Commons, licensed under CC by SA 3.0. Nickel patch test VV. Mouth of a patient after a nickel oral mucosa patch test. The upper lip shows a circular, whitish spot, which is a local reaction to the previously applied nickel patch. Source: Fig 3b, in, beneficial effects of a low-nickel diet on relapsing IBS-like and extra-intestinal symptoms of celiac patients during a proper gluten-free diet, nickel allergic contact mucositis in suspected non-responsive celiac disease by Borghini R., De Amicis N., Bella Aetal, MDPI, licensed under CC by 4.0. Modifications, image cropped and removal of the B. Atopic dermatitis VV. /LL defined, erythematous macules with excoriation, due to scratching, can be seen on the flexural surface of the knee. Source, copyright IMPP. Seborrheic dermatitis, chest, VV. Chest of a male patient with dark red, sharply demarcated, confluent erythema with fine scaling between and underneath the breasts. Typically accompanied by strong pruritus. Source, courtesy of Dr. Gary M. White MD. Dyshydrotic eczema VV. Multiple vesicles with an erythematous base are visible on the finger. These findings are suggestive of dyshydrotic eczema. Source, Finger Pomphalix 1 by Maslasha, Wikimedia Commons, licensed under CC by SA 3.0. Uroallergic contact dermatitis, 4/8. Yearwad Fe Reneset. Pa, Ra teg Ro my Fe equals AEB 5 Tima equals E, CAS di. Plaque psoriasis. Multiple sharply demarcated confluent plaques covered with hard, coarse, silver-white scaling are visible over the extensor surface of the knee. This is the characteristic appearance of plaque psoriasis. Source, copyright IMPP. Interdigital skin lesions in scabies. Multiple erythematous papules can be seen in the interdigital folds between the index and middle finger. Interdigital folds are a common site for scabies, as the scabies mite prefers warmer skin regions with a thin keratinous layer. Source, ID hashtag 15831, CDC/J Pledger, Centers for Disease Control and Prevention, CDC, licensed under public domain. Uroallergic contact dermatitis, 6/8. Tinnitus, athlete's foot. Plantar view of the left foot showing skin peeling in the region of the forefoot, which gives it a blistered appearance. The erythematous base appears dry and scaly. This finding is due to a dermatophyte infection, tinnitus. Source, courtesy of Dr. Gary M. White MD. Uroallergic contact dermatitis, 7. Dermatitis herpetiformis. Grouped, erythematous, papulovesicular lesions that are partially excoriated, presumably due to pruritus, can be seen on the dorsal forearm. Source, copyright IMPP. Cutaneous T-cell lymphoma. Multiple partially confluent, sharply demarcated, erythematous, scaling plaques are visible on this patient's flank. This appearance is suggestive of cutaneous lymphoma. Source, copyright IMPP. IgA vasculitis. IgA vasculitis, IgAV, previously referred to as Henoch-Schönlein purpura, HSP, is an acute immune complex-mediated small vessel vasculitis that most commonly occurs in children. Onset is often preceded by an upper respiratory tract or gastrointestinal infection. IgAV in adults may be idiopathic. Affected individuals typically develop palpable purpura, arthritis, and/or arthralgia, and abdominal pain. Renal involvement, i.e., IgAV nephritis, is more common and usually more severe in adults than in children, typically manifesting with hematuria. While IgAV is a clinical diagnosis, laboratory studies are used to identify organ involvement and exclude differential diagnoses, and skin biopsy can confirm the diagnosis in patients with atypical presentations. IgAV is usually self-limited, treatment is generally supportive. Systemic Glucocorticoids may be required depending on severity of manifestations, example in IgAV nephritis, or orchitis. IgAV has an excellent prognosis in children, usually resolving within 1 month when not complicated by IgAV nephritis. Adults often manifest with more severe features and have lower remission rates. All patients require follow-up assessments to rule out the development of chronic renal disease. WA. CE. Epidemiology. Degree sex, 7 to age, more common in children. Copyright 90% of affected individuals. OS. CE. Etiology. The exact pathogenesis is unknown and assumed to be multifactorial. Factors that likely play a role include, scent preceding infection. Up to 90% of cases are preceded by viral or bacterial infection 1 to 3 weeks prior. 3. Most commonly an upper respiratory tract infection caused by group A Streptococcus. 4. Copyright GL infections also possible. Many other organisms have also been associated with IgAV. IgA nephropathy. Scent drugs, example ACE inhibitors, clarithromycin, and vaccines. Scent genetic predisposition. Scent solid organ malignancies, in adults. 5. WA. Fe. Ho. Pathophysiology. Hypothesized pathophysiological mechanism, exposure to allergen/antigen, example infection, drugs, stimulation of IgA production, deposition of IgA immune complexes in vascular walls, example in the skin, GL tract, joints, kidneys, activation of complement vascular inflammation and damage. OSOE. Clinical features. An upper respiratory tract infection often precedes symptom onset by 1 to 3 weeks. 3. Constitutional symptoms, low-grade fever, malaise, fatigue plus skin, 100% of cases, D%. 6. LEO symmetrically distributed erythematous papules or urticarial lesions that coalesce into palpable purpura, ebuli, pustules, and necrotic or hemorrhagic purpura, more common in adults. 5. OE most commonly in the lower extremities, buttocks, and other areas of pressure or constraint, example from clothing. Back collapse. Fine text outline. Joints, 75% of cases. 7. Arthritis/arthralgia, most commonly in the ankles and knees. Scent gastrointestinal tract, 60% of cases. 7. Copyright colicky. Abdominal pain, degree intussusception. 1. Hematochezia or melena. Nausea and/or vomiting plus kidneys, IgAV nephritis, 20 to 50% of children, 50 to 80% of adults, is nephritic syndrome. Copyright see also IgA nephropathy. Other organs, rare, copyright genitourinary tract, example epididymo-orchitis, urethritis, copyright central and peripheral nervous system, example headaches, seizures, intracerebral hemorrhage, copyright respiratory tract, example mild interstitial changes, alveolar hemorrhage, copyright eyes, example episcleritis, uveitis. Copyright IgAV is characterized by PAPA, purpura, abdominal pain, arthritis/arthralgia, and hematuria. Copyright IgAV is an important differential diagnosis to consider in children with a limp. Copyright IgAV is much less common but typically more severe, example involving hemorrhagic or necrotic skin lesions, IgAV nephritis, in adults than in children. Is. Diagnostics. Approaches CI 7-10. Scent pediatric and adult patients make a clinical diagnosis of IgAV based on typical clinical features. Copyright obtain laboratory studies to identify organ involvement and exclude alternative diagnoses. Degree if the diagnosis remains unclear, confirmatory biopsy. Copyright suspect IgA vasculitis in any patient with palpable purpura, arthralgia, and abdominal pain. 7. Laboratory studies M1, 7-5. Obtain the following studies in all patients to assess for renal and GI involvement, plus CBC. O. Usually normal platelet count, E. Hemoglobin suggests GI bleeding. BMP, 7 creatinine and/or T-bun suggest IgAV nephritis scent coagulation panel, typically normal, AE urine, may be normal, abnormal values suggest IgAV nephritis copyright urinalysis, first sample of the day hematuria, proteinuria copyright microscopy, nephritic sediment, E.G, RBC casts, dysmorphic RBCs, plus stool blood test, positive if there is GI bleeding. Additional laboratory studies. The following studies may support the diagnosis of IgAV but are not required in the diagnostic workup. +1 ESR, CRP if preceding streptococcal infection, copyright hypocomplementemia, 3, OT anti-streptolysin O, ASO, titers, 4, plus TIGN serum and imaging/1L5. Back collapse find text. O. Outline. Imaging, 91I5. Imaging studies should be obtained according to the patient's symptoms and/or suspected complications. Plus abdominal ultrasound, indicated in patients with abdominal pain to evaluate for intussusception. 6. Intussusception is the most common complication of IgAV requiring surgery in children. 9. Biopsy, 1L8. Histology from the skin and/or kidney confirms the diagnosis of IgAV. 8. Scent skin copyright indications, atypical skin features E findings leukocytoclastic vasculitis A IgA and C3 complex deposition, hallmark, in small vessels of the superficial dermis 3E kidney copyright indications, severe renal involvement, 1L14 copyright findings equals mesangial IgA deposition equals C3 and fibrin equals crescent formation in more severe cases A. Differential diagnoses. Differential diagnosis of IgAV based on clinical features. Clinical feature of IgAV differential diagnosis hypersensitivity vasculitis. Small vessel vasculitides such as copyright granulomatosis with polyangiitis, copyright eosinophilic granulomatosis with polyangiitis E, microscopic polyangiitis, copyright systemic lupus erythematosus, SLE, purpura 7 coagulopathies, example hemophilia A. Immune thrombocytopenia, hemolytic uremic syndrome. Meningococcal septicemia, acute leukemia. Autoimmune diseases such as degree SLE, copyright juvenile idiopathic arthritis, CHIA, degree rheumatic fever arthritis/arthralgia, septic arthritis. Reactive arthritis. Renal disease, IgA nephropathy. Of the DIP, no IgA deposition on biopsy. No IgA deposition on biopsy affects adults associated with specific antibodies, example MPO-ANCA. Abnormal coagulation studies, example 7-APTT. Low platelet count, non-palpable purpura. Low platelet count abnormal coagulation studies, example TPT. No IgA deposition on biopsy associated with specific antibodies, example anti-DSNA, A. Arthritis typically in a single joint. No rash, abdominal pain, or renal symptoms. No rash, joint, or GL symptoms primarily affects young adults. QB-IgAV is a unique cause of purpura without thrombocytopenia. The differential diagnoses listed here are not exhaustive. Add NA collapse. A. Find text. Al. Outline. Treatment. Approach, 111-9I10. Decisions about pharmacotherapy are based on symptom severity and should be guided by a specialist. Scent all patients, provide supportive care. Ensure adequate hydration, oral rehydration therapy and for fluid therapy as needed. Copyright provide NSAIDs and/or acetaminophen for pain. Copyright discontinue drugs suspected of inducing IgAV. 18 patients with severe vasculitis and/or IgAV nephritis. Copyright initiate systemic glucocorticoid therapy. Copyright most cases of IgAV are self-limited and only require supportive care. Systemic glucocorticoids IL. Asterisk indications. Copyright IgAV nephritis o severe abdominal pain. Copyright rectal bleeding. Copyright orchitis. Copyright cerebral vasculitis eo pulmonary hemorrhage. Copyright other features of severe vasculitis. Disposition 191. All patients require scheduled outpatient follow-up to monitor for delayed renal impairment. See follow-up of IgAV. OH at 2 shared no. Complications. Plus renal 20. Copyright IgAV nephritis may progress to nephrotic syndrome. Copyright serious complication, rapid progressive glomerulonephritis, RPGN, with crescent formation o end-stage renal disease sent gastrointestinal intussusception. 1. Copyright small bowel infarction or perforation. We list the most important complications. The selection is not exhaustive. G. O and follow-up. Patients with IgAV require follow-up due to an increased risk of chronic kidney disease. OLST 21 cent monitoring. Copyright blood pressure. Copyright urine studies, urinalysis, UPCR, UACR. Copyright serology, creatinine with EGFR. OOE. Prognosis. Sent IgAV usually resolves with full recovery. However, relapse is likely in patients with previous renal involvement. And back collapse. Find text outline. 4. Etiology. Why often triggered by upper respiratory tract infection, causes IgA immune complex deposition in small vessel walls, for nausea, vomiting. Diagnostics. Primarily clinical diagnosis. Treatment. 7 MR. Most cases are self-limiting nephritis mild disease, supportive treatment, example NSAIDs, severe disease, systemic glucocorticoids. Complications, AE abdominal pain GL, intussusception, bowel ischemia/perforation, occult, blood in stool renal, progressive kidney involvement, example nephrotic syndrome, chronic kidney disease. 7 P. At hematuria / palpable purpura EE/K arthritis/arthralgia. AA and smiley face, DL. IgA vasculitis fact sheet VV. Copyright Boss. Euro IgA vasculitis, 1/4. Purpura in IgA vasculitis. Maculopapular, reddish, non-blenching, palpable skin lesions, purpura, are seen on both the distal right arm and leg. On the lower leg, the lesions are partially confluent and present with scaling and erosion. Source, Purpura 2, O Quick Wikimedia Commons licensed under public domain. Purpura in IgA vasculitis. Multiple well-defined erythematous skin lesions, purpura, are distributed on the shin of this pediatric patient. Some purpura have coalesced to form ecchymosis. Purpura may be palpable and non-blenchable on examination. Source, Figure 1, in Hanox-Conline purpura associated with primary active Epstein-Barr virus infection, a case report by B. Karakaeli, S. Yilmaz, D. Kakir et.al., the Pan-African Medical Journal, licensed under CC by 4.0. Purpura in IgA vasculitis. Photograph of the leg of an 18-year-old male. Multiple well-defined erythematous skin lesions, purpura, are visible. Some purpura have coalesced to form ecchymosis. Examination revealed the purpura to be palpable and non-blenchable. An accompanying tetrad of arthritis, abdominal pain, and kidney impairment is typical of IgA vasculitis. Histology pathology is required to confirm the diagnosis of IgA vasculitis. Source: Purpura by Hector, Wikimedia Commons, licensed under CC by SA 3.0. Purpura in IgA vasculitis VV. Lower extremity of a patient with painful rash, multiple, partially confluent, erythematous skin lesions and small dark purple bumps, palpable purpura, are visible around the patient's ankle and lower leg. The rash spreads bilaterally and is accompanied by surrounding edema. These findings are typical of IgA vasculitis, formerly Haynock-Skonline purpura, for which the tetrad of rash, arthritis, abdominal pain, and kidney impairment is characteristic. Source: Figure 2, in Haynock-Skonline purpura in the adult, a case report by Ivan Virovets, Danielle Biggs, Jitam, licensed under CC by 4.0. Euro-IgA vasculitis, 1/3. AIG2D 37% K55M Niedrig H. Alg. Overlay. Target sign in intussusception M. Ultrasound abdomen, bowel, transverse plane, concentric alternating hyperechoic and hypoechoic rings are visible. The hyperechoic rings, green overlay, are formed by mucosa and the hypoechoic rings, red overlay, by submucosa. Together the alternating layers produce a target-like appearance, target sign, bullseye sign. Our great thanks to Albertin and Krankenhaus, Hamburg, Germany, for kindly providing this case. AIG2D 37% K55M Niedrig HAIIG. Copyright. Overlay. Target sign in intussusception. Ultrasound abdomen, bowel, transverse plane, concentric alternating hyperechoic and hypoechoic rings are visible. The hyperechoic rings, green overlay, are formed by mucosa and the hypoechoic rings, red overlay, by submucosa. Together the alternating layers produce a target-like appearance, target sign, bullseye sign. Our great thanks to Albertin and Krankenhaus, Hamburg, Germany, for kindly providing this case. Overlay. Leukocytoclastic vasculitis VV. Photomicrograph of a skin tissue sample, H&E stain, high magnification, there is focal neutrophilic inflammation, neutrophils indicated by arrowheads, neighboring a small blood vessel, marked by blue line, of the skin with the typical appearance of fragmented neutrophilic nuclei, leukocytoclasia, examples marked by arrows. These findings are suggestive of small vessel leukocytoclastic vasculitis, leukocytoclastic vasculitis. Source: Leukocytoclastic vasculitis high mag JPG by Nephron, Libre Pathology, licensed under CC by SA 3.0. =VR. NA. Cent. Overlay Y. Crescent formation in rapidly progressive glomerulonephritis, RPGN, V photomicrograph of kidney biopsy tissue, H&E stain, high magnification, a hypercellular, crescent-shaped zone with an inflammatory infiltrate, yellow overlay, is visible within the glomerulus. Glomerular crescent formation is a characteristic histological finding in RPGN. UR1, in ANCA vasculitis and hemophagocytic lymphohistiocytosis following a fecal microbiota transplant by A. M. Lani, A. Bromley, A. Fifima, Hindawi, case reports in rheumatology, licensed under CC by 4.0. X. Kawasaki disease. Kawasaki disease is an acute, necrotizing vasculitis of unknown etiology. The condition primarily affects children under the age of 5 and is more common among those of Asian descent. The disease is characterized by a high fever, desquamative rash, conjunctivitis, mucositis, example strawberry tongue, cervical lymphadenopathy, as well as erythema and edema of the distal extremities. However, Coronary artery aneurysms are the most concerning possible manifestation as they can lead to myocardial infarction or arrhythmias. Kawasaki disease is a clinical diagnosis, further supported by findings such as elevated ESR or evidence of cardiac involvement on echocardiography. Treatment with 4-immunoglobulins and high-dose aspirin is essential and should be initiated immediately after diagnosis. Yo degree IEEE. Epidemiology. Asterisk sex, 7-2, 1.5:1, 1 EH, primarily children. WAOE. Etiology. The exact cause of Kawasaki disease remains uncertain. However, it is associated with infectious and genetic factors. The prevalence is higher in patients of Asian descent and in siblings of affected children. 1.5. VA. CE. Clinical features. Asterisk clinical diagnosis requires fever for at least 5 days and one of the following. 6. Copyright 24 other specific symptoms copyright. Always consider Kawasaki disease in small children with a rash and high fever unresponsive to antibiotics. Crash and burn, conjunctivitis, rash, adenopathy, strawberry tongue, hands and feet, and burn, fever equals 5 days, are the most common features of Kawasaki disease. Back collapse. Find text outline. FA, CE. Diagnostics. Kawasaki disease is a clinical diagnosis, see clinical features above, which is supported by the following diagnostic findings: sent laboratory findings OTESR and CRP leukocytosis copyright thrombocytosis OTAST, alt-sent echocardiography O for evaluating coronary artery aneurysms copyright minimal evaluation, should be performed at diagnosis, at 2 weeks, and at 6 to 8 weeks after onset. 8. 2.7. OES. Treatment. Sent for immunoglobulin, IVIG, copyright high single dose to reduce the risk of coronary artery aneurysms copyright most effective if given within the first 10 days following disease onset 9 plus high dose oral aspirin, 10 ll 11 for glucocorticoids, may be considered in addition to standard treatment, especially in cases of treatment refractory disease, as they lower the risk of coronary involvement. Copyright to avoid the risk of Reye syndrome, children should not be treated with aspirin, especially if a viral infection is suspected. Kawasaki disease is an exception to this rule. WA. OSOR. Complications. Plus coronary artery aneurysm, 1 and 8. The risk of aneurysms is highest during the 2nd and 3rd weeks following symptom onset. 8. A rupture or thrombosis of the aneurysm can be lethal. Sent myocardial infarction. Sent myocarditis. Ventricular dysfunction copyright most commonly occurs within the first 2 weeks of onset of Kawasaki disease. 21. Copyright often seen in infants with untreated Kawasaki disease. 3. Copyright most commonly associated with lymphocytic myocarditis. 14. IL-12 copyright manifests with symptoms, example tachypnea or diaphoresis with feeding, exertional dyspnea, and physical examination findings of congestive heart failure, example hepatomegaly, gallop, rouse, or crackles on. Lung auscultation. 15. Copyright increased risk of sudden death. 3. Arrhythmias. We list the most important complications. The selection is not exhaustive. OOCR. Tips and links. Sources. Last updated September 16, 2023. Back collapse. Find text outline. Euro Kawasaki disease, 1/3. Cervical lymphadenopathy polymorphous rash. Oropharyngeal mucositis at red, swollen tongue at cracked, red lips. Coronary artery aneurysms or desquamation of fingertips. Swelling and erythema of hands and feet. Clinical features of Kawasaki disease VV. Copyright Boss. Typical findings in Kawasaki disease VV. A. Bilateral, non-purulent conjunctivitis. B. Stomatitis with bright red lips. C. Erythema and edema of the hands. D. Erythema and edema of the feet. E. Truncal rash. F. Cervical lymphadenopathy. G. Ultrasound of an enlarged cervical lymph node, increased perfusion. H. Desquamation of fingertips. 1. Deep grooves in the nail, bowlines. Source, Figure 2, in Kawasaki Disease by C. M. Heydrich, A. Schnabel, T. Hosbake, Frontiers in Pediatrics, licensed under CC by 4.0. Euro Kawasaki Disease, 3/3. Strawberry tongue in Kawasaki disease VV. The tongue appears enlarged and is covered by a gray-white exudate. Prominent papillae are also visible. Source, Figure 1, in An Adult Kawasaki Disease with Coronary Artery Involvement, a Unique Case Report and Literature Review by Faizaluddin. M. Iftikhar P.M., K. ETAL, Curious, licensed under CC by 3.0. Euro Kawasaki Disease, 1/1. Copyright. Overlay. Coronary artery aneurysm in Kawasaki disease. Volume rendering of a thorax CT, anterior view, with contrast, showing aorta and coronary vessels. The proximal part of the left anterior descending branch of the left coronary artery, LCA, is dilating, green overlay, and there is significant variation of vessel diameters. This abnormal morphology suggests an aneurysm of the LCA. Source, Coronarinersimon-Bay Kawasaki Syndrome, CT, Volume Rendering Tree, 001 by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. X. Acute rheumatic fever. Acute rheumatic fever, ARF, is an inflammatory sequela involving the heart, joints, skin, and central nervous system, CNS, that occurs 2 to 4 weeks after an untreated infection with group A Streptococcus, GAS. The pathogenic mechanisms that cause rheumatic fever are not completely understood, but molecular mimicry between streptococcal M protein and human cardiac myosin proteins is thought to play a role. Because of the structural similarities between the two proteins, antibodies and T cells activated to respond to streptococcal proteins also react with the human proteins, causing tissue injury and inflammation. In addition to nonspecific symptoms, example fever, malaise, and fatigue, patients present with symptoms involving the heart, carditis or valvulitis, joints, migratory polyarthritis, skin, subcutaneous nodules, erythema marginatum, and / or CNS, sydenham chorea. The diagnosis of ARF is primarily clinical and based on the Jones criteria. Diagnostic evaluation in ARF typically shows elevated inflammatory markers, positive anti-streptococcal antibodies, and valvular damage on echocardiogram. The first-line treatment is penicillin combined with symptomatic anti-inflammatory treatment, typically with salicylates or glucocorticoids, if salicylates are not effective. ARF may be complicated by progressive, permanent damage to the heart valves, especially the mitral valve, resulting in chronic rheumatic heart disease. Preventing the cardiac complications of ARF is the main goal of both primary prophylaxis, i.e., antibiotic therapy for gas pharyngitis, and secondary prophylaxis, antibiotic administration following an episode of ARF. OSOE. Definition. SENT delayed inflammatory complication of group AB hemolytic streptococcal pharyngitis that usually occurs within 2 to 4 weeks of acute infection. 1*1 of the non-suppurative complications of gas pharyngitis. SENT rheumatic heart disease refers to two clinical entities. Copyright acute pancarditis as a sequela of gas infection. Copyright chronic cardiac valvular changes as a complication of acute rheumatic fever. WA. OOIOS. Epidemiology. Scent peak incidence, 5 to 15 years of age, 2, plus prevalence, more common in resource-limited countries. 1. Epidemiological data refers to the U.S., unless otherwise specified. Why? And etiology. Previous infection with group A B hemolytic streptococcus, gas, also referred to as Streptococcus pyogenes O, usually acute tonsillitis or pharyngitis, strep throat, degree gas infections of the skin, example erysipelas, impetigo, cellulitis, tend to be complicated by post-streptococcal glomerulonephritis rather than rheumatic fever. OOE. Pathophysiology. Scent. The exact pathogenesis is not yet entirely understood. Most commonly accepted mechanism involves the following: acute tonsillitis/pharyngitis caused by gas without antibiotic treatment, development of antibodies against streptococcal M protein, cross-reaction of antibodies with nerve and myocardial proteins, most commonly myosins, due to molecular mimicry, type 2 hypersensitivity reaction, acute inflammatory sequela 2I, 4I. WA. 3s. Back collapse. Fine text outline. Pathology. Plus myocardial findings, LLEO Askhoff bodies / equals granuloma of rheumatic inflammation equals central area of fibrinoid necrosis equals surrounded by characteristic multinucleated giant cells, Askhoff cells, and other inflammatory cells, mononuclear cells, plasma cells, and T lymphocytes, due to a type 4 hypersensitivity reaction. 1. Copyright Anitz cow cells equals cardiac histiocytes, mononuclear cells, appearing in Askhoff bodies equals large and elongated cells equals longitudinal section, ovoid nucleus containing wavy, caterpillar-like bar of chromatin, caterpillar cell, equals transverse section, ali appearance. Essay. RT / OO. OFOT. Clinical features. Scent. Constitutional symptoms: fever, malaise, fatigue plus joints, migratory polyarthritis. Scent. Heart. Pancreatitis, endocarditis, myocarditis, and pericarditis. Copyright. Valvular lesions, most commonly on high-pressure valves equals mitral valve, 65% of cases, equals early mitral regurgitation or prolapse equals late mitral stenosis. Rheumatic fever is the most frequent cause of mitral stenosis. Mixed mitral stenosis / regurgitation equals aortic valve, 25% of cases, equals aortic regurgitation equals aortic stenosis. Late manifestation, equals tricuspid valve, 10% of cases. Copyright. Dilated cardiomyopathy due to severe valvular disease, myocarditis CNS, sydenham chorea, involuntary, irregular, non-repetitive movements of the limbs, neck, head, and / or face, $70 A, 2:1. Copyright. Most common cause of acute chorea in children in the U.S. Copyright occurs 1 to 8 months after the inciting infection, degree. Copyright. Clinical features equals sometimes asymmetrical or confined to one side, hemichorea. Equals additional motor symptoms, example bulismus, muscle weakness, and speech disorders, slurred or jerky speech. Equals milkmaid grip, characterized by the inability to maintain muscle contraction in the hands. Intermittent loss of contraction results in alternating squeeze and release of grip. Milking, equals choreic hand, characterized by intermittent wrist flexion with extension of the digits. Spooning of the hand, equals neuropsychiatric symptoms, example inappropriate laughing / crying, agitation, anxiety, apathy, obsessive compulsive behavior. O. Pathophysiology. Streptococcal antigens lead to antibody production. Antibodies cross-react with structures of the basal ganglia, particularly the striatum, and cortical structures. Reversible dysfunction of cortical and striatal circuits. Scent. Skin. O. Subcutaneous nodules. O. Erythema marginatum, centrifugally expanding pink or light red rash with a well-defined outer border and central clearing. D. Equals painless and non-pruritic. Equals location, the trunk and limbs are affected, the face is spared. May rapidly appear and disappear at different locations. 1. Equals differential diagnosis. For details, see overview of annular skin lesions. QB rheumatic heart disease tends to involve the high-pressure valves, i.e., the mitral and aortic valves. And valvular lesions sometimes do not manifest until pregnancy, when blood volume is increased. A. Q at the symptoms of acute rheumatic fever can be remembered by reading the Jones criteria. See diagnostics below, as an acronym that replaces the O with a heart. J equals joints, AT equals pancarditis, N equals nodules, E equals erythema marginatum, S equals sydenum chorea. Back collapse. Find text outline. Diagnostics. Approach, 11 IL-12. Patients should be evaluated for evidence of a preceding gas infection via throat culture, antigen, or antibody test. EARF is diagnosed using the revised Jones criteria. All patients with suspected or confirmed ARF require a cardiac workup. Revised Jones criteria, 5, 12I11. Sent diagnostic criteria for patients with laboratory findings of a preceding gas infection. Copyright initial episode of ARF, 2 major criteria or 1 major plus 2 minor criteria. Copyright recurrent ARF, either the same as for an initial episode of ARF or the presence of 3 minor criteria. Revised Jones criteria for the diagnosis of ARF. Low-risk populations. Migratory polyarthritis, primarily involving the large joints, 1 carditis, pancarditis, including valvulitis. Major criteria equals sydenum chorea, CNS involvement, subcutaneous nodules, erythema marginatum. Polyarthralgia. Sent high fever, 238.5 degrees Celsius, T acute phase reactants, ESR equals 60 mm/hour and/or CRP equals 30 mg/L, ECG showing prolonged PR interval. 1 minor criteria. Routine laboratory studies, 11. Initial laboratory findings typically show nonspecific signs of infection. Plus complete blood cell count, 111I13. Copyright typically shows leukocytosis. O may show normochromic, normocytic anemia of chronic inflammation. Sent acute phase reactants, 11O CRP, elevated, typically 30 mg/LOESR, elevated, typically equals 60 mm/hour. Confirmation of gas infection, 1. Sent used to rule out differential diagnoses. -E Any of the following test results can confirm recent gas infection. Copyright tests showing elevated or rising antibodies equals foot antistreptolysin O titer, ASO, 1 antistreptococcal DNA SEB titer, ADB, copyright positive throat culture. Copyright positive rapid gas carbohydrate antigen detection test. Moderate to high risk populations. Arthritis, monoarthritis or migratory polyarthritis, polyarthralgia. Carditis, pancarditis, including valvulitis, sydenum chorea, CNS involvement, subcutaneous nodules, erythema marginatum. Monoarthralgia. High fever, equals 38.5 degrees Celsius. ECG showing prolonged PR interval. Sent false positives are possible due to colonization of gas in the upper respiratory tract. Sent for more information on the diagnosis of gas pharyngitis, see acute tonsillitis. Assessment for cardiac involvement, 111L141I15. All patients with confirmed or suspected rheumatic fever require an ECG and echocardiography. Cardiac workup for ARF modality. Most common, prolonged PR interval, first degree AV block. 4 Sent potential additional findings include, second degree AV block. ECG. Copyright complete heart block. Copyright sinus tachycardia. Copyright accelerated junctional rhythm. Copyright ECG features of pericarditis. Characteristic findings 14-13-15. Asterisk acute infection, features of rheumatic valvulitis, example mitral regurgitation, aortic regurgitation echocardiography asterisk chronic disease, mitral stenosis, 4L. Asterisk enlarged left atrium chest X-ray sent enlarged left ventricle sent X-ray findings of pulmonary edema. WV equals A. Collapse find text. Acute phase reactance, ESR equals 30 mm/hour and/or CRP equals 30 mg/L. Al. Outline. Assessment for neurological involvement, 171 I-18. The diagnosis of sydenham chorea is based on clinical and laboratory findings. Neuroimaging, MRI or CT brain, not routinely indicated echocardiography should be obtained in all patients with sydenham chorea because concurrent cardiac involvement is common. 14. And management. Treatment of ARF involves pain relief for arthritis, antibiotics to both treat acute gas infection and prevent recurrence, and medical management of associated complications. Gas eradication, 141. Sent first line, penicillin V sent in patients with penicillin allergy, use, copyright cephalosporins, hypersensitivity without anaphylaxis, O or macrolides, severe hypersensitivity to beta-lactam antibiotics, 14 symptomatic treatment of arthritis and fever. Plus first line, nonsteroidal anti-inflammatory drugs, NSAIDs, 1/21L19 copyright aspirin onaproxen E second line, glucocorticoids, example prednisone. OIR note OE. Lee management of complications. Cardiac involvement. Re-ST cardiacations in ARF19L141 cardiac complication acute management bed rest is not required. Mild to moderate consider an ACE inhibitor, particularly if the patient has aortic regurgitation. Bed rest with gradual ambulation is recommended. 12 Manage underlying heart failure using standard guideline-directed medical therapy. In suspected myocardial involvement, monitor and treat patients for arrhythmias, see myocarditis. Severe in acute mitral regurgitation, urgent valve replacement may be necessary. Sydenham chorea, 19-14. In the majority of cases, sydenham chorea is self-limiting, with most patients seeing an improvement within a few weeks and nearly all patients fully recovered by 6 months. Stent supportive therapy, indicated for all patients, may be the only treatment required in mild disease arrest in a calm environment. Avoidance of overstimulation. Copyright patient and caregiver education about the condition. Pharmacotherapy. Copyright consider for patients with difficulties performing activities of daily living. Copyright options include carbamazepine and valproic acid, 2120. OOOE. Lee prevention. Primary prevention 21. He aims to prevent ARF from developing as a result of gas infection. Sent patients should receive prompt antibiotic treatment for gas tonsillopharyngitis, example with penicillin V, and streptococcal skin infections. Back collapse. Find text outline. 19. Acute rheumatic fever. Lee management of complications. Cardiac involvement. Of cardiacations in ARFL 9-14 cardiac complication. Acute management. Bed rest is not required. Mild to moderate consider an ACE inhibitor, particularly if the patient has aortic regurgitation. Bed rest with gradual ambulation is recommended. 12 Severe manage underlying heart failure using standard guideline-directed medical therapy. In suspected myocardial involvement, monitor and treat patients for arrhythmias, see myocarditis. In acute mitral regurgitation, urgent valve replacement may be necessary. A. Sydenham chorea, 19-14. In the majority of cases, Sydenham chorea is self-limiting, with most patients seeing an improvement within a few weeks and nearly all patients fully recovered by 6 months. SENT supportive therapy, indicated for all patients, may be the only treatment required in mild disease, copyright rest in a calm environment. Avoidance of overstimulation. Patient and caregiver education about the condition. SENT pharmacotherapy. Copyright consider for patients with difficulties performing activities of daily living. Copyright options include carbamazepine and valproic acid. 1. 21L20. OOCE. Lee prevention. Primary prevention. 21. He aims to prevent ARF from developing as a result of gas infection. SENT patients should receive prompt antibiotic treatment for gas tonsillopharyngitis, example with penicillin V, and streptococcal skin infections. 19. Secondary prevention. Patients with a history of ARF are at high risk for recurrence, which may worsen existing rheumatic heart disease. SENT all patients require antibiotic prophylaxis. Start immediately after completion of antibiotics for ARF. Copyright drug of choice, IM penicillin G benzathine every 4 weeks. Copyright alternatively, oral penicillin V. Patients with penicillin allergy, sulfadiazine. Copyright antibiotic prophylaxis should be decided according to whichever of the following results in the longest treatment duration. 21 equals possible ARF, 5 12 months. 14 equals rheumatic fever without carditis, 5 years or until the patient reaches 21 years of age equals rheumatic fever with carditis, with no residual heart disease. 10 years or until the patient reaches 21 years of age equals rheumatic fever with carditis and permanent valvular heart defects. 10 years or until the patient reaches 40 years of age. Educate patients on early recognition of symptoms and the importance of adhering to prophylaxis. Emphasize the importance of dental care and regular dental checkups. OOE. Prognosis. Cardiac involvement is the most important prognostic factor. 1. Copyright early death from rheumatic fever is usually due to myocarditis rather than valvular defects. Copyright patients with a history of carditis, and possible post-inflammatory scarring and calcification, during an initial rheumatic fever episode are at high risk of developing valvular heart defects with recurrent episodes. Rheumatic heart disease. Back collapse. Fine text outline. Acute rheumatic fever, 1/1. Acute rheumatic fever. Etiology: previous gas pharyngitis/tonsillitis without antibiotic treatment. Peak incidence 5 to 15 years of age. Diagnosis: evidence of a previous gas infection, example throat culture, rapid antigen detection test, anti-streptolysin O, anti-streptococcal DNase B test, revised Jones criteria. Treatment: antibiotic treatment of underlying gas infection, symptomatic treatment of arthritis and fever. Constitutional: high fever, malaise, valvulitis, pancarditis. Emarginatum CNS. 1 to 8 months after infection. Sydenham chorea. Jerking subcutaneous nodules. Degree flinching. Joints. Migratory polyarthritis. NS equals A equals L. Untreated gas / development / molecular / type 2 hypersensitivity / inflammation and pharyngitis / tonsillitis. F of antibodies to mimicry VA reaction. L cell damage. Acute infection latent period, 2 to 4 weeks. Acute rheumatic fever fact sheet. Copyright Boss. Rheumatic fever onset. Overlay. Askhoff body and Anitz cow cells VV. Photomicrograph of a myocardial tissue specimen, H&E stain, high magnification, a collagenous nodule, green overlay, is seen within the myocardial tissue. The nodule contains a loose lymphoplasmacytic infiltrate and large eosinophilic cells with an ovoid nucleus, Anitz cow cells, arrowheads. Anitz cow cells are thought to be histiocytes. These nodules, referred to as Aschhoff bodies, are thought to represent myocardial granulomas, which are typically found in rheumatic heart disease. Source: Aschhoff body in rheumatic myocarditis by Ed Uthman, Flickr, licensed under CC by SA 2.0. Erythema marginatum. Left upper arm of a child diagnosed with acute rheumatic fever, ARF, erythematous plaques with areas of central clearing are visible on the ventral aspect of the forearm. This is characteristic of erythema marginatum, the characteristic annular erythema occurring in 10% of attacks of acute rheumatic fever in children, caused by group A Streptococcus. Source: Erythema marginatum by ADSI, Wikimedia Commons, licensed under CC by SA 4.0. Modifications: image has been cropped. Acute rheumatic fever, 1/2. Subcutaneous nodules in rheumatic fever VV. Solitary subcutaneous, erythematous, warm, and tender protuberances are visible on the left shoulder. In conjunction with flu-like symptoms, ankle swelling, and an elevated anti-streptolysin O, ASO, titer, these skin findings indicate rheumatic fever. Source: Figure 1, in Acute Rheumatic Fever, a review of essential cutaneous and histological findings by M. A. Hurd, M. C. Green, M. Royer, Curious, licensed under CC by 4.0. HR, 81 QRS, 106 milliseconds Pax 69 PD, 120 milliseconds QT, 400 milliseconds QRS AX, minus 22 PR, 302 ms underscore QTC, 465 ms underscore tax, 79 underscore QRS TX, 3. T.7:23-7.27. First degree atrioventricular block. 12 lead ECG, paper speed, 25 mm/s, normal sinus rhythm heart rate, 80/min normal axis PR interval, 300 ms. The PR interval greater than 200 ms indicates first degree atrioventricular block. Our great thanks to Thomas Waldiak, MD, for kindly providing this case. 25 Ms 10 Mim Yen. Copyright. Overlay. Mobitz type 2 second degree atrioventricular block and bifascicular block BV. 15 lead ECG, paper speed, 25 mm/s. Irregular rhythm atrial rate 70/min, ventricular rate 40/min left axis deviation, lat RS in lead, plus, R. The intermittent non-conducted P waves, with constant PR in the conducted beats, indicate Mobitz IL second degree atrioventricular block, which may have a regular conduction ratio or be completely irregular. The combination of RBBB and left anterior vesicular block represents a bifascicular block. NB 8644, 65, MMO copyright MRE 14T. Copyright. Overlay. Third degree atrioventricular block VV. Rhythm strip ECG, paper speed, 25 mm/s, atrial rate 100/min, ventricular rate 40/min, escape rhythm, RR intervals and PP intervals are regular. Atrioventricular, AV, dissociation, P waves, red overlay, and QRS complexes, green overlay, have regular but unrelated rhythms because there is no conduction between atria and ventricles, resulting in some P waves being completely or partially buried in QRS complexes, 6 P wave, or T waves, 4 and 9 P waves. AV dissociation with bradycardia is characteristic of third degree AV block, complete heart block. Source: Rhythm strip showing third degree heart block, Moody Groove, Wikimedia Commons licensed under public domain. Overlay. Enlarged left atrial appendage V. X-ray chest, PA view, a CONV exudy between the moguls produced by the main pulmonary artery, PA, and left ventricle, LV, suggests enlargement of the left atrial appendage, LA, normal configuration indicated by dashed line. Breast shadow opacification, green overlay, simulates parenchymal airspace disease. A. Aortic arch source, copyright IMPP. Overlay. Enlarged left atrial appendage VV. X-ray chest, PA view, a CONV exudate between the moguls produced by the main pulmonary artery, PA, and left ventricle, LV, suggests enlargement of the left atrial appendage, LA, normal configuration indicated by dashed line. Breast shadow opacification, green overlay, simulates parenchymal airspace disease. A. Aortic arch source, copyright IMPP. XX systemic lupus erythematosus. Systemic lupus erythematosus, SLE, is a multi-system autoimmune disease that predominantly affects women of childbearing age and is the most common form of lupus. The exact cause is still unknown, but hormonal and immunological features and genetic predisposition are considered likely etiological factors. Disease presentation is variable but is usually characterized by phases of remission and relapse. Symptoms can range from mild and localized to life-threatening systemic disease. SLE can affect any organ, but typical findings include arthritis, a malar rash, facial butterfly rash, and constitutional symptoms such as fever and fatigue. Involvement of the kidneys is common and can lead to lupus nephritis. Potential manifestations of SLE include cutaneous lupus erythematosus, CLE, and neuropsychiatric systemic lupus erythematosus, ANPSL. However, they can also occur independently from SLE. Other forms of lupus in addition to SLE include drug-induced lupus erythematosus, DIL, and neonatal lupus. The diagnosis of lupus is based on clinical findings and is further supported by laboratory studies, including the presence of anti-nuclear antibodies, ANAs, and antigen-specific ANAs, i.e., anti-DNA, anti-SM. The 2019 Euler/ACR classification criteria for SLE do not need to be fulfilled to make a diagnosis but may further support it. Management consists of general measures, such as avoiding sun exposure, and lifestyle modifications for prevention. Long-term immunosuppressive therapy depends on disease severity and organ involvement. Hydroxychloroquine is typically used, as it has been shown to reduce flares and decrease mortality. In severe cases, additional immunosuppressants, example mycophenolate, azathioprine, or biological agents may be given. Cardiovascular, neurological, and renal disease, lupus nephritis, together with infections, are the main causes of death in patients with SLE. Smiley face, as 6EO == OE. Epidemiology. Asterisk sex, 2710:1. Cent peak incidence and prevalence lab, copyright age of onset equals women, 15 to 44 years equals men, no particular age copyright race, highest in populations of African descent. Epidemiological data refers to the U.S., unless otherwise specified. 0% OE. Etiology. The exact etiology is unknown, but several predisposing factors have been identified. Genetic predisposition 3-OHLA-DR2 and HLA-DR3 are commonly present in individuals with SLE. Copyright genetic deficiency of classical pathway complement proteins, C1q, C2, C4, in approximate 10% of affected individuals. Scent hormonal factors, hyperestrogenic states, example due to oral contraceptive use, postmenopausal hormonal therapy, endometriosis, are associated with an increased risk of SLE. 41 plus environmental factors, 1L41 copyright cigarette smoking and silica exposure increase the risk of developing SLE. UV light and EBV infection may trigger disease flares, but there is insufficient evidence on whether they cause SLE. Drugs such as procainamide or hydralazine, see drug-induced lupus erythematosus. WA. CE. Pathophysiology. The exact pathomechanism of SLE is not fully understood, but the following two processes are the most widely accepted hypotheses: 5. Autoantibody development, deficiency of classical complement proteins, C1q, C4, C2, failure of macrophages to phagocytose immune complexes and apoptotic cell material, i.e., plasma and nuclear antigens, dysregulated, intolerant lymphocytes targeting normally hidden intracellular antigens, autoantibody production, example ANA, anti-DNA, SENT. Autoimmune reactions, copyright type IL hypersensitivity, most common in SLE, antibody-antigen complex formation in microvasculature, complement activation and inflammation, damage to skin, kidneys, joints, small vessels, O-type IL hypersensitivity, IgG and IgM antibodies directed against antigens on cells, example red blood cells, cytopenia. Back collapse, find text outline. Clinical features. SLE is a systemic disease characterized by phases of remission and relapse. Some individuals only experience mild symptoms, while others experience severe symptoms and rapid disease progression. SLE can affect any organ. Common 61. SENT constitutional, fatigue, fever, weight loss, joints, 90% of cases. 3. Copyright arthritis and arthralgia, copyright distal symmetrical polyarthritis, most commonly affects the joints of the fingers, carpal joints, and the knee skin, 85% of cases. 3270 malar rash, butterfly rash, flat or raised fixed erythema over both malar eminences, nasolabial folds tend to be spared. Raynaud phenomenon, copyright photosensitivity, maculopapular rash / trademark copyright discoid rash, copyright oral ulcers, usually painless, copyright non-scarring alopecia, except with discoid rashes, periungual telangiectasia. Both rheumatoid arthritis and SLE arthritis affect the MCP and PIP joints, but SLE does not usually lead to deformities. Less common. SENT hematological, petechiae, pallor, or recurrent infections due to cytopenias, musculoskeletal, myalgia, SENT serositis, pleuritis and pericarditis, effusions, kidneys, nephritis with proteinuria, see lupus nephritis, SENT heart, pericarditis, myocarditis, endocarditis, Liebman-Sachs endocarditis, aortic valve lesions, degree coronary artery disease, lungs, pneumonitis, interstitial lung disease, pulmonary hypertension, SENT vascular, copyright vasculitis, copyright thromboembolism, c. Antiphospholipid syndrome, neurological, seizures, copyright psychosis, personality changes, lupus cerebritis, copyright aseptic meningitis, polyneuropathy plus eyes, keratoconjunctivitis, sicca, 5. Copyright SLE can cause LSE, Liebman-Sachs endocarditis. WA. OE. Diagnostics. General principles, degree LL 101. SENT SLE is a clinical diagnosis. SENT diagnostic studies support the diagnosis and serve as markers of disease activity and / or organ damage. Copyright the 2019 Euler/ACR classification criteria for SLE may be considered to further support the diagnosis, but do not need to be fulfilled to establish a diagnosis of SLE. Lawlio. Back collapse, find text outline. Soap brain, MD serositis, oral and / or nasal ulcers, arthritis, photosensitivity, blood disorders, renal involvement, ANAs, immunological phenomena, anti-dsDNA, anti-SM, antiphospholipid antibodies, neurological disorders, and malar or discoid rash are the features of SLE. Laboratory studies /9 Li 10. The following studies are commonly part of a minimum diagnostic workup if SLE is clinically suspected. 9 SENT anti-nuclear antibodies, ANAs, copyright positive titers of =1:80 have 98% sensitivity for SLE, Entry criterion for the 2019 Euler/ACR classification criteria for SLE. O. If negative, consider differential diagnoses and/or follow up with the patient regularly. Antigen-specific ANAs, request only if ANAs are positive. O. Anti-DNA antibodies equals autoantibodies against double-stranded DNA equals positive in 60 to 70% of patients equals highly specific for SLE levels correlate with disease activity, especially lupus nephritis activity. 1O anti-SM antibodies equals autoantibodies against Smith antigens, non-histone nuclear proteins, equals positive in copyright complement levels, C3 and/or C4 in patients with active disease I. Copyright inflammatory markers 2-1 equals ESR, may be elevated in patients with active disease equals CRP, often normal, may be elevated in patients with serositis, arthritis, or infections, copyright CBC, may show leukopenia, thrombocytopenia, and/or autoimmune hemolytic anemia or anemia of chronic disease OCMP, may show 7-bun and/or creatinine, and/or electrolyte abnormalities O urinalysis and urine microscopy, may show proteinuria, hematuria, and/or urinary calcime. Copyright ANAs have the highest sensitivity but low specificity for SLE. Anti-DNA and anti-SM antibodies are the most specific antibodies for SLE. And RPR and VDRL are usually used to test for syphilis but may also be positive in SLE. Classification criteria for SLE 61L121. The classification criteria for SLE were originally developed for research purposes, not as diagnostic criteria. Nevertheless, these criteria are often used in clinical practice to support the diagnosis of SLE. Sent further considerations copyright consider other, more likely diagnoses before attributing a criterion to SLE. Copyright criteria do not need to occur simultaneously. The occurrence of any criterion at least once is sufficient. 2019 Euler/ACR classification criteria for SLE, L12. Domain criteria. Asterisk constitutional fever 38.3 degrees Celsius 100.9 degrees Fahrenheit. WBC count. Asterisk hematologic platelet count. Autoimmune hemolysis 5. Delirium. Neuropsychiatric psychosis. Primary generalized or focal seizures. Non-scarring alopecia. Oral ulcers asterisk mucocutaneous SCLE or DLE clinical ACLE. Pleural or pericardial effusion. Back collapse fine text. Al. Outline. Weight. 2. Pleural or pericardial effusion 75. Acute pericarditis with equals 2 of the following, asterisk serositis pleuritic chest pain copyright pericardial rub degree 6 ECG changes, example diffuse ST elevations or PR depression, copyright evidence of pericardial effusion on imaging studies. Joint involvement, one of the following asterisk musculoskeletal copyright synovitis of equals 2 joints 6 copyright tenderness in equals 2 joints with equals 30 minutes of morning stiffness. Sent proteinuria 0.5 g in 24 hours 24. Renal asterisk class IL or V lupus nephritis confirmed on renal biopsy 8. Asterisk class IL or LV lupus nephritis confirmed on renal biopsy 10 colonase any of the following are positive. Copyright anticardiolipin antibodies sent antiphospholipid antibodies 2 copyright anti-B2GPI antibodies lupus anticoagulant C3 or C4 immunological, complement proteins sent C3 and C474. Asterisk any of the following, asterisk SLE specific antibodies copyright positive anti-DNA antibodies degree 6 copyright positive anti-SM antibodies. SLE classification requires all of the following to be met. Entry criterion. At least one clinical criterion. Total additive score equals 10 points, calculated by adding the highest weighted criteria within each domain together. Additional diagnostics, 91. Request additional tests based on suspected organ involvement, see also specific clinical manifestations and clinical features. Imaging studies. Imaging studies can help in the assessment of organ or joint involvement. X-ray joints, perform in patients with articular symptoms. Sent X-ray or CT chest, perform in patients with symptoms of pulmonary involvement, example interstitial lung disease, pleuritis. Sent echocardiography, consider in patients with suspected pericardial effusion or Liebman-Sachs endocarditis. Histopathology, 31. Skin biopsy copyright consider in patients with atypical dermatologic presentation or no response to initial therapy. Olupaspan test, LBT, a direct immunofluorescence staining technique used to detect immunoglobulin and complement component deposits along the dermoepidermal junction in affected and unaffected skin in patients with SLE14 copyright. See also cutaneous lupus erythematosus. Kidney biopsy, in case of suspected lupus nephritis. Biopsy of an affected organ, example skin, kidney, can be performed to support the diagnosis but is not required for all patients. Risk assessment. 1. Recommended in all patients with SLE, risk enhancing factor. Copyright patients with SLE have double the cardiovascular risk compared to patients without SLE. Cardiovascular disease is among the most common causes of death in patients with SLE. 0. A. Treatment. Back collapse. Find text outline. Treatment. General principles, 151-1310. Plus patients with SLE usually require lifelong immunosuppressants. 1. Copyright management is guided by disease severity and the systems or organs affected, see also specific clinical manifestations. Copyright patients should be frequently monitored for medication-induced adverse effects. NSAIDs can provide symptomatic relief. 9. Non-pharmacological measures include, copyright lifestyle modifications for prevention, example smoking cessation, aerobic exercise, copyright avoidance of UV light. If applicable, optimize management of ASCT and offer preconception counseling, see also SLE and pregnancy. 10. Disease severity. Disease severity can be classified based on the presence of clinical features and laboratory markers of disease activity and/or organ damage in SLE. Mild disease, no vital organs affected, example constitutional symptoms, mild arthritis rash and/or cytopenias. Moderate disease, no vital organs affected, example cutaneous vasculitis, serositis, RA-like arthritis, moderate rash and/or cytopenias, or no response to standard therapy. Severe or organ-threatening disease, example nephritis, myelitis, pneumonitis, mesenteric vasculitis, severe cytopenias. Pharmacotherapy, 131-91-121. All patients, hydroxychloroquine is the cornerstone of therapy, regardless of disease activity. 13F16, mild to moderate disease, no vital organs affected. Consider the addition of oral glucocorticoids with or without other immunosuppressive agents to achieve remission. Severe or organ-threatening disease. Copyright induction therapy equals high dose for glucocorticoids and other immunosuppressive agents equals used until symptom remission or low disease activity is achieved. Copyright maintenance of remission equals hydroxychloroquine with or without lower dose glucocorticoids equals and/or immunosuppressants or biological agents plus disease flares. Adjust therapy based on the severity of organ involvement. 1. Prevention and monitoring for medication-induced adverse effects, 131-9-210. All patients, offer influenza and pneumococcus immunizations. Glucocorticoids and immunosuppressants OSS for infection. Copyright monitor for side effects of glucocorticoid therapy. Plus hydroxychloroquine, request ophthalmologic screening at baseline, after 5 years, and yearly thereafter. 3. WA. RO, XE. Specific clinical manifestations. The specific manifestations of SLE are classified based on the systems affected. Cutaneous lupus erythematosus, CLE. Some patients with lupus present with predominantly cutaneous manifestations. Cutaneous manifestations are classified based on their chronicity, acute, subacute, or chronic. Acute cutaneous lupus erythematosus, ACLE, 171 I18 LL Cent L. Cent general information, frequently associated with active SLE. Cent epidemiology, most common in individuals 20 to 30 years of age. Cent clinical features: O malarish copyright O maculopapular rash, also called maculopapular rash of lupus and photosensitive lupus dermatitis. Cent diagnostics copyright diagnosis is clinical. Copyright consider a biopsy in patients with atypical clinical presentation. 1E serum studies positive ANAs in 95% of patients. 17 levels of anti-SN and anti-SM antibodies are often positive. ACLE is frequently associated with systemic disease. Back collapse. Fine text outline. Subacute cutaneous lupus erythematosus, SCLE, LL17. Cent general information: EO, an uncommon variant O, may be associated with systemic disease. Cent clinical features: O extreme photosensitivity. O begins as a papular eruption or small scaly plaques that develop into either annular or psoriasiform lesions. MSO lesions heal without scarring but may cause hypopigmentation. O usually affects the neck, shoulders, and upper limbs, but spares the face. Cent diagnostics copyright based on a combination of patient history, clinical examination, and histology. O patients often have positive ANAs and anti-RO/SSA antibodies. Discoid lupus erythematosus, DLE, 72171. DLE is the most common form of chronic CLE. Cent general information, rarely associated with systemic disease. Cent epidemiology $0 3:1, copyright most common in women 30 to 50 years of age. Cent clinical features: O erythematous, inflammatory scaly plaques that are painful to remove. O the plaques heal, but cause scarring. Alopecia, atrophy, peripheral hyperpigmentation, and central depigmentation. He degree typically affects the face, neck, and head, triggered by exposure to UV light. Cent diagnostics copyright based on a combination of patient history and clinical examination. Copyright autoantibodies, i.e., ANAs, and antigen-specific ANAs, are usually negative. Copyright skin biopsy, consider in patients with atypical clinical presentation. 13 equals vacuolar degeneration of basal cells, interface dermatitis, with lymphocytic infiltrates equals follicular hyperkeratosis or plugging may be seen on the scalp, and mucin deposition may be seen in long-standing lesions. Lupus band test can help differentiate DLE from SLE. 4I. Cent differential diagnosis. For details, see overview of annular skin lesions. Cent prognosis copyright: the prognosis for patients with DLE is better than the prognosis for those with SLE. Copyright: the risk of developing SLE is at. DLE is the most common form of chronic CLE, it is rarely associated with systemic disease. Management of CLE, 731L9. Cent general recommendations: O wear sunblock with SPF equals 50 and protective clothing. Copyright: see also general principles in the treatment section. Pharmacological treatment: O first line treatment, hydroxychloroquine equals plus topical glucocorticoids, example fluocinolone and / or topical calcineurin inhibitors, example pimecrolimus, 13:9 equals with or without systemic glucocorticoids, example prednisone, lupus nephritis. Description 191. Back collapse. Fine text. Al. Outline. Lupus nephritis. Description 19. Most dangerous specific manifestation because of its high morbidity and mortality can manifest as nephritic syndrome and / or nephrotic syndrome. See overview of glomerular death. Common, found in up to 50% of individuals with SLE at presentation I. Pathophysiology 19. Mesangial and / or subendothelial deposition of immune complexes, example anti-SN antibodies, anti-SM antibodies, expansion and thickening of mesangium, capillary walls, and / or glomerular basement membrane. Clinical features. Hypertension, edema, hematuria. Diagnostics, degree. Laboratory studies OBMP, F-creatinine. Copyright urinalysis, proteinuria, hematuria, cellular casts, RBCs, hemoglobin, granular, tubular, or mixed. Copyright spot urine protein creatinine ratio, proteinuria 0.5 g/g, 1 kidney biopsy. Copyright indicated in patients with either 9 unexplained 7 creatinine equals proteinuria equals 1.0 g/g equals proteinuria equals 0.5 g/g and hematuria or cellular urinary casts. Findings, immune complex mediated glomerulonephritis. Perform regular urinalysis follow-up in patients with SLE, as early detection and treatment of renal disease can prevent progression to severe disease. Management of lupus nephritis, 191. General principles. Copyright all patients should receive standard therapy for lupus and individualized management of CKD. Pharmacological management degree equals 4 glucocorticoids, example methylprednisolone, equals plus other immunosuppressants, example mycophenolate or cyclophosphamide. Neuropsychiatric systemic lupus erythematosus, AMSL, 21. Description: the presence of neurological and psychiatric symptoms in patients with SLE that cannot be attributed to another condition. 22. Epidemiology, found in 40% of patients with SLE. 21. Classification: the American College of Rheumatology has identified 19 AMSL syndromes. 22. Psychiatric SYIC lupus erythematosus. 22 Central nervous system, peripheral nervous system, aseptic meningitis, cerebrovascular disease, demyelination, acute inflammatory demyelinating polyradiculoneuropathy, Guillain-Barré syndrome, headache, chorea, autonomic disorder, hyclopath, single mononeuropathy or mononeuropathy multiplex, Ilopa-us-a myasthenia gravis, seizures equals AOE, cranial neuropathy, plexopathy, polyneuropathy. Acute confusional state, anxiety disorder, cognitive impairment, mood disorder, psychosis. Diagnostics. 21. General principles rule out other common etiologies, example infections, malignancy, adverse drug effects. Back collapse. Find text outline. SAAE diagnostics. 21. Copyright general principles equals rule out other common etiologies, example infections, malignancy, adverse drug effects. Equals consult a neurologist if AMSL is suspected. Copyright imaging studies equals first line studies, MRI brain, T1/T2 weighted, may detect AMSL and also rule out other neurosurgical lesions and infections. Equals consider other studies, example EEG, SPECT, depending on clinical features. Copyright laboratory studies equals CSF examination, request for patients with a suspected neurological infection. Equals serology, antiphospholipid antibodies, ANA's copyright. See also the diagnostics section. Plus treatment, depends on the underlying cause. 21. Antithrombotic and / or antiplatelet therapy for ischemic, embolic, or thrombotic manifestations. Immunosuppressive treatment for inflammatory manifestations, see also the treatment section. CE. Differential diagnoses. Drug-induced lupus erythematosus, DIL, 2329. Description: Lupus-like symptoms triggered by medication. Scent epidemiology. OF equals 2. ODIL accounts for 10% of all SLE cases. EO most common in white populations. Copyright most common in individuals 50 to 70 years of age. 1. Scent etiology. Copyright genetic susceptibility equals presence of a genetic mutation that causes decreased acetyltransferase activity, which results in the slow acetylation of drugs equals presence of HLA-DR2, HLA-DR3, HLA-DR4, or an unexpressed C4 complement allele. Copyright drug triggers 23. High risk, procainamide and hydralazine; low risk, sulfa drugs and certain non-sulfa drugs, example isoniazid, methyldopa, minocycline, phenytoin, TNFA inhibitors. Clinical features, usually manifest equals 1 month after medication initiation. Copyright constitutional, fatigue, fever, and weight loss. O musculoskeletal, myalgia and symmetrical polyarthralgia. Copyright skin lesions, example malar rash. Copyright serositis. Diagnostics 251L degree O ANAs are positive in nearly all patients. Copyright antihistone antibodies equals antihistone antibodies are seen in 90 to 95% of patients. Equals nonspecific, they may also be present in 75% of patients with SLE. Copyright anti-DSNA antibodies, uncommon in patients with DIL scent treatment. Copyright stop the triggering drug. Copyright if necessary, start temporary pharmacotherapy, see the treatment section. Scent prognosis, most cases resolve within a few weeks after the causative medication has been discontinued. And my two hips, methyldopa/minocycline, TNFA inhibitors, hydralazine, isoniazid, procainamide/phenytoin, and sulfa drugs are triggers for DIL. DIL can manifest with various features that are also seen in idiopathic SLE, example fever, arthritis, malar rash, serositis, but typically does not affect the CNS or kidneys, unlike SLE. Undifferentiated connective tissue disease, UCTD. Scent definition, a term used to describe a clinical entity that manifests with features of autoimmunity without fulfilling the criteria for any specific connective tissue disease. Plus classification criteria 24. Copyright clinical features that suggest a systemic autoimmune disease. Copyright positive ANAs on 2 separate occasions. O disease duration of equals 3 years. Scent approach to management, 24. Copyright provide the patient with clear information on the diagnosis. 4. Back collapse fine text outline. Plus approach to management 24. Copyright provide the patient with clear information on the diagnosis. Copyright refer to a rheumatologist for periodical follow-up. Copyright no specific therapy is required, consider symptomatic management. Prognosis, up to 25% of patients with UCTD progress to an identifiable systemic autoimmune disease within 1 to 3 years. 24. Copyright in patients with UCTD, the presence of serositis, fever, and/or anti-SM or anti-DSNA antibodies has been associated with progression to SLE. 25. OOE. Special patient groups. SLE and pregnancy. Plus General 26127 Copyright while fertility is not affected by SLE, it may be affected by immunosuppressive drugs. 5. Copyright pregnancy may trigger flares in disease activity. Copyright increased severity of maternal disease correlates with increased risk of maternal and fetal complications during pregnancy, see complications below. Plus risk assessment 24L27 Copyright cardiac, lung, and kidney screening 27 Copyright serological profile anti-RO/SSA and anti-LA/SSB are associated with an increased risk of neonatal lupus. Anticardiolipin antibodies and lupus anticoagulant, 1 risk of miscarriage and thrombosis-related complications, see antiphospholipid syndrome, Scent Management 27115 Copyright Pregnancy Planning and Counseling, 26 Medical treatment should not be discontinued but the drug regimen may be changed. Preconception, pregnancy, and breastfeeding, hydroxychloroquine and or azathioprine equals disease flares, hydroxychloroquine and or prednisolone FA. Low-dose aspirin from 12 weeks gestation reduces the risk of preeclampsia. 27. Teratogenic immunosuppressive drugs, example methotrexate, mycophenolate, cyclophosphamide, should be avoided. Scent complications 27. maternal equals SLE flares equals hypertension, preeclampsia equals venous thromboembolism. Fetal neonatal equals neonatal lupus syndrome equals miscarriage equals intrauterine growth restriction fetal AV block, 26 equals preterm delivery. Avoid estrogen-containing hormonal contraceptives in patients with antiphospholipid syndrome because of the increased risk of thrombosis. Educate patients of reproductive age about contraceptive methods, planned pregnancy, and the potential teratogenic effects of pharmacological treatment. Neonatal lupus syndrome 261 I-27. Scent general, rare, has a high mortality rate, plus etiology, associated with the transfer of maternal antibodies, anti-RO/SSA and anti-LA/SSB. Scent clinical features copyright first to third degree congenital AV block copyright periorbital or diffuse rash, often presents in the first weeks after birth, Copyright cytopenia C hepatitis, elevated liver enzyme scent diagnostics copyright the following two criteria must be present at birth, antibodies, anti-RO/SSA or anti-LA/SSB, in either the mother or child heart block, characteristic rash, and or hematologic hepatic involvement with no identifiable cause in the newborn fetus scent treatment, directed at specific organ involvement scent prognosis, symptoms usually resolve within a few months. Back collapse fine text outline. 7-6. Complications. Infections, 131L28. Plus responsible for 25 to 50% of deaths in patients with SLE, 28 most common infections copyright bacterial, skin, lungs, and urinary tract copyright viral, varicella zoster virus, cytomegalovirus, and human papillomavirus A. Patients with SLE are at increased risk of developing infections because of disease-related factors, example pancytopenia and or immunosuppressive treatment. Cardiovascular disease, 15. 7. Colonase. Risk of thrombosis in all patients with SLE, especially if secondary antiphospholipid syndrome is present. 1. Colon risk of myocardial infarction and stroke because of accelerated atherosclerosis. Other comorbidities 3129. Liebman-Sachs endocarditis pancytopenia non-Hodgkin lymphoma 4. Osteonecrosis of long bone epiphyses, example osteonecrosis of the femoral head, 81. Interstitial lung disease, pulmonary hypertension medication-induced adverse effects pregnancy-related adverse effects, see SLE and pregnancy in special patient groups below, we list the most important complications. The selection is not exhaustive. 7 shared not. Prognosis. Plus mortality, 10-year survival rate is 90%, 1L29 plus causes of death copyright in early disease equals high disease activity with renal or neurological complications equals infections due to disease-related factors and immunosuppressive therapy copyright in late disease cardiovascular disease 2 degrees equals complications due to atherosclerosis equals coronary artery disease most common cause of death in SLE $32, end-stage renal disease, 9 adverse effects of long-term medication. B and redness in cheeks, malar rash renal disease, infections, and cardiovascular complications are the 3 most common causes of death in SLE. Copyright damage to the kidneys or nervous system is associated with a poor prognosis. OOE. Tips and links. Sources. Last updated August 1, 2023. Back collapse fine text outline. Systemic lupus erythematosus, 1/1. Systemic lupus erythematosus. Etiology: autoimmune disorder, genetic predisposition, HLA-DR2, HLA-DR3, environmental and hormonal factors play a role. Epidemiology. Peak age, 20 to 40 years. Serology: ANA, anti-nuclear antibodies, ESP. Anti-DNA antibodies, anti-RO/SSA antibodies, anti-SM antibodies, anti-phospholipid antibodies. Laboratory findings: J, C3 and C4 complement levels. General symptoms: fever, fatigue, weight loss. Systemic lupus erythematosus fact sheet. Copyright Boss. CNS involvement, psychosis, seizures, personality changes, non-scarring alopecia. NESETE: oral ulcers, chylitis, esophagitis, malar rash, dry eyes, Sicca syndrome, serositis, pleuritis or pericarditis. Lupus nephritis INFGEAE: registered Raynaud phenomenon, #/ in periungual telangiectasia / registered. A. Morning stiffness / myalgia, arthralgia, peripheral neuropathy. A. Malar rash in systemic lupus erythematosus. An erythematous macular rash with adherent keratotic scaling is visible over the nasal bridge, cheek, malar eminence, brow, and chin. The rash has spared the nasolabial fold. Mild chylitis is also visible. This is the characteristic appearance of the malar rash typically seen in systemic lupus erythematosus. Because this rash typically affects both malar eminences symmetrically, resembling butterfly wings, it is also referred to as a butterfly rash. Source: copyright IMPP. Eurosystemic lupus erythematosus, 2/7. Malar rash. Source: Figure 1, in Systemic lupus erythematosus in India, a clinico-serological correlation by Mathur, R, Deo, K, Raheja, A, Curious, licensed. Under CC by 4.0. Eurosystemic lupus erythematosus, 3/7. Macular rash in systemic lupus erythematosus VV. An erythematous maculopapular rash is visible on the lateral aspect of the arm. This is the characteristic appearance of the macular rash in systemic lupus erythematosus, and it typically occurs on sun-exposed areas of the skin. Source: copyright IMPP. Eurosystemic lupus erythematosus, 4/7. Discoid lupus erythematosus. Several sharply defined, partially confluent, erythematous, annular, discoid, lesions are visible. The center of the lesions appears atrophic. Follicular plugging, hyperkeratotic follicles appearing as white spots within the lesions, and scarred, hyperpigmented borders can also be seen. These are the characteristic features of discoid lupus erythematosus, DLE, a chronic, scarring variant of cutaneous lupus erythematosus. DLE lesions are typically pruritic and have a propensity to first appear on the face and neck. Source: copyright IMPP. Discoid systemic lupus erythematosus. Back of a patient with Takayasu arteritis. Several annular, discoid, sharply demarcated, erythematous lesions can be seen. The center of the lesions appears atrophic. These are characteristic features of discoid systemic lupus erythematosus. Source: Figure 1, in Takayasu's arteritis with systemic lupus erythematosus, a rare association by Dhrubajyoti Bandyopadhyaya, Vijayanganesan, Dabarati Bar, Diptak Bhamik, Sibnarayan Sasmal, Kankadika Chaudhary, Subyasachi Mukhopadhyaya, Udraja Hajra, Manas Layak, Parthsarthi Karmakar, Hindawi, licensed under CC by 3.0. Systemic lupus erythematosus, 6/7. Copyright overlay. Periungual telangiectasia in systemic lupus erythematosus. Several dilated capillaries, examples circled, are visible on the periungual skin of the second to fourth fingers of both hands. These findings are consistent with systemic lupus erythematosus but are also seen in other connective tissue diseases. Source: Copyright IMPP. Systemic lupus erythematosus VV. 21-year-old woman with history of SLE and lupus nephritis. The characteristic butterfly rash, an erythematous, mildly scaly, macular rash with nasolabial sparing on buccal area, is visible. A mixed hyperpigmented and hypopigmented scaly skin area on lateral forearm with some erythema consistent with photosensitivity reaction of lupus are visible. B. Source: Fig 1a/b. In seizure as an initial presentation for posterior reversible encephalopathy syndrome in undiagnosed systemic lupus erythematosus and lupus nephritis, a case report by Ethan N. Hartman, Kubertuna, Elio Mansour, Karthi Kram Komanduri, Aneta Teresa Krozek, Curious, licensed under CC by 4.0. Systemic lupus erythematosus, 1/2. Overlay. Red blood cell, RBC, casts in urine sediment V. Photomicrograph of urine sediment, phase contrast microscopy, a tubular cast, blue overlay, is visible in the center of the image. The cast is composed of numerous RBCs, identifiable by their characteristic biconvex shape, examples outlined in yellow, in a matrix of fibrin and plasma proteins. Several epithelial cells surrounding the RBC cast are also visible. RBC casts in urinary sediment are typically seen in glomerulonephritis. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Systemic lupus erythematosus, 1/2. E.J. Wisplinghoff Laboratories. Copyright overlay. Red blood cell, RBC, casts in urine sediment V. Photomicrograph of urine sediment, phase contrast microscopy, a tubular cast, blue overlay, is visible in the center of the image. The cast is composed of numerous RBCs, identifiable by their characteristic biconvex shape, examples outlined in yellow, in a matrix of fibrin and plasma proteins. Several epithelial cells surrounding the RBC cast are also visible. RBC casts in urinary sediment are typically seen in glomerulonephritis. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Systemic lupus erythematosus, 2/2. Lupus band. Fluorescence photomicrograph of skin tissue, immunofluorescence staining, a sharp well-defined band of green immunofluorescence is visible at the dermoepidermal junction. This indicates a positive lupus band test caused by the deposition of immunoglobulins and complement at the dermoepidermal junction. A positive lupus band test is seen in patients with lupus erythematosus. Source: Copyright IMPP. A. Malar rash in systemic lupus erythematosus. An erythematous macular rash with adherent keratotic scaling is visible over the nasal bridge, cheek, malar eminence, brow, and chin. The rash has spared the nasolabial fold. Mild cheilitis is also visible. This is the characteristic appearance of the malar rash typically seen in systemic lupus erythematosus. Because this rash typically affects both malar eminences symmetrically, resembling butterfly wings, it is also referred to as a butterfly rash. Source: Copyright IMPP. Eurosystemic lupus erythematosus, 2/10. Malar rash. Hyperpigmented areas measuring approximate 3 to 4 cm are visible over the patient's cheeks with sparing of the nasolabial folds. This appearance is suggestive of a malar rash, which is typically seen in lupus erythematosus. Source: Figure 1, in Systemic Lupus Erythematosus in India, a clinico-serological correlation by Mathur, R. Deo, K. Raheja, A. Curious, licensed under CC by 4.0. Systemic lupus erythematosus, 3/10. Macular rash in systemic lupus erythematosus VV. An erythematous maculopapular rash is visible on the lateral aspect of the arm. This is the characteristic appearance of the macular rash in systemic lupus erythematosus, and it typically occurs on sun-exposed areas of the skin. Source: Copyright IMPP. Eurosystemic lupus erythematosus, 4/10. Subacute cutaneous lupus erythematosus VV. Symmetrical erythematous plaques are visible on the lateral aspect of the arm, shoulder, and torso. These annular plaques are well circumscribed and scaly. The appearance of the psoriasiform rash in subacute cutaneous lupus erythematosus is often triggered by exposure to UV light. It typically affects the neckline, upper back, arms, and scalp, but spares the face. Source: Copyright IMPP. Eurosystemic lupus erythematosus, 5/10. Subacute cutaneous lupus erythematosus. Numerous partially confluent erythematous macules and plaques are visible over the entire upper back of this patient. Source: Copyright IMPP. Eurosystemic lupus erythematosus, 6/10. Discoid lupus erythematosus. Several sharply defined, partially confluent, erythematous, annular, discoid, lesions are visible. The center of the lesions appears atrophic. Follicular plugging, hyperkeratotic follicles appearing as white spots within the lesions, and scarred, hyperpigmented borders can also be seen. These are the characteristic features of discoid lupus erythematosus, DLE, a chronic, scarring variant of cutaneous lupus erythematosus. DLE lesions are typically pruritic and have a propensity to first appear on the face and neck. Source: Copyright IMPP. Eurosystemic lupus erythematosus, 7/10. Discoid lupus erythematosus. Multiple annular, discoid, sharply demarcated, erythematous plaques, 0.5 to 3 cm in diameter with central atrophy and scaling are visible underneath the right ear. Additional scaly plaques are located on the lobe, helix, and antihelix of the ear. These are the characteristic features of discoid lupus erythematosus, DLE, a chronic, scarring variant of cutaneous lupus erythematosus. DLE lesions are typically pruritic and have a propensity to first appear on the face and neck. Source: Copyright IMPP. Discoid systemic lupus erythematosus. Back of a patient with Takayasu arteritis. Several annular, discoid, sharply demarcated, erythematous lesions can be seen. The center of the lesions appears atrophic. These are characteristic features of discoid systemic lupus erythematosus. Source: Figure 1, in Takayasu's arteritis with systemic lupus erythematosus, a rare association by Dhrubajyoti Bandyopadhyaya, Vijayanganesan, Dabarati Bar, Diptyk Bhaumik, Subnarayan Sasmal, Kankadika Chaudhary, Subyasachi Mukhopadhyaya, Udraja Hajra, Manas Laik, Parthsarthi Karmakar, Hindawi, licensed under CC by 3.0. Systemic lupus erythematosus, 9/10. Lupus band. Fluorescence photomicrograph of skin tissue, immunofluorescence staining. A sharp well-defined band of green immunofluorescence is visible at the dermoepidermal junction. This indicates a positive lupus band test caused by the deposition of immunoglobulins and complement at the dermoepidermal junction. A positive lupus band test is seen in patients with lupus erythematosus. Source: Copyright IMPP. Systemic lupus erythematosus, 10/10. E.J. Wisplinghoff Laboratories. Copyright overlay. Red blood cell, RBC, casts in urine sediment v photomicrograph of urine sediment, phase contrast microscopy, a tubular cast, blue overlay, is visible in the center of the image. The cast is composed of numerous RBCs, identifiable by their characteristic biconvex shape, examples outlined in yellow, in a matrix of fibrin and plasma proteins. Several epithelial cells surrounding the RBC cast are also visible. RBC casts in urinary sediment are typically seen in glomerulonephritis. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Systemic lupus erythematosus, 10/10. Overlay. Red blood cell, RBC, casts in urine sediment v. Photomicrograph of urine sediment, phase contrast microscopy, a tubular cast, blue overlay, is visible in the center of the image. The cast is composed of numerous RBCs, identifiable by their characteristic biconvex shape, examples outlined in yellow, in a matrix of fibrin and plasma proteins. Several epithelial cells surrounding the RBC cast are also visible. RBC casts in urinary sediment are typically seen in glomerulonephritis. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Urosystemic lupus erythematosus, 1/1. Neonatal lupus syndrome VV. Face of a newborn with erythematous rash. Multiple ring-shaped erythematous patches can be seen around the lips, eyelids, and on the forehead. Neither nose or cheeks are affected by the rash. These findings are typical of neonatal lupus syndrome. Source: Fig 1, in Neonatal lupus erythematosus, a cutaneous cases based update by Francesco Savino, Serena Viola, Valentina Tarasco, Emanuela Locatelli, Alberto Ricagna, Paola Capo, BMC, licensed under CC by 4.0. X. Post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis, PSGN, is an acute glomerular inflammation that follows infection with nephrogenic strains of streptococci. Although most commonly seen in children following group A streptococcal tonsillopharyngitis, skin infections such as impetigo may also trigger PSGN. Individuals aged 60 years, especially those with diabetes, malignancy, or alcohol dependency, may also be affected. Deposition of immune complexes within the glomerular basement membrane results in complement activation and subsequent damage to the glomeruli. PSGN typically manifests as nephritic syndrome with hematuria, mild proteinuria, edema, and hypertension. Evidence of recent streptococcal infection, example elevated anti-streptolysin O, ASO, and / or anti-DNase B titers, and low complement levels support the diagnosis. Close monitoring and supportive management of edema and hypertension are usually sufficient. Antibiotic therapy is indicated if there is evidence of active gas infection, primarily to minimize the risk of complications and community spread. While most children recover fully, adults are more likely to develop rapidly progressive glomerulonephritis and / or end-stage kidney disease and may require long-term monitoring. 00° IEEE. Epidemiology. Plus bimodal age distribution, mostly affects children, between the ages of 3 to 12 years, and patients 60 years of age ***. The incidence of PSGN has decreased in developed countries due to the systematic use of antibiotics and improved hygienic standards. Epidemiological data refers to the U.S., unless otherwise specified. WA. OIOE. Etiology. Prior infection with group A beta hemolytic streptococci, gas, scent site of infection. Copyright in children equals infection of the mouth and pharynx, tonsillitis, pharyngitis. PSGN typically arises 1 to 2 weeks following infection. Equals soft tissue infections, erysipelas, impetigo. PSGN typically arises 4 to 6 weeks following infection. Equals osteomyelitis. Degree in adults, the site of infection is usually not the respiratory tract. Infection-associated glomerulonephritis can also occur following other bacterial infections, example with Staphylococcus aureus, Staphylococcus epidermidis, gram-negative bacteria, viral infections, or malaria, and it can also manifest during an acute infection. TI. Infective endocarditis is a common cause of Staphylococcus infection-associated glomerulonephritis, especially amongst individuals who use intravenous drugs. 1-2. OSCE. Pathophysiology. Infection with nephrogenic strains of group A beta hemolytic streptococci immune complexes containing the streptococcal antigen deposit within the glomerular basement membrane, likely involves molecular mimicry, plus complement activation, 1 consumption of complement factors, destruction of the glomeruli immune complex mediated glomerulonephritis and nephritic syndrome. See glomerular diseases for more information. WA. CE. Clinical features. Approximate 50% of patients remain asymptomatic. Symptoms occur approximately 1 to 6 weeks following an acute infection. Scent nephritic syndrome O hematuria, T or cola-colored urine O hypertension, can lead to headaches O edema, prominent facial edema, copyright oliguria plus influenza-like symptoms 1E flank pain. Back collapse fine text outline. Diagnostics. Suspect PSGN in individuals with features of nephritic syndrome and a recent history of gas infection. 1. Initial evaluation IIIS. Scent urinalysis with microscopy, nephritic sediment O hematuria with RBC casts degree proteinuria O pyuria * quantification of proteinuria, typically shows non-nephrotic range proteinuria, 2 cent BMP may reveal, 607 bun, 7 creatinine copyright electrolyte abnormalities CBC, may show normocytic, normochromic anemia 7 * C3 compel it, C4 compel PP it levels, classically shows 4 C3 complement with normal C4 complement allele. Evidence of preceding gas infection, 1. Scent anti-streptococcal antibody titers OT-ASO, FT antidinase B antibodies, 7 anti-hyaluronidase antibodies scent isolation of group A beta hemolytic streptococci degree equals pharyngitis, rapid strep test, throat culture equals skin lesions, wound cultures. Copyright PSGN typically occurs following a gas infection rather than during an active infection. Obtain appropriate diagnostic studies to isolate group A beta hemolytic streptococci only if active infection is suspected. 1. Additional studies. Renal ultrasound, 111. Indications, may be obtained during a diagnostic workup of hematuria findings, typically normal, may show nonspecific increased echogenicity of the renal cortex. Renal biopsy, 121I2. Plus indications, not routinely performed, 4 copyright signs of rapidly progressive glomerulonephritis copyright atypical presentation 1F3 scent supportive findings, proliferative glomerulopathy with immune complex deposits O light microscopy, enlarged and hypercellular glomeruli, copyright immunofluorescent microscopy, granular deposits in the glomerular mesangium and capillaries equals consisting of IgG, IgM, C3 complement. 13 equals lumpy bumpy appearance, also called a starry sky appearance, 4I electron microscopy, immune complexes between the epithelial cell layer and the glomerular basement membrane, referred to as subepithelial humps, 1M trademark, 1312. OO. CE. Differential diagnoses. C. Diseases associated with nephritic syndrome. Back collapse fine text outline. Acid shared node. Treatment. Most cases of PSGN are self-limiting and complications of volume overload are managed with supportive treatment. Supportive care, 1L2. Management of edema and volume overload. Low sodium diet. Antihypertensives, 1-12I2. Plus indicated for hypertension refractory to management of edema and volume overload scent preferred agents include, copyright calcium channel blockers, example nifedipine, EACE inhibitors or ARBs, equals uncertain benefit, given the self-limited nature of PSGN, L2 equals avoid in patients with rapidly progressive renal dysfunction. 1. Exacerbate ACE and hyperkalemia, 12 copyright avoid ACE inhibitors and ARBs in patients with rapidly worsening renal function and / or sudden onset of nephrotic range proteinuria, as these medications can Antibiotic therapy. Antibiotics do not affect the course of PSGN but should be administered in individuals with active gas infection to prevent complications, example abscess, rheumatic fever, and community outbreak of nephritogenic strains of S. pyogenes. 16-cent indication, evidence of active infection, example positive cultures for gas, to prevent NLE regimens, should be based on the site of infection. Copyright gas tonsillopharyngitis, initiate recommended antibiotic regimens for acute gas pharyngitis. Copyright skin and soft tissue infections, example impetigo. Begin empiric antibiotic therapy for skin and soft tissue infections. OOURWE. Complications. Complications are more common in adults. Scent acute renal failure, scent rapidly progressive glomerulonephritis, scent nephrotic syndrome later in the course of the disease. We list the most important complications. The selection is not exhaustive. GFR note. O. Prognosis. E-recovery usually occurs within 6 to 8 weeks. Copyright in children, restitution of kidney function in 90% of cases. In some cases, urinalysis may remain abnormal for extended periods. 1 cent in adults, about 50% of patients suffer from persistently reduced renal function. Your notes. SOD. Tips and links. Sources. Last updated November 18, 2022. Euro post-streptococcal glomerulonephritis, 1/4. Copyright. Overlay. Red blood cell, RBC, casts in urine sediment VV. Photomicrograph of urine sediment, phase contrast microscopy, a tubular cast, blue overlay, is visible in the center of the image. The cast is composed of numerous RBCs, identifiable by their characteristic biconvex shape, examples outlined in yellow, in a matrix of fibrin and plasma proteins. Several epithelial cells surrounding the RBC cast are also visible. RBC casts in urinary sediment are typically seen in glomerulonephritis. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Euro post-streptococcal glomerulonephritis, 2/4. Overlay. Post-infectious glomerulonephritis VV. Microscopic image of a kidney biopsy, PA stain, high magnification, a renal corpuscle surrounded by numerous tubules can be seen in the center of the image. Because the renal corpuscle is markedly enlarged, the space between the glomerular capillaries and the parietal layer of the Bowman capsule, black dashed outline, is narrowed. Within the glomerulus, there is hypercellularity due to proliferation of endothelial cells, yellow arrowheads, and mesangial cells, black arrowheads. Inflammatory infiltrate, predominantly neutrophils, blue arrowheads, and monocytes, white arrowheads, is also present. As a result, the lumina of the capillaries are not clearly identifiable. This is the histopathologic appearance of post-infectious glomerulonephritis. Source: Post-infectious glomerulonephritis, very high mag by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Euro post-streptococcal glomerulonephritis, 3/4. Acute post-streptococcal glomerulonephritis, APSGN. Fluorescence microscopy, immunofluorescence staining for C3, high magnification. Granular deposits of C3 are visible, resulting in a starry sky pattern. Source: Figure 3 in, the role of nephritis-associated plasmin receptor, NAPIR, in glomerulonephritis associated with streptococcal infection. Euro post-streptococcal glomerulonephritis, 4/4. Overlay. Post-infectious glomerulonephritis, PIGN, VV. Transmission electron micrograph, TEM, of renal tissue from a patient with non-HPV associated PIGN. A glomerular capillary containing a red blood cell, red overlay, and an epithelial foot process of a renal podocyte can be seen, green overlay. Multiple hump-shaped electron-dense deposits, arrows, are also apparent. These subepithelial immune complex deposits may be present in PIGN. Blue overlay, nucleus of endothelial cell source, Fig 3, in HPV-associated post-infectious acute glomerulonephritis, a report of 10 cases by Zhang Y, Li J, Peng Wetal, PLOS1, licensed under CC by 4.0. Modifications, image cropped. Post-streptococcal glomerulonephritis, 4/4. Overlay. Post-infectious glomerulonephritis, PIGN, VV. Transmission electron micrograph, TEM, of renal tissue from a patient with non-HPV-associated PIGN. A glomerular capillary containing a red blood cell, red overlay, and an epithelial foot process of a renal podocyte can be seen, green overlay. Multiple hump-shaped electron-dense deposits, arrows, are also apparent. These subepithelial immune complex deposits may be present in PIGN. Blue overlay, nucleus of endothelial cell source, Fig 3, in HPV-associated post-infectious acute glomerulonephritis, a report of 10 cases by Zhang Y, Li J, Peng Wetal, PLOS1, licensed under CC by 4.0. Modifications, image cropped. Juvenile idiopathic arthritis. Juvenile idiopathic arthritis, JIA, formerly called juvenile rheumatoid arthritis, is a broad term for childhood rheumatic diseases that begin before the age of 16 and are characterized by joint inflammation that lasts more than 6 weeks. It is classified into various types based on the pattern of joint involvement, the presence of extra-articular manifestations, example uveitis, rash, nail changes, lymphadenopathy, hepatosplenomegaly, laboratory findings, and disease prognosis. Oligoarticular JIA, which is the most common type, presents with asymmetric involvement of up to 4 joints, with the knee joint most often affected. Nearly half of all cases of oligoarticular JIA are associated with anterior uveitis, which may be diagnosed by slit lamp examination. Laboratory tests such as ESR, rheumatoid factor, RF, anti-nuclear antibodies, ANA, and the HLA-B27 antigen test are used to classify and determine the prognosis of JIA. Treatment of JIA is similar to that of adult rheumatoid arthritis and involves the use of NSAIDs, intra-articular steroid injections, and disease-modifying antirheumatic drugs, DMARDs, such as methotrexate. Systemic glucocorticoid therapy should be avoided because of the risk of growth impairment. OSRO, EXO. Epidemiology. Plus prevalence, 1:1000 children J-cent sex, 2 cent age of onset. WA. And etiology. Cent idiopathic immunological predisposition, different HLA associations to its copyright oligoarticular JIA, HLA-DR8, HLA-DR5 copyright polyarticular JIA, HLA-DR4O emphasis associated and psoriatic JIA, HLA-B27 cent possibly triggered by a viral or bacterial infection. Exposure to antibiotics during childhood may increase the risk of JIA. Your note degree. Pathophysiology. Autoimmune and/or autoinflammatory disease, chronic synovial inflammation with infiltration of plasma cells, B lymphocytes, and T lymphocytes, joint capsule hyperplasia, growth of fibrovascular connective tissue, pannus, invasion of the articular surface, loss of joint function. 4. AY. Phe, rise equals QO. Shared note. Clinical features. For the exact pattern of joint involvement and specific extra-articular symptoms, see subtypes and variants below. Cent arthritic symptoms, copyright swollen joints, rarely erythema, copyright early morning stiffness, copyright limited or painful joint movement plus extra-articular manifestations. O fever, 4 = 2 weeks, O uveitis, O rash, O nail changes, O lymphadenopathy, O hepatosplenomegaly. Cent nonspecific features, Copyright excessive crying lethargy decreased scholastic performance. Back collapse fine text outline. O excessive crying lethargy. Decreased scholastic performance copyright growing pains. The affected joints are often stiff in the morning or after longer periods of inactivity, example sitting. Joint stiffness improves with movement and decreases later in the day. Subtypes and variants. Relative upsal frequency. Asterisk most common, form oligoarticular, accounts for 50% of all GIA cases. Seronegative, 30% of polyarticular GIA cases. Seropositive. Systemic GIA, 19% of, still disease, asterisk A cases WW. Asterisk. Enthesitis asterisk 10% of related GIA cases. Back. Peak incidence. Asterisk 2 to 4 years. Asterisk 1 to 4 years and 6 to 12 years, bimodal incidence. 2 to 4 years 8. Asterisk 2 years and 6 to 14 years, bimodal incidence. Classification of juvenile idiopathic arthritis ALS. Sex definition. Arthritis involving more than 25 joints within 6 months of disease onset. Arthritis involving equals 1 joint N. That lasts for at least 2 weeks equals with fever spikes occurring on at least 3 consecutive days and 21 extra articular. Q4O. Manifestation. Arthritis and psoriasis. Or arthritis and 2 of the following features, OE-GO-A, 2:1. Copyright dactylitis copyright nail changes, pitted nails, onycholysis, psoriasis among first-degree relatives. Degree. R. Intermittent fever. Pattern of joint extra-articular. Asymmetrical pattern large, weight-bearing joints, knee and ankle, are usually affected. 1. Symmetrical or asymmetrical asterisk cervical spine and temporomandibular joints are also affected. Asterisk symmetrical. Asterisk monoarthritis, oligoarthritis, and polyarthritis possible, most commonly. Affects equals 2 joints, I, asterisk often involves knees, ankles, and wrists. Asymmetrical. Asterisk asymmetrical I. E. Collapse. Asterisk chronic anterior uveitis asterisk. Copyright seen in 25% of oligoarticular GIA cases bilateral involvement is degree. Common. Chronic anterior uveitis asterisk co. Rheumatoid nodules on the extensor surface of elbows and the Achilles tendon, 30% of cases. Transient, migratory, macular, salmon pink rash FH asterisk generalized lymphadenopathy asterisk splenomegaly and / or hepatomegaly serositis, peritonitis, pleuritis, and / or pericarditis. Chronic anterior uveitis asterisk fonale changes psoriatic skin lesion often appear after the onset of arthritic symptoms EA. Acute anterior uveitis anterior asterisk CL associated with chronic inflammatory bowel disease may progress to ankylosing spondylitis. BY find ETRP plus NSAIDSNL. Scent negative RF, plus mostly good yo steroids EA asterisk positive ANA, SVC SIL injection 70% of cases, scent possibly methotrexate. Asterisk variable degree TESR clinical scent negative RF course and a scent positive ANA, high risk of 40% of cases, functional limitation standard therapy with scent persistent methotrexate disease with an NSAIDS periodic plus ESR exacerbation equals and a high asterisk positive RF, 7 risk of progressive joint destruction. Degree MESR NSAIDS scent the clinical TT acute phase poor response course is reactants, example to highly CRP ferritin, methotrexate variable. Scent anemia, and TNF asterisk complete leukocytosis, inhibitors remission and, etanercept, occurs in 40 thrombocytosis adalimumab, 50% of cases. Asterisk RF negative AFA. Anative, I positive, in NSAIDs and 50% of cases. Intra-articular scent HLA-B27 May. Scent mostly good a steroid B positive A, injections RF negative. NSAIDs and intra-articular asterisk HLA-B27 steroid positive, in 80% injections 2 mostly good of cases, asterisk sulfasalazine RF negative may be used instead of methotrexate. A. Find text. Al. Outline. Ad. A prerequisite for the diagnosis of all forms of GIA is that arthritic symptoms begin before the age of 16 and last 2 to 6 weeks. Lap == and an asterisk equals. I. G degree ES. Diagnostics. The clinical diagnosis of GIA can be supported by a number of diagnostic tests. Laboratory tests. Blood tests are used to classify GIA, assess the prognosis, and rule out other similar conditions, see subtypes and variants above. Plus autoantibodies levels, 0, a rheumatoid factor, RF, equals absent in most cases of GIA, except seropositive polyarticular GIA, equals associated with poor prognosis degree 7 ANA equals most commonly associated with oligoarticular GIA, 70%, equals incidence of anterior uveitis increases when antinuclear antibodies, ANA, are present. Copyright anti-CCP antibodies, indicate a poor prognosis 1 cent acute phase reactants 07 ESR, usually seen with all forms of GIA 01 CRP ferritin, usually associated with systemic GIA CBCO anemia 1 leukocytosis degree copyright thrombocytosis, denotes a more severe inflammatory response in polyarticular and systemic GIA. Imaging tests. Plus ultrasound 12O used to detect synovial hypertrophy and intra-articular fluid collections degree best imagistic tool for the detection of early bone erosions X-ray 3O may be used for the identification of GIA complications copyright should not be performed routinely other diagnostic tests. Scent synovial biopsy copyright can provide a definitive diagnosis of GIA 4E shows infiltration of plasma cells, B lymphocytes, and T lymphocyte slit lamp examination, should be performed for regular ophthalmological screening in patients with anterior uveitis, A19, plus slit lamp examination, 5IL10 copyright patients with a high risk of developing anterior uveitis, ANA positive, age of onset. Anterior uveitis that occurs with GIA may be asymptomatic, especially in the case of chronic anterior uveitis. However, untreated anterior uveitis is associated with a high risk of developing glaucoma, cataracts, and optic nerve damage. Therefore, early detection via slit lamp examination and swift initiation of treatment are of paramount importance. FOE. Differential diagnoses. The differential diagnosis of GIA includes other causes of non-suppurative arthritis in children, 16 cent acute lymphocytic leukemia plus reactive arthritis 1. Back collapse find text outline. Acute lymphocytic leukemia cent reactive arthritis acute rheumatic fever e juvenile ankylosing spondylitis connective tissue disease, example SLE, Sjogren syndrome, cent trauma cent hemophilia. The differential diagnoses listed here are not exhaustive. WA. FA, IEEE. Treatment. Definitive therapy. First line therapy 71. NSAIDs copyright indomethacin equals commonly used, highly effective in the treatment of GIA equals has severe side effects, headaches, renal failure, and bone marrow depression copyright other commonly used NSAIDs, naproxen, ibuprofen, meloxicam, celecoxib, and tolmedin sent local intra-articular steroids, example triamcinolone indicated in the case of active arthritis. Second line therapy. Plus disease-modifying antirheumatic drugs, DMARDs, 8. Copyright therapy with DMARDs should be started as early as possible in the case of high disease activity. A copyright DMARD of choice is determined on an individual basis with methotrexate being used in most cases. 1 cent biologic agents copyright indicated if the response to DMARDs is poor. Examples: etanercept, adalimumab, tocilizumab, anakinra, cent systemic glucocorticoid therapy, oral, 4, 19 rarely used in children because of the risk of catabolic side effects, example osteoporosis, growth impairment. Copyright a short course of systemic glucocorticoid therapy may be prescribed in the following situations: severe systemic involvement, example severe serositis, C-still disease, as bridge therapy when DMARDs are initiated, acute anterior uveitis, macrophage activation syndrome supportive therapy. Scent physiotherapy, to prevent joint deformities, scent surgery, splints, and/or orthotics, to correct limb length discrepancy and/or joint deformities. Copyright most drugs that are used to treat adult rheumatoid arthritis may be used to treat GIA as well, see therapy in rheumatoid arthritis. However, certain forms of therapy, example systemic glucocorticoid therapy, should, as a rule, be avoided in children. OES. Complications. Scent articular complications, copyright joint destruction, joint subluxation and/or deformities, example swan neck deformity, boutonniere deformity, limb length discrepancy, copyright growth retardation. Scent extra-articular complications, copyright chronic anterior uveitis, blindness, copyright pericarditis, pleuritis, copyright macrophage activation syndrome, MAS, 4-array complication of CHIA, most commonly systemic CHIA, characterized by thrombocytopenia, elevated transaminases, low fibrinogen, and markedly increased ferritin levels in a patient with systemic CHIA, the presence of a normal or decreased WBC count, falling ESR, and/or increased triglyceride levels should raise the suspicion of MAS. Back collapse, fine text outline. Plus disease-modifying antirheumatic drugs, DMARDs, 8. Copyright therapy with DMARDs should be started as early as possible in the case of high disease activity. Copyright the DMARD of choice is determined on an individual basis with methotrexate being used in most cases. 1 cent biologic agents copyright indicated if the response to DMARDs is poor. Examples: etanercept, adalimumab, tocilizumab, anakinra, cent systemic glucocorticoid therapy, oral, 4, 19 copyright rarely used in children because of the risk of catabolic side effects, example osteoporosis, growth impairment. Copyright a short course of systemic glucocorticoid therapy may be prescribed in the following situations: severe systemic involvement, example severe serositis, C-still disease, as bridge therapy when DMARDs are initiated, acute anterior uveitis, macrophage activation syndrome supportive therapy. Scent physiotherapy, to prevent joint deformities, surgery, splints, and/or orthotics, to correct limb length discrepancy and/or joint deformities. Copyright most drugs that are used to treat adult rheumatoid arthritis may be used to treat GIA as well, see therapy in rheumatoid arthritis. However, certain forms of therapy, example systemic glucocorticoid therapy, should, as a rule, be avoided in children. 270E. Complications. Articular complications, joint destruction, joint subluxation and/or deformities, example swan neck deformity, boutonniere deformity, limb length discrepancy. Copyright growth retardation. 1 cent extra-articular complications, copyright chronic anterior uveitis, blindness, copyright pericarditis, pleuritis. Macrophage activation syndrome, MAS, 4, array complication of CHIA, most commonly systemic CHIA, characterized by thrombocytopenia, elevated transaminases, low fibrinogen, and markedly increased ferritin levels. In a patient with systemic CHIA, the presence of a normal or decreased WBC count, falling ESR, and/or increased triglyceride levels should raise the suspicion of MOS. We list the most important complications. The selection is not exhaustive. O*2 shared N. Prognosis. The clinical course and prognosis are highly variable, see subtypes and variants above, C1. Most cases, 95%, resolved by puberty. Scent factors associated with a poor prognosis 7, early onset copyright prolonged active systemic disease copyright hip and/or wrist involvement copyright polyarticular involvement symmetrical disease presence of RFO presence of anti-CCP antibodies. Early disease onset is associated with a greater degree of growth impairment and deformity. FO. STD notes MANA. Sources. Last updated September 7, 2022. Back collapse fine text outline. Seronegative polyarthritis. 2 to 4 years of age 7 to 10 years of age 9 to 12 years of age 2D2D7 *D. Pattern of joint involvement and iridocyclitis in juvenile idiopathic arthritis, CHIA, VV, oligoarthritis, asymmetrical oligoarthritis involving systemic juvenile idiopathic arthritis, still disease. Etiology idiopathic. Epidemiology 2G peak age of onset, 2 to 4 years. Serology typically negative for autoantibodies. Laboratory studies anemia, leukocytosis, thrombocytosis. Complications macrophage activation syndrome, MOS. Intermittent fever. Generalized lymphadenopathy. Serositis, pleuritis/pericarditis/peritonitis. A. My. FLL transient, salmon pink rash. Systemic juvenile idiopathic arthritis, still disease, fact sheet. Copyright on BOS. Hepatomegaly and/or splenomegaly. Arthritis, synovitis, knees, ankle, and small joints of the hand. Enthesitis-related psoriatic CHIA. Systemic CHIA. \4ZSYI\D. 8 anterior uveitis _IESS equals. Migratory, \of salmon-colored \foo\Fe enthesitis. 2 years and 6 to 14 years QD. Systemic psoriatic and enthesitis-related juvenile idiopathic arthritis, CHIA. Commonly involved joints for each subtype are highlighted in red. Also illustrated in systemic CHIA are pyrexia, and the extra-articular manifestations of lymphadenopathy, serositis, pleuritis, peritonitis, and/or pericarditis, and hepatosplenomegaly. Note, anterior uveitis in psoriatic CHIA is commonly bilateral and chronic, while in enthesitis-related CHIA it more commonly manifests as unilateral flare UPS. Copyright on BOS. X-reactive arthritis. Reactive arthritis, formerly known as Reiter's syndrome, is a post-infectious autoimmune condition that is most commonly preceded by bacterial infection of the gastrointestinal or urinary tract. It is categorized as a seronegative spondyloarthropathy and is associated with HLA-B27. Reactive arthritis often affects young adults and manifests with musculoskeletal and/or extra-articular symptoms. The classic triad of arthritis, conjunctivitis, and urethritis is only seen in about 1/3 of patients. The diagnosis is based on clinical features such as patient history and physical examination and may be supported by laboratory or imaging findings, although there are no specific confirmatory tests for reactive arthritis. Reactive arthritis usually resolves spontaneously within 6 to 12 months. Treatment during this acute phase is primarily supportive, example NSAIDs for arthritis. Underlying infections should be identified and treated. A small proportion of patients develop severe or chronic arthritis. For these individuals, systemic corticosteroids or disease-modifying antirheumatic drugs, DMARDs, may be required. Pass equals ZO * OE. Epidemiology. Genetic predisposition and association with HLA-B27, C. seronegative spondyloarthritis, * commonly affects young men. 61.23% HIV infection is associated with an increased risk of reactive arthritis. Epidemiological data refers to the U.S., unless otherwise specified. CES. Etiology. For post-infectious autoimmune disorder, scent posturearthritis, after infection with chlamydia, common, or ureaplasma ureolyticum * postenteritis, after infection with Shigella, Yersinia, Salmonella, or Campylobacter FL * in rare cases, after infection with Bartonella hensleyi, registered. CE, she cherishes cooking yummy salmon. Shigella, chlamydia, Campylobacter, Yersinia, and Salmonella are the most common causes for reactive arthritis. CE. Clinical features. LEL. Scent latency period, 1 to 4 weeks. Scent musculoskeletal symptoms. Copyright oligoarthritis, sometimes polyarthritis, equals acute onset, equals often asymmetrical with a migratory character, equals occurs predominantly in the lower extremities. Copyright sacroiliitis o enthesitis. Copyright dactylitis e extra-articular symptoms. Copyright conjunctivitis, iritis, episcleritis, or keratitis. 2 Copyright dermatologic manifestations. Equals balanitis circinata, skin lesions of the glands resembling psoriasis. Ha equals keratoderma blenoragicum, hyperkeratinization of the palms and soles. Copyright urethritis. Copyright oral ulcers. Copyright cardiac manifestations. IU aortic regurgitation. 5-7 equals atrioventricular blocks, equals pericarditis. Back collapse. Fine text outline. Symptoms from preceding infection. Cf. Copyright diarrhea. Copyright urogenital tract symptoms, dysuria, pelvic pain, prostatitis. At classic triad of reactive arthritis, seen in approximately 1/3 of affected individuals. Can't see, conjunctivitis, can't pee, urethritis, can't climb a tree, arthritis. Copyright. CE. Diagnostics. Overview. Reactive arthritis is primarily a clinical diagnosis. 6 laboratory studies and imaging typically show nonspecific signs of inflammation. Further studies may be necessary to identify underlying infections, example via stool culture, urethral swabs, exclude differential diagnoses of reactive arthritis, example rheumatoid factor, arthrocentesis and synovial fluid analysis, laboratory studies, ILL. Scent blood tests. Copyright CBC, TTWBC, *platelets. 60 inflammatory markers, 7 ESR, TCRP 5111 rheumatoid factor or anti-CCP antibodies, -19 arthrocentesis with synovial fluid analysis, 6, OTWBC count, 5000-50,000/mm*, neutrophil predominant. Copyright gram stain and cultures, typically negative. Copyright crystals, absent, i.e. stool culture, scent culture for Shigella, Yersinia, Salmonella, and Campylobacter. EST testing. Copyright perform NAAT on urine or urogenital samples for genitourinary chlamydia. Copyright consider HIV testing. As with other seronegative arthropathies, there is an association between reactive arthritis and HLA-B27. Approximately 50 to 80% of HLA-B27 tests are positive in patients with reactive arthritis. However, HLA-B27 testing is not required to diagnose reactive arthritis and does not change the management of the condition. 16. 3. Genitourinary chlamydia infection is frequently asymptomatic, have a low threshold for testing for chlamydia in patients with reactive arthritis. U1. Imaging, 19LL1. Suspected arthritis or recommended modality, X-ray of affected region, S. Copyright findings, may show erosions and bone proliferation. Suspected synovitis or enthesitis. Recommended modalities, MRI with 4 gadolinium or ultrasound. Copyright findings, may include synovial hypertrophy, hypervascularization of soft tissue, tendon thickening. Additional studies. C-cent degree pected cardiac manifestation copyright ECG to screen for atrioventricular blocks and pericarditis degree echocardiogram for aortic regurgitation suspected ocular manifestations, slit lamp examination for keratitis and anterior uveitis. Back collapse fine text outline. Aortic regurgitation can be fatal if missed, request an echocardiogram if there are any concerning clinical features. Treatment. Overview. Acute reactive arthritis. Degree management is primarily supportive as reactive arthritis is typically self-limiting. Identify and treat underlying infections, example genitourinary chlamydia. Refer patients to rheumatology and physiotherapy. Chronic reactive arthritis, i.e., persistence of symptoms 6 months, or severe disease, DMARDs, example sulfasalazine, may be required. Supportive therapy. Plus NSAIDs, first-line treatment for all symptomatic patients 11. Sent glucocorticoids, indicated in patients with inadequate response or contraindications to NSAIDs. DMARDs, indicated in patients with chronic, 6 months, or severe disease 12. Management of underlying infections, 1 lel. Sent treat active infections. Sent for sexually transmitted infections. Copyright perform contact tracing for sexual partners and offer testing. Copyright Council on Safer Sex Practices. Differential diagnoses. Infection-associated arthritis 20. Condition reactive arthritis. C. Trichomonas enterobacteria causative degree Shigella pathogen degree Yersinia copyright Salmonella degree Campylobacter. Recent gastrointestinal or urinary tract infection 1 risk factors plus HLA-B27, C. seronegative spondyloarthritis, young men. Onset acute. Reactive arthritis triad degree arthritis copyright conjunctivitis degree urethritis clinical PF hires * symptoms may include, degree sacroileitis degree enthesis copyright dactylitis copyright conjunctivitis. Copyright oligoarthritis EO asymmetrical distribution pattern degree migratory o lower body, especially knee. Back. Differential D of infecti aseptic arthritis gonococcal, disseminated non-gonococcal. S. aureus streptococci gram-negative rods copyright E. coli EOP aeruginosa. 4 drug use plus immunodeficiency joint replacement. Acute. Articular inflammation fever pain impaired range of motion. Monoarthritis mostly knees, hip, wrists. Gonococcal infection, 23. And gonorrhea. High sexual activity unprotected sex men who have sex with men, MSM. Women, 4:1. Variable 251. Arthritis dermatitis syndrome copyright polyarthralgias copyright tenosynovitis degree dermatitis copyright fever, chills purulent gonococcal arthritis copyright inflammation of up to 4 joints. Polyarthralgias, ADS, degree asymmetrical degree migratory E large and small joints monoarthritis, also oligoarthritis/polyarthritis, OE asymmetrical O frequently affected joints, 26 equals knees equals ankles W via collapse. D arthritis 91121. Lyme disease 22. B Bergdorferi 1. Frequent outdoor activities, example hunters, farmers, hikers. Progressive. Stage IL degree migratory arthralgias copyright carditis copyright, facial, nerve palsy E early neuroborreliosis stage IL copyright chronic arthritis degree aseptic meningitis copyright late neuroborreliosis. Polyarthropathy O asymmetrical degree migratory copyright intermittent or persistent copyright large joints, knee, elbow. A. Fine text. Syphilitic arthritis. Copyright T. pallidum. Asterisk congenital syphilis asterisk MSM asterisk HIV infection 24. Asterisk progressive. Asterisk secondary syphilis. Degree syphilitic arthritis epiphysitis, osteochondritis para-articular swelling bilateral intermittent hydroarthrosis of the knee. Degree. Asterisk polyarthralgia, migratory. Outline. Div ID of iiated arthritis 91L21. Septic arthritis condition reactive arthritis gonococcal, disseminated Lyme disease, 22 syphilitic arthritis non-gonococcal EEE 23 gonococcal infection. Asterisk C Trichomonas _ S aureus enterobacteria. Streptococci causative copyright Shigella copyright Gram negati equals S. Gadav rods and gonorrhoe E asterisk B Burridorferi, copyright T pallidum pathogen copyright Yersinia, AAP copyright E. coli degree Salmonella 5 EOP aeruginosa degree Campylobacter Z. Asterisk recent gastrointestinal or high sexual activity urinary tract infection for drug use unprotected sex asterisk congenital syphilis asterisk frequent outdoor activities, example risk factors plus HLA-B 27, C seronegative asterisk immunodeficiency asterisk men who have sex with men, asterisk MSMSE equals hunters, farmers, hikers, spondyloarthritis, plus joint replacement, MSM, asterisk HIV infection 24 asterisk young men asterisk women, 4:1. Onset acute plus acute asterisk variable 25 progressive. Asterisk reactive arthritis triad asterisk stage LL copyright arthritis plus arthritis dermatitis syndrome degree migratory arthralgias asterisk secondary syphilis copyright conjunctivitis, E polyarthralgias degree carditis copyright syphilitic arthritis copyright urethritis. Inflammatory GN degree tenosynovitis copyright, facial, nerve palsy copyright epiphysitis clinical plus fever ITIISC, AX symptoms may include, pain degree dermatitis degree early neuroborreliosis osteochondritis degree fever, chills I copyright sacroiliitis plus impaired range of motion stage ill degree para-articular swelling O emphasis asterisk purulent gonococcal arthritis copyright chronic arthritis copyright bilateral intermittent degree dactylitis degree inflammation of up to 4 joints copyright aseptic meningitis hydroarthrosis of the knee E conjunctivitis E. Late neuroborreliosis. Scent polyarthralgias, ADS. EO asymmetrical degree migratory copyright large and small joints asterisk oligoarthritis WN polyarthropathy plus monoarthritis, also distribution. Pattern. Degree. SFMITICA. Maitrutri. Plus. Monoarthritis. Mostly knees, hip, wrists. Oligoarthritis / polyarthritis. Asymmetrical. Degree. Asymmetrical. Siaptitary. A. 9 yen 9y copyright lower body, especially 261 copyright intermittent or persistent knee, copyright frequently affected joints, copyright large joints, knee, elbow, equals knees equals ankles equals wrist equals elbow. Arthrocentesis and culture. Plus empiric antibiotic therapy initial arthritis, oral antibiotics asterisk self-limiting disease for septic arthritis equals. Degree doxycycline asterisk only symptomatic treatment, evacuation of purulent ZAE, asterisk ceftriaxone IM or 4+E amoxicillin. A treatment NSAIDs material asterisk benzathine penicillin G step-up therapy, glucocorticoids or DMARDs Taylor therapy according to Gram stain C treatment of septic arthritis. Doxycycline Po degree cefuroxime. Recurrent arthritis, ceftriaxone 4. Non-infectious arthritis 2 degrees. Scent rheumatoid arthritis. Asterisk other seronegative spondyloarthritis asterisk crystal-induced arthritis, i.e., gout, pseudo-gout. Asterisk systemic lupus erythematosus. The differential diagnoses listed here are not exhaustive. G. OO and prognosis. SENT resolves spontaneously within a year. SENT high rate of recurrence J. GVU. OOSO. Tips and links. Sources. Back collapse find text. O. Outline. Reactive arthritis extra-articular symptoms. Epidemiology for YE at most commonly affects young men SE/E associated with HLA-B27/etiology/musculoskeletal symptoms at post-infectious autoimmune disorder conjunctivitis, at frequently a complication of genitourinary uveitis sacroileitis, example chlamydia, or gastrointestinal, example Shigella, infection, //. Diagnostics I/FR while at primarily clinical diagnosis X7 /IEST testing for patients at risk / at treatment +++____-7 tol, LEL at self-limiting condition, sent /Han Eli degree at supportive treatment, example NSAIDs, 4, AEQOIY7 dactylitis. Urethritis. Asymmetrical, migratory oligoarthritis. Enthesitis. Reactive arthritis fact sheet VV. Copyright on Boss. Knee effusion VV. The right knee and area around the knee is markedly swollen and slightly erythematous. Source, Knee Fusion by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Modifications, arrow removed. Conjunctivitis VV. Left eye significant conjunctival injection is visible. There is increased tearing visible in the inferior fornix. These findings are typical for conjunctivitis. The absence of purulent secretion suggests a viral infection, although conjunctival injection can also be caused by various other conditions. Source, Conjunctivitis by Raimundo Pastor, Wikimedia Commons, licensed under CC by 4.0. Anfe, C equals Fa, 2 ES pi equals ENI, equals IO. Smiley face, pi FAAI, smiley face, ion NEIO. These findings are typically associated with rheumatic diseases such as reactive arthritis. Several ulcerated, small, flat lesions are visible. Photograph of the glans penis. Balanitis circinata. Uroreactive arthritis, 4/4. Keratoderma blenoragicum VV. Solace of an adult patient with reactive arthritis. Multiple hyperpigmented papules and plaques are visible on the solace of the forefoot. The glabrous skin of the forefoot appears thickened and scaly, hyperkeratosis. This is the typical manifestation of keratoderma blenoragicum, a cutaneous eruption seen in a third of patients with reactive arthritis, Reiter's syndrome. Source, Feet Reiter's syndrome, Dr. M. F. Rain, Wikimedia Commons licensed under public domain. Uroreactive arthritis, 1/2. Overlay. Synovitis of knee joint MRI knee, T1 weighted, sagittal view, there is hyperintense thickening of the synovial membrane, marked with X, and a joint effusion, green overlay. The sharply demarcated hypointense lesion visible dorsally, marked with Y, is most likely a Baker cyst. Source, copyright IMPP. Uroreactive arthritis, 1/2. Copyright overlay. Synovitis of knee joint MRI knee, T1 weighted, sagittal view, there is hyperintense thickening of the synovial membrane, marked with X, and a joint effusion, green overlay. The sharply demarcated hypointense lesion visible dorsally, marked with Y, is most likely a Baker cyst. Source, copyright IMPP. Uroreactive arthritis, 2/2. Anterior uveitis VV. Slit lamp examination of the anterior part of the eye iris details are blurred. This indicates inflammatory infiltration of the anterior chamber. Keratic precipitates, originating from inflammatory material, are present on the endothelium of the cornea. These are typical signs of anterior uveitis. Source: Copyright IMPP. X. Angioedema. Angioedema is a self-limited, localized swelling of the dermis, subcutaneous tissues, and/or submucosal tissues caused by fluid leakage into the interstitial tissue. It is mediated by vasoactive substances and can be classified as histamine-mediated, often secondary to allergic reactions, and NSAIDs, bradykinin-mediated, due to ACE inhibitor use or enzyme deficiencies, or unknown, idiopathic. Patients usually present with swelling of the eyelids, lips, and tongue. However, life-threatening laryngeal edema may occur, which requires immediate airway protection. Treatment generally consists of aggressive supportive care and avoidance of triggers, if applicable. In acute cases, histamine-mediated angioedema is treated with systemic glucocorticoids, antihistamines, and, if necessary, epinephrine for anaphylaxis. Bradykinin-mediated angioedema is treated with C1 inhibitor, C1-INH, concentrate, bradykinin bireceptor antagonists, or kallikrein inhibitors. 7 *. OOIEEE. Overview. Histamine-mediated angioedema and Rene I. 12. OE bradykinin-mediated angioed. Hereditary angioedema types I3 acquired angioedema onset cent minutes cent hours. Duration *12 to 24 hours *24 to 48 hours. Après in 90 years cent acquired C1-INH deficiency, 40 years. O. Family history possible common uncommon. Plus IgE mediated, copyright food allergens degree drugs, example NSAIDs, and antibiotics, copyright stinging insects cause, autosomal dominant degree latex 2 inheritance acquired C1-INH deficiency direct mast cell activation 3R trigger copyright medications 1 cause/trigger 3L4 degree drugs estrogen fluctuation, copyright lymphoproliferative or autoimmune equals NSAIDs copyright infection L disorders equals opiates RRPE degree mental 4 * ACE inhibitor induced, AC inhibitors 11 equals radio contrast agents. I copyright physical equals exercise equals temperature equals vibration equals UV radiation. Prodrome, no common uncommon. Laryngeal edema. Extremity or truncaledema equals. Pogsiple common gastrointestinal symptoms associated, smiley face, symptoms bronchospasm urticaria common uncommon hypotension. RESP to DARD phylaxy, EA good poor. RA. FO, so. Classification. Histamine-mediated angioedema, mast cell-mediated angioedema, 1112. Scent direct mast cell activation non-LGE mediated copyright possible triggers, NSAIDs, most commonly aspirin, opiates, radio contrast media scent allergic reactions copyright IgE mediated copyright possible triggers, food, insect bites/stings, antibiotics, latex, NSAIDs, less commonly, other allergens, physically induced 1O family history of atopy. Bradykinin-mediated angioedema 8L2. Back collapse fine text outline. LT bradykinin-mediated angioedema, percent, L2. Hereditary angioedema, inherited C1 inhibitor deficiency, O autosomal dominant inheritance degree clinical manifestations in childhood or adolescence O possible triggers, estrogen fluctuation, example OCPs, hormone replacement, menstruation, ovulation, and pregnancy, infection, example H. pylori, mental stress/fatigue, physical exertion, trauma, surgical and dental procedures, drugs, example ACE inhibitors, and weather changes 3-4, scent acquired angioedema, acquired C1 inhibitor. Deficiency, copyright presents in advanced or middle age, usually in or after the fourth decade of life, copyright often associated with lymphoproliferative diseases and B-cell malignancies, scent ACE inhibitor induced, rarely ARB-induced impaired bradykinin breakdown. Angioedema of unknown cause IL-2. Scent idiopathic angioedema, O recurrent episodes without known cause. Copyright possible triggers, cold, heat, stress, and exercise. Scent infections. Copyright more common in children. Copyright possible triggers, common cold, streptococcal pharyngitis, urinary tract infections. Scent drug induced, calcium channel blockers, fibrinolytics, immunosuppressive agents, example tacrolimus. OOCE. Clinical features. Common symptoms. Scent facial edema, mouth, eyelids, tongue, scent laryngeal involvement, dyspnea and inspiratory stridor, potentially life-threatening scent. Possible swelling of extremities and urogenital area, example hands, feet, scrotum, histamine-mediated angioedema. Scent often associated with urticaria and pruritus. Scent other associated with clinical findings of allergic reactions, see type 1 hypersensitivity reaction. Scent onset within 30 minutes to 2 hours of exposure and resolution over hours to days. Bradykinin-mediated angioedema. Scent family history often present, hereditary angioedema, scent abdominal symptoms, colicky abdominal pain, nausea/vomiting, diarrhea. Angioedema of the extremities or trunci not associated with urticaria or pruritus. References, /1. OE. Diagnostics. Scent initial evaluation. Copyright. The diagnosis is mainly based on history and clinical findings, plus further evaluation, indicated for follow-up or if the etiology is unclear. 2 IL-6180 laboratory studies equals serum mast cell tryptase, increased in histamine-mediated angioedema equals evaluation of C1-INH deficiency in bradykinin-mediated angioedema, see table below. Back collapse. Fine text outline. Copyright imaging, not routinely recommended. Type LC1-INH level JC1-INH function LC4 level, 4 during acute attack C1Q level normal. O or differential diagnoses. Hereditary angioedema type LL normal L4 during acute attacks normal. Type IL normal 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 normal. Anaphylaxis is the most important differential diagnosis, see differential diagnoses of anaphylaxis. The differential diagnoses listed here are not exhaustive. WA. OE. Management. Emergency management FLL2I91I10. Scent evaluate for anaphylaxis, see anaphylaxis diagnostic criteria. O if there is concern for anaphylaxis, equals give IM epinephrine. 6. Acquired angioedema ACE inhibitor induced C1-INH deficiency normal 1 normal abnormal I normal. Equals start aggressive supportive care, example for fluids, supplemental oxygen. See treatment of anaphylaxis for the full algorithm. Airway management. O if airway compromise is present, equals see airway management and ventilation in anaphylaxis. Equals call anesthesia/otolaryngology for help. Equals prepare for difficult airway with rescue devices and set up for surgical airway. Scent stop any potential triggers, remove potential exposures or offending medications, example ACE inhibitors. Copyright if airway compromise is suspected, stridor, wheezing, diminished air movement, or the patient is in shock, administer IM epinephrine immediately, start oxygen and 4 fluids, and consider intubation to protect the airway. Once acute therapy has been initiated, the type and cause of angioedema should be determined. Copyright intubation is very risky in patients with angioedema and should only be performed by an expert. If there is no time for help, then preparation for the procedure must also include rescue devices and surgical airway equipment. Case-based specific treatment /5LL2. Scent ABCs intact and no airway compromise, proceed with histamine-mediated angioedema treatment. Poor response to repeated IM epinephrine administration, consider bradykinin-mediated angioedema treatment. A. Treatment of histamine-mediated angioedema and treatment of idiopathic angioedema. Scent standard therapy degree 4 antihistamines, example diphenhydramine copyright 4 glucocorticoids, example methylprednisolone equals positive response, continue standard treatment. 1 equals poor response, consider bradykinin-mediated angioedema treatment. Plus if the initial response to standard therapy is followed by progression to anaphylaxis 1, see treatment of anaphylaxis. Treatment of bradykinin-mediated angioedema, and treatment of hereditary angioedema/81I191. Administer one of the following targeted therapies: degree purified C1-INH concentrate, protein replacement, plasma-derived equals recombinant. Back collapse. AA. Find text outline. Trapere tur way with tuok vices et su up tut surgitaren way. Scent stop any potential triggers, remove potential exposures or offending medications, example ACE inhibitors. Copyright if airway compromise is suspected, stridor, wheezing, diminished air movement, or the patient is in shock, administer IM epinephrine immediately, start oxygen and 4 fluids, and consider intubation to protect the airway. Once acute therapy has been initiated, the type and cause of angioedema should be determined. Copyright intubation is very risky in patients with angioedema and should only be performed by an expert. If there is no time for help, then preparation for the procedure must also include rescue devices and surgical airway equipment. Case-based specific treatment LL2. Scent ABCs intact and no airway compromise, proceed with histamine-mediated angioedema treatment. Poor response to repeated IM epinephrine administration, consider bradykinin-mediated angioedema treatment. A. Treatment of histamine-mediated angioedema and treatment of idiopathic angioedema. Scent standard therapy copyright 4 antihistamines, example diphenhydramine copyright 4 glucocorticoids, example methylprednisolone equals positive response, continue standard treatment. Equals poor response, consider bradykinin-mediated angioedema treatment. Scent if the initial response to standard therapy is followed by progression to anaphylaxis 1, see treatment of anaphylaxis. Treatment of bradykinin-mediated angioedema, and treatment of hereditary angioedema 8-10L. Administer one of the following targeted therapies: copyright purified C1-INH concentrate, protein replacement, equals plasma-derived equals recombinant copyright kallikrein inhibitor, ecallantide O bradykinin B2 receptor antagonist, icatibant * second line or suspected ACE inhibitor induced etiology, fresh frozen plasma, FFP. Epinephrine, glucocorticoids, and antihistamines are usually not effective in acute hereditary angioedema attacks. If these have been given empirically, example for suspected anaphylaxis with airway compromise, and there is a poor response, then targeted therapy for bradykinin-mediated angioedema should be considered as the next step. Feedback. Prevention. General 2. Scent trigger avoidance, example allergens, offending medications, environmental factors, scent counseling on symptom recognition and instructions for when to return to the hospital * pre-specified treatment action plans specific. Plus hereditary angioedema, 8LL10L11 copyright consider one of the following options for pharmacological prophylaxis, equals plasma-derived C1-INH concentrate attenuated androgens, example danazol, O follow up with a hereditary angioedema specialist sent histamine-mediated angioedema 2 copyright epinephrine auto-injector for patients with anaphylaxis, prescription and directions for use copyright follow up with an allergist/immunologist for allergen immunotherapy as needed. O1SI Irade Hist. Tips and links. Sources. Last updated July 26, 2023. Back collapse fine text outline. Bradykinin prekallikrein HMWK synthesis. Bradykinin degradation factor XIL mutation T factor SLA5. Kallikrein. Hereditary or acquired OEL. T bradykinin. Rago copyright 1 ACE angioedema. Inactive metabolites. Bradykinin-mediated angioedema VV. Bradykinin-mediated angioedema is triggered by increased levels of the pro-inflammatory vasodilator bradykinin, which can build up via several different mechanisms. Top left, the rare hereditary angioedema, HA, type 3, normal levels and function of C1INH, can be caused by several different gene mutations. Illustrated here is a mutation resulting in increased factor 12 activity, which leads to increased bradykinin generation. Center left, in HA type, low levels of normal C1INH, HA type 2, normal or high levels of dysfunctional C1INHI, and acquired angioedema, acquired low levels of C1INH. The normal inhibitory function of C1INH on the kallikrein kinase system is reduced, resulting in increased bradykinin generation. Bottom left, in ACE inhibitor-induced angioedema, reduced bradykinin breakdown due to inhibition of ACE results in the buildup of bradykinin. Euroangioedema, 1/1. Bradykinin prekallikrein HMWK synthesis. Bradykinin degradation factor XIL mutation TT factor SLA5. Y kallikrein. Hereditary or acquired OA_C. YT bradykinin. AUS OJ-ACE angioedema. Inactive metabolites. Bradykinin-mediated angioedema VV. Top left, the rare hereditary angioedema, HA, type 3, normal levels and function of C1INH, can be caused by several different gene mutations. Illustrated here is a mutation resulting in increased factor 12 activity, which leads to increased bradykinin generation. Center left, in HA type, low levels of normal C1INH, HA type 2, normal or high levels of dysfunctional C1INHI, and acquired angioedema, acquired low levels of C1INH. The normal inhibitory function of C1INH on the kallikrein kinase system is reduced, resulting in increased bradykinin generation. Bottom left, in ACE inhibitor-induced angioedema, reduced bradykinin breakdown due to inhibition of ACE results in the buildup of bradykinin. C1INH, C1 inhibitor, ACE, angiotensin-converting enzyme, HMWK, high molecular weight kininogen, HA, hereditary angioedema. Hereditary angioedema. Facial edema, primarily affecting the eyelids, is visible on the patient's face. Source, copyright IMPP. Euroangioedema, 2/4. Angioedema. The severely swollen lower lip is most likely angioedema. Source, copyright IMPP. Angioedema VV. The upper and lower lip appear swollen. Source, angioedema of the lips, Dr. Bowden, by J. Heilman, Wikimedia Commons, licensed under CC by SA 3.0. Angioedema. The patient's right soft palate appears severely swollen. Source, Edeme Mucorosquinque by Group de Ogre, Wikimedia Commons, licensed under CC by SA 4.0. Features of angioedema: E. facial edema, E. dyspnea, stridor /. E. urticaria, plus. Stop potential triggers, assess ABCXYS. Signs of airway, signs of compromise, ABC intact, anaphylaxis. Add. YLT ED __once__ known hereditary _once__ give empiric IMG stable angioedema. Stable epinephrine secure airway early. If no improvement, J no yes with repeated doses. Treat as bradykinin-mediated angioedema. C1INH concentrate kallikrein inhibitor, bradykinin B2 receptor antagonist, fresh frozen plasma. Treat as histamine-mediated angioedema. E4 antihistamines, E4 glucocorticoids. No improvement. Temporary improvement OT followed by deterioration. Deterioration improvement. V. Continue as histamine, continue as bradykinin-mediated angioedema, treat as anaphylaxis-mediated angioedema. EIM epinephrine E supportive management. MD scab E follow anaphylaxis E early ICU consult if we protocol airway symptoms E identify the trigger E send plasma C4 levels. Management of angioedema VV. X gonorrhea. Gonorrhea is a sexually transmitted disease caused by the bacterium Neisseria gonorrhoeae that leads to genitourinary tract infections such as urethritis, cervicitis, pelvic inflammatory disease, PID, and epididymitis. The disease primarily affects individuals between 15 to 24 years of age and has an incubation period of 2 to 7 days. Gonorrhea is commonly asymptomatic, especially in women, which increases the chance of further spreading and complications. In symptomatic cases, typical clinical symptoms include purulent vaginal or urethral discharge, dysuria, and signs of epididymitis, example scrotal pain or PID, example pelvic pain, dyspareunia. Gonorrhea may also cause extragenitourinary manifestations, such as proctitis and pharyngitis. Rarely, disseminated disease may occur, which typically manifests with a triad of arthritis, pustular skin lesions, and tenosynovitis. Diagnostic tests include nucleic acid amplification testing, gram stains, and bacterial cultures from urine or swabs of the genitourinary tract as well as blood and synovial fluid in disseminated infection. Treatment consists of antibiotics, mainly ceftriaxone and doxycycline, but may require different approaches in more severe cases. Without treatment, prolonged infection may lead to complications, such as a hymenal and tubal synechia that lead to infertility in women. Yes. Epidemiology. Asterisk incidence. IL-2 copyright second most commonly reported infectious disease in the U.S. after chlamydia copyright 820,000 cases per year in the U.S., Cent age, primarily individuals between 15 to 24 years of age epidemiological data refers to the U.S., unless otherwise specified. OOE. Etiology. Pathogen O. Neisseria gonorrhoeae, and gonorrhoeae, gonococcus, O. gram-negative, intracellular, aerobic, diplococci scent transmission copyright sexual, oral, genital, or anal, O. Perinatally risk factors copyright sexual risk behavior, lack of barrier protection, multiple partners, O. Asplenia, complement deficiencies E. risk groups O. Men who have sex with men, MSM, O. Individuals with low socioeconomic status OCE, Cs. Clinical features. Overview. An asymptomatic course is common, particularly in women, and increases the risk of further spread and complications. Incubation time, 2 to 7 days urogenital manifestations. Urethritis O. Purulent urethral discharge, yellow-green, possibly blood-tinged, O. Dysuria O. Urinary frequency sent in male individuals copyright potentially epididymitis, one-sided scrotal pain and swelling copyright prostatitis copyright penile shaft edema without other signs of inflammation sent in female individuals copyright cervicitis equals purulent, yellow, malodorous cervical discharge equals cervical pain and bleeding on manipulation, example pelvic exam. Back collapse fine text outline. Copyright pelvic inflammatory disease, PID, equals fever, abdominal/pelvic pain, dyspareunia equals abnormal, intermenstrual bleeding equals Fitzhugh-Curtis syndrome, perihepatitis with RUQ pain, copyright Bartholinitis, pain, edema, and discharge of the labia copyright vulvovaginitis may occur but is rare. 1. Extragenital. M. Manifestations. Scent pharyngitis, sore throat, pharyngeal exudate, cervical lymphadenitis, scent gonococcal proctitis. 1. O. Purulent discharge, possible anorectal bleeding and pain. Rectal mucosa inflammation. Copyright rectal abscess, less common. Copyright constipation. Copyright tenesmus. Gonococcal conjunctivitis, may affect adults or neonates. Disseminated gonococcal infection, DGI. Epidemiology. 2% OFCA. Most common in individuals. Not to be confused with reactive arthritis. A. OOE. Diagnostics. Sent specimens for testing include copyright first catch urine O swab specimens of secretions, urine, urethra, endocervix, pharynx. Copyright for DGI, collect blood and synovial fluid, gained via arthrocentesis, sent test of choice, nucleic acid amplification testing, NAAT, O alternatives. Gonococcal gram stain gonococcal culture useful in determining antibiotic resistance results are not rapidly available, about 48 hours, sensitivity is lower than NAAT sent. Additionally, for arthritis, synovial fluid analysis may be clear, non-purulent, or cloudy, purulent, T leukocyte count, up to 50,000 cells/mm, especially segmented neutrophils. Gram stain sometimes positive. Back collapse. Find text. Outline. Asterisk screening for gonorrhea, USP recommendations, copyright annual NAAT screening of gonorrhea, typically also chlamydia. 4. Sexually active women 24 years with risk factors, example new or multiple sex partners, sex partner with an STI, evaluate for other STIs if positive, example chlamydia, T. pallidum, HIV. CDE, on SS-FOS. Treatment. Asterisk uncomplicated gonorrhea, 3.0 first-line treatment, single-dose ceftriaxone IM1. Copyright in case chlamydia co-infection has not been ruled out plus doxycycline PO twice a day for 7 days or, during pregnancy, plus single-dose azithromycin 1. Sent DGI. Copyright ceftriaxone for every 24 hours for 7 days, 1. Copyright in case chlamydia infection has not been ruled out, plus doxycycline PO twice a day for 7 days. Copyright drainage of purulent joint, S, in all patients, evaluate and treat the patient's sexual partners from the past 60 days. Copyright treat the patient's sexual partners with a single-dose ceftriaxone IM. Copyright provide expedited partner therapy if the timely evaluation of sexual partners is not feasible. 4. Sexual partners must be treated simultaneously to avoid reinfections. Your notes. Shared notes. Complications. Hymenal and tubal synechia, tubal motility disorders. Infertility. Gonococcal conjunctivitis, particularly in neonates, C. Naserial conjunctivitis, Sent DGI, sepsis with endocarditis, meningitis, osteomyelitis, or pneumonia. We list the most important complications. The selection is not exhaustive. FVAE. Related 1-minute telegram. Interested in the newest medical research, distilled down to just 1 minute? Sign up for the 1-minute telegram in tips and links below. Your note I shared not. Tips and links. Sources v. Feedback. Urogenital gonococcal infection. Pelvic inflammatory www/ disease. Copyright YS, Rs, 3 cervicides. Prostatitis O. Epididymitis. RFC degree dysuria. Copyright Co. AE scrotal pain, S swelling. A swollen, painful 5U Bartholin gland. Yellow-green discharge. Urogenital gonococcal infection VV. Copyright Boss. Gonorrhea, 2/8. Urethral discharge in gonococcal infection VV. Source, copyright IMPP. Cervical discharge in gonorrhea, speculum view, VV. The surface of the cervix is covered with yellowish-white, purulent discharge. The external os of the uterus is inflamed and red. These findings are consistent with gonorrhea. Source: ID #4087, CDC, Centers for Disease Control and Prevention, CDC, licensed under public domain. Vaginal discharge in gonococcal infection VV. Purulent discharge can be seen on this patient's vulva on external genital examination. Source: SOA Gonorrhea Female by SOA AIDS Amsterdam, Wikimedia Commons, licensed under CC by SA 3.0. Urogonorrhea, 5/8. Arthritis dermatitis syndrome. Fever. % skin degree lesions TD code JI / Migratory polyarthralgia. 3 Fe / AK / EIA equals U / S tenosynovitis. Arthritis dermatitis syndrome VV. Copyright Boss. Gonococcal arthritis VV. Right arm of a patient with Neisseria gonorrhoeae infection. The elbow joint appears swollen, indicating an underlying effusion. Above the affected joint and surrounding area, the skin is slightly reddened. A papular lesion is visible on the forearm. These findings are consistent with gonococcal arthritis with additional inflammation of the skin, arthritis dermatitis syndrome. Source: ID #6805, CDC/Emory, Centers for Disease Control and Prevention, licensed under public domain. Pustular skin lesion in disseminated gonococcal infection VV. Infectious pustule with accompanying erythema on the palmar side of index finger. Source: ID #11255, CDC, Centers for Disease Control and Prevention, CDC, licensed under public domain. Pustular skin lesion in disseminated gonococcal infection. A pustule with surrounding erythema is located on the left palm in the area of the fifth metacarpal bone. Source: copyright IMPP. Overlay Y. Neisseria gonorrhoeae VV. Photomicrograph of an urethral smear specimen, gram stain with Fuchs counter stain, high magnification. The smear shows an abundance of neutrophils recognizable by their typical segmented nuclei and accumulations of diplococci, in the intracellular, within neutrophils, examples indicated by white arrowheads in magnification, and extracellular space, examples indicated by black arrowheads. This microscopic finding is characteristic of acute gonorrhea caused by Neisseria gonorrhoeae. Diagnosis must be confirmed by cultural isolation and identification of the pathogens. Source: gonococcal urethritis Phil 4085 Lours, CDC/Joe Miller, Centers for Disease Control and Prevention, Atlanta, USA, licensed under public domain. Infant with gonococcal ophthalmic disease. The eyelids are swollen, with purulent exudate forming crusts around them. Below the crusts there may be a large reservoir of pus. Special care should be taken and safety goggles should be worn when examining the eyes. Source: ID #3766, CDC/J Pledger, Centers for Disease Control and Prevention, CDC, licensed under public domain.